We are live now.
Okay. So, a very good afternoon, friends in India, and a very good morning to Dr. Warren Hill. It is 2:30 a.m. In his place right now, and it is very kind of him to be, to allow himself to be present here for this meeting. This is actually a symposium in advances in biometry. This is what AIS has been doing every year. It's a virtual meeting and it's international collaboration. So Santosh wanted me to organize this program with a lot of international pioneers, those who have done a lot of work in this particular field. So I thought there cannot be anybody better than Dr. Warren Hill for this for this program. So I also would like to thank Dr. Nirupama Baliga, who will be introducing the speaker, then Dr. Ramesh Rajan, Dr. Sandhya Nair, and Dr. Twinkle Shah. All of them take keen interest in IOL power calculations and have been presenting papers and talks in the various sessions in the country. So over to you, Dr. Nirupama.
Thank you, Dr. Arup. It's indeed a great privilege to introduce Dr. Warren Hill. He's a renowned ophthalmologist and one of the foremost experts in intraocular lens power calculations today. And we are indeed honored to have him with us for this AIOS symposium on advances in biometry. He has graduated from the University of Arizona and completed his ophthalmology training at University of Rochester in New York. He's certified by the American Board of Ophthalmology, the American College of Eye Surgeons, the National Board of Physicians and Surgeons, and also the World College of Refractive Surgery and Visual Sciences. He has been in private practice in Mesa, Arizona for over 4 decades, and he has devoted his career for challenging anterior segment surgeries and also the mathematics of IOL power calculations. His website, drhill.com, is one of the most popular IOL power calculation resources, which has benefited several ophthalmologists in calculating the most accurate IOL power for their patients undergoing cataract surgery. He is a visiting professor for grand rounds at numerous institutions and an adjunct professor of ophthalmology and visual sciences at Case Western Reserve University. He has delivered over 36 eponymous lectureships and presented 990 clinical papers, along with performing live surgeries at national and international ophthalmic meetings. He is a member of the International Intraocular Implant Club, and he has delivered the ASCRS Innovators Lecture, the Lindstrom Medal Lecture, and the AO's Charles Kellman Lecture, which are all prestigious awards. He has been the recipient of the Rayner Medal in Ophthalmology from the UK and Ireland Society of Cataract and Refractive Surgeons and the Presidential Recognition Award from the International Society of Refractive Surgery. And apart from ophthalmology, he's very passionate about flying his military airplane in air shows and is licensed as a multi-engine commercial pilot. So we are really looking forward to his talks today. And he will be giving 3 talks. One is on the artificial intelligence, the future in IOL power calculations, and the other on blended vision, and finally on the recent advances in the technologies for IOL power calculation. Over to you, Dr. Warren.
Okay, well, thank you. Thank you very much. You're able to hear me okay? Let's see if we can share the screen here and make sure that all this works here. Zoom sometimes has a mind of its own here. Okay, and can you confirm to me that you're able to see this okay?
Yes.
Okay, good. Okay, well, it's a great pleasure to be here with all of you today, and we're going to talk about something that's a little mysterious to most ophthalmologists, and that's artificial intelligence. And I'm here to tell you that this is going to drive a lot of what it is that we do in many aspects of ophthalmology.
You have to come to
only
the full
IOL power
screen view,
calculation.
Oren. Full screen view. We're not seeing getting the full screen view.
Okay, let's take a look here. Am I where? Okay, I'm sharing the screen right now. What are you seeing?
Dr. Warren, you can unshare the screen once and then close the keynote and then start the keynote again, because it's showing the presenter view right now. So then we can probably modify that.
Okay, let me figure out how we're going to do this here. This is a little problem we have with. Okay,
When
we're
you
going to
tested it,
unshare
it
the
was
screen.
perfectly fine. So I think it should be okay.
Oh, okay. I think I know what we need to do here.
Yes.
Okay, let's give this one more try, and I apologize for the vagaries of Zoom. Is that better now?
It is still
Is that
showing
showing?
the presenter view.
Okay.
We can proceed with the present view. It's not a.
Hold on just a minute here. Let's see if we can. According to this, we're doing it correctly. Hang on. Does that
Yes, it's
show it
perfect
now?
now. Yes, yes.
Okay, good. Okay. Well, anyhow, let's just dive right in here. And as I mentioned, artificial intelligence is something that's not only going to be doing IOL power calculations, but almost every aspect of ophthalmology. And these are my industry relationships. The only thing that has any relevance here is that Hochstreit in Switzerland sponsored some of the original research that we began doing this almost 15 years ago. And they've been vigorously supporting and at times funding the research for our project here. So as anterior segment surgeons, how can we be the most effective? Well, we want to avoid complications. And when we think about complications, these are the things we think about. We lay awake at night after something like this happened in the operating room, or perhaps somebody has a small pupil and a history of pseudoexfoliation, or they have a history of uveitis. And these are all things that bother us, but actually these are relatively uncommon. And the most common complication is an unanticipated refractive outcome. And I'll show you how common that is. So that's really the elephant in the room when we go into the operating theater is, do we have the power right? And all of us can remember the time when we were maybe operating on a celebrity or perhaps our mother-in-law or somebody where it absolutely positively had to be correct. We worry about this. So what are our accuracy standards, and should what's most common be good enough for us? And here are 6 studies that may be known to you. And you can see for the 1 diopter outcome, we're doing really well. For the half diopter outcome, we still have a little bit of a ways to go. And you might think that the Tesla study in the Journal of Cataract and Refractive Surgery was aspirational, but actually I know these people. And this is what's possible with when all the measurements are done correctly and we're using the very best calculation methods. Now, over the years, Wolfgang Haggis and I did the ULib site together, and I've looked at over 300,000 surgeries. And these are the numbers that I'm seeing at least most commonly. It used to be about 78%. It's about 80% right now for the average ophthalmologist. And so this 20% gap is really the gap that we need to close. And for those of you that track your outcomes, these numbers should be pretty familiar. So for the average ophthalmologist who uses optical biometry and modern formulas, this 80% is pretty common. 84% would be upper tier, and 90% would be for people that perhaps are a little OCD and really spend a lot of time. So this is what 80% looks like. And if we're putting in multifocal lenses or toric IOLs, I think we need to get rid of as many of these black dots as we possibly can. So why are refractive outcomes not significantly better? We have amazing equipment. We have OCT for our measurements. We have very sophisticated computers. Well, let's just go back to the beginning. This is the Vergence formula of Carl Friedrich Gauss from the first half of the 19th century. And remember when we were studying as residents, object vergence plus lens vergence equals image vergence. But fast forward to 2026, and this is the mathematical backbone for most theoretical formulas. And you can see we're still using the Gauss Vergence formula. And of course, we have some indices of refraction. We've included the effective lens position, keratometry, the axial length, but it's still the Vergence formula. And the other thing to remember is the power of an intraocular lens within the eye is relative and not absolute. And what that means is if you put a 21 diopter lens inside the eye, it only acts as a 21 diopter lens a very specific distance from the principal plane of the cornea. You move that same lens posterior 0.5 millimeters, That's a 1 diopter error at the plane of the capsular bag. And try holding your fingers 0.5 millimeters apart, and you can see how sensitive it is. So really the main difference between modern theoretical formulas is how they estimate the effective lens position. The difference between different practices, different surgeons, is how they do the measurements. But the main difference between theoretical formulas is the effective lens position. And that can only be estimated. It can't be calculated. Now, you would think, well, our dear friend Graham Barrett, he has a theoretical formula. How is it that he does such a very good job? And if Graham Barrett was sitting here next to me, he would agree that what he has is not really a formula, it's a calculation method. And he's put decades of time into this. And so it's not really a formula, it's about 3,000 lines of code that allows him to do a good job. And it's kind of a hybrid of a lot of different things. And we're all grateful to Graham for the wonderful work that he's done. So is there a way to avoid the limitation of the effective lens position? And we can do that by looking for methods that do not rely on the effective lens position. And in the words of Steve Jobs, we need to think differently. So if I would ask you to allow me to make the case for developing and using artificial intelligence for IOL power calculations. Now, what are the advantages of that? Well, first of all, it doesn't limit solutions to possibilities that we already understand. And it makes the best of what's available. And actually, we can bypass some of the limitations of the physical model. And we can identify and integrate the influence of relationships that are previously unknown, like what is the relationship between the distance of the scleral spur to scleral spur as opposed to lens thickness? Nobody knows. We can figure this out. And it's well suited to real world problems where ideal models remain elusive. And IOL power calculations, of course, is the poster child for that. Now, also with artificial intelligence, we can have insights into calculation accuracy before surgery. And I'm going to show you a tool that we use for this that allows us to have a very meaningful conversation with the patient prior to actually doing the surgery. We have some challenges. One of them is getting really large numbers of cases with highly accurate results. And of course, the high axial height rope is still a conundrum for a lot of us. We've all had a patient where the measurements were perfect, the surgery was magnificent, and the patient ended up minus 150, and we had no idea. And we're working on that right now. So IOL power calculation by artificial intelligence works by pattern recognition, and I'm going to show you a few things as to how this works. So here's some patterns that we may recognize, and of course Alfred Hitchcock, Winston Churchill, Elvis Presley, Xi Jinping, Albert Einstein. These are all silhouettes, and think about how little information there is here. It's just a black line against a white background, but the way our brain works, we can actually come up with what's going on with each one of these patterns. And pattern recognition is the key to artificial intelligence. Well, why not do this with IOL power calculations? And we can look at this pattern of a certain axial length, central corneal thickness, average corneal power, gender, proposed spherical equivalent. And that pattern gives us a 21 diopter lens. And this is the basis for the majority of IOL power calculation outcomes by artificial intelligence. And here would be another example where this pattern gives us a 12 diopter IOL that we would implant. And because artificial intelligence is not limited in the same way as a Gaussian formula, we can do this at a very, very high level and in a way that a basic linear formula could not take care of. So let me just show you an example of how this works. Inside this square, we have 1,000 vectors. Vector just means it's something with 2 coordinates. And they all look random, but actually these crosses were put in using something called a Manhattan distance generator. And the Manhattan distance between 2 points is as though we were driving a taxi cab between one part of New York City and another. And you can't drive the taxi cab through the buildings. you have to go around it. So it's kind of like a grid-like pattern. So that's the Manhattan distance. This would be the Euclidean distance, whereas the bird flies, over top of the building. And I'm going to ask a very simple neural network to tell us the underlying pattern of all these seemingly random vectors. And we're going to give it 5,000 tries. And with today's scary fast computers, that's like, 0.1 seconds. It's not much. So here we are at 40 cycles, 120 cycles, 500 cycles. And by 5,000 cycles, we've actually been able to find the underlying pattern of all these seemingly random vectors. And the power of this technology is really quite stunning. And this is just with a very simple neural network. When we get into deep learning and transfer learning, we can up the sophistication dramatically. So going back to the beginning, my friend Jerry Clark in Wisconsin thought he would try and do IOL power calculations and compare using artificial intelligence and compare that to the Holiday 1 formula. And he trained a neural network with 200 consecutive cases and developed a lens constant for the Holiday 1 formula. And what he found was that his half diopter accuracy using artificial intelligence was dramatically better than with the Holiday 1 formula. Now you would say, well, the half diopter outcome of 33%, that's not very good. But remember, this is in 1997. We had manual keratometry, we had immersion or applanation biometry. So it was a very different time in terms of available technology. And I have to admit that we in ophthalmology, we miss this. And Jerry was doing some really important work, but there was some other stuff we were paying attention to. Remember back in 1997, we were trying to figure out foldable lenses and how to do phacoemulsification correctly and how to correct the incision. So this was kind of low on the priority compared to the technology we were struggling with. So the limitations of his study was that we didn't really have the kind of computing power we have today. It was a really small data set. And this type of work at the time was really challenging to set up. And there's also a tendency to overfit the data, which means that the outcomes look just like the database, and we don't want anything like that. But Jerry gets really a lot of credit for this because that was an idea many years ahead of its time. Now, this is what's called in mathematics, is called an optimized response surface model, where we look at what we would like to see, which is a flat plane, and compared to what we get, which is kind of this lumpy, bumpy configuration. So this wasn't a very good outcome, but there were a lot of limitations. And if you look at our first try with very simple neural network and correct computing power, this was with 900 cases. This is our very first attempt at this. So you can see that we knew instantly we were on the right track. So what are some of the current options for real-world artificial intelligence calculations? Well, we can do a basic neural network, which is how we started out. And the advantage of this is that we can just use off-the-shelf software without special programming. But it doesn't really perform well with large-scale, multi-part interactive problems. So this is basically what it looks like. We have our organized input of data here. It's axial length, central corneal power, anterior chamber depth, and what it is we're looking to calculate. And then we have a forward propagation phase where we come up with the answer, but then we can train the neural network by adjusting a series of hidden layers that contain weights and biases, and go through this multiple times until the accuracy doesn't get any better. So basically, we're training a neural network to kind of think and come up with the right answer. There are a number of different ways to do this, and most of them are pretty simplistic compared to what we're doing right now. But at least it was a start, and this was the very first method that we used when we came up with version 1 of the method that I've put together. Now, next is machine learning, and that's a subset of artificial intelligence that trains algorithms to learn from examples and direct experience and instruction. And it's kind of the intersection of computer learning and statistics. Again, off-the-shelf methods can be used to do this, and this is basically what's done by the majority of artificial intelligence methods that you've heard about recently, and they're hybrids. Part of it is machine learning and part of it is Gaussian optics. It does require some human intervention, and it contains some internal bias, which is difficult to identify. And machine learning methods may be overwhelmed by very large data sets and show accuracy limitations. So basically, we have our different data sets collected from different sites. We figure out what it is we're looking to do. We come up with a basic method. It's a Darwinian selection, kind of survival of the fittest. And we can do tens of thousands of different iterations until we get the right accuracy. We come up with our model, we optimize our algorithms, and then we do our predictions, and then we optimize things. And then that gives us our finalized predictions. And these are the current machine learning IOL power calculation hybrid methods, and many of these might seem very familiar to you. There are a number of different types, and supervised learning is what most people are using right now. But you may be familiar with speech recognition, credit scoring, stock market predictions. These are all machine learning methods. But it's really just a way of combining computer learning with statistics for algorithm generation. Now let's get into what I'm doing right now and where I think a lot of this is headed, and that's deep learning. And deep learning is a very large neural network with a lot of hidden layers that mimics the human brain. So think of it like a neural network on steroids. It can be used for very high level pattern recognition for very large data sets. And it does have some limitations, but we're figuring out how to get past these. So one of the very first exercises for deep learning was, can we identify a dog, have a picture of a dog? And the problem with dogs are they have pointy noses and ears and tails and spots, and it looks like other things. It could be a cat or it could be something else. So we put in enough information and we do our forward calculation, is this a dog? Is this not a dog? And then we can train it by these back propagation loops until we get the right answer. And we find out that, yes, this is a dog. This may seem very, very simple because the human brain is very good at pattern recognition. But in mathematics, this is kind of difficult. Now we're very sophisticated. But in the beginning, this was a lot to consider. There are a lot of different ways to do deep learning, and the two that you might be familiar with, if you've ever done this yourself, you've probably done a convolutional neural network. And say if you go through Terminal 5 at London Heathrow, I guess if they're taking your picture, they want to identify you, that's using a convolutional neural network. And if you're on their internet, you use things like ChatGPT. That's called a transformer neural network. And it's very clever how this works. Again, these are statistical exercises. The original ChatGPT 3.5 had 175 billion parameters and 96 layers. The way in which it works is it kind of fills in the blanks. So let's say you're writing a sentence and you're asking ChatGPT to finish the sentence for you. The sentence might be, on a clear day, the sky is, and then it goes out and looks at a bunch of examples and comes up with a 98% chance that the next word is blue. And that's why it comes up. That's how it comes up with this. So again, these are statistical exercises. And that's why it can be language independent, because it doesn't really depend on the language. It depends on what it is that it sees. ChatGPT 4 has 1.76 trillion parameters. ChatGPT 5 is what we're using right now, and that's 17 trillion parameters. And ChatGPT 6 will have more than 20 trillion parameters. Remember, there are 2 trillion known galaxies in the known universe. This is pretty amazing. This may be the first time that we're going to have artificial generalized intelligence. And artificial generalized intelligence is a direct mimicking of the human brain at a level that's really uncanny. So in early 2027, we're going to probably have a form of artificial generalized intelligence. And I think this is going to be transformative. Now, what we're working on right now is something called transfer learning, and this is very exciting because this allows us to do very good things with limited amounts of data. So it's a supervised learning where one model is trained for a task to enhance a smaller model for performing a similar task. And I'll show you how that works with lens power calculations. So knowledge transfer improves specificity and accuracy. And this is really uniquely suited to lens power calculations. And this is the work that myself and Jonas Hanley, a PhD mathematician in Zurich, Switzerland, this is what we've been working on. So let's say you were, during childhood, you had a bicycle and you learned how to ride a bike, and then later on you got a motorcycle. The skills learned in riding a bicycle can be transferred to riding a motorcycle. That's a form of transfer learning. So new information is incorporated to refine accuracy. There are a number of different types, and the one that we're most interested in is called transductive, where the large model that we train very specifically and the target model that has less data but is similar, they're very close to each other. And that allows us to have a base calculation for a certain type of IOL and then refine that for different model IOLs. And here's an example of how this works. So let's say we want to identify different cat species. And we all know the cats have pointy ears, whiskers, maybe a pointy nose, they have a tail, they have coloration. And then they have different other characteristics. And there are 41 different species of cats, not types of cats, but species. And if we're looking at pictures of cats and we want to tell one cat from another, we can have our source model refined by the models, by these individual smaller models. And we can assign categories, we can extract features, we can add features, and then we can train the artificial intelligence model so that these smaller models now have enhanced performance, and we've repurposed the larger models. So let's say we have a cat like this, and we say, gee, what is that? Well, that's the African lynx called the caracal. And we have smaller models that have repurposed the larger model. So how does this work for lens power calculation? So let's say our baseline pre-trained model is the SN60WF, one of the most widely implanted lenses in the world. And we may have 35,000 of these. So we have a really good model for this particular lens. And then how many different types of other lenses are there available? Well, there's hundreds and hundreds of other types, and they're all slightly different, but they're similar. So this is, these would be single piece acrylic lenses. And we can optimize each of these targets by extracting features that are unique to each of these lenses, like the haptic diameter, the haptic stiffness, the interaction with the caps or bag, the radius of curvature for the anterior and posterior surfaces, the shape factor, index of refraction, etc. And we can refine the outcomes for these smaller data sets, because we can't have 35,000 of each one of these. And what we get is enhanced accuracy. So we've combined the power of pattern recognition with refinement for individual IOLs. And for example, the SN60WF and the PC-BU, they're similar. They're single piece acrylic lenses, but they have a lot of differences. One has a carrier, it has stiffer haptics, it responds differently to the capsular bag, and all of these are things that determine the refractive outcome. Now, this is just for single piece acrylic lenses, but what about three-piece lenses, plate haptic lenses, or an anterior chamber lens? We're going to have to come up with these large source models for each of these individually. Now, remember, theoretical formulas have lens constants, and a lens constant simply shifts the power prediction curve up or down. That's all a lens constant does. The advantage of transfer learning is that each feature of a lens that contributes to predicting accuracy is identified, and these unique influences are applied to the calculated IOL power. So this is IOL power calculation on a completely different level. Now let's just talk a little bit about quantum computing, because this is in the future, but this is going to completely transform our ability to solve complex problems. And we all know that quantum computing can do calculations at a level previously never even imagined. We use bits for computers. These use qubits, and just a simple 30-qubit quantum computer can perform 10 trillion floating point operations per second, 5 times the estimated number of galaxies in the observable universe. What this does is it removes computational complexity as a limiting factor. And the convergence of quantum computing and artificial intelligence is going to enhance the accuracy of IOL power prediction to previously unattainable levels. And this also opens up the possibility for original solutions to seemingly unsolvable problems. And the interesting thing about quantum computing is it's not about having a faster computer. It's about a complete reimagination of the computational process. We won't go into actually how this works. We won't go into, superimposition, where just an impossibly large number of calculations are carried out simultaneously. But this really has the potential to profoundly impact the investigational process at every single level. And I hope we'll be able to take advantage of that for lens power calculations. So currently, even with what we have right now, artificial intelligence has the highest percentage of patients with a half diopter accuracy. And I hope we're going to be able to improve on this. So we can anticipate a new level of accuracy, and this is going to be constantly improving. So new calculation methods allows for the use of new tools. And I previously mentioned that we can figure out how the patient's going to do after surgery, before surgery. And I'll share with you one of the tools that we use. We've borrowed this from engineering. And this is called boundary modeling. And if we plot central corneal power against axial length, we come up with a plot like this, which is very, very characteristic for the human eye. We can draw a boundary here where we have 90% accuracy for the outcomes. And we can identify those data points that were involved in cases where the accuracy was less than 90%. And this is what we call an out of bounds calculation. And we can flag the user and say, oh, for Mrs. Smith's lens power calculation, one of the data points was outside. So we can't guarantee a 90% chance of being within half a diopter. That's important for the conversation prior to surgery. A data point that falls, say, in this area, within the 90% boundary for all the measurements has that 90% accuracy. We can tell before surgery how the patient may do. And the conversation is basically, Mrs. Jones, God has given you an unusual eye. We don't have the same kind of accuracy, but we're going to do our best. And if you tell the patient beforehand, it's not your fault. If they find out afterwards, they may blame you. So the use of boundary models, it just makes the conversation more accurate. An out-of-bounds calculation is still valid. It's just more difficult to obtain the predicted accuracy. And now the boundary models that we're using for artificial intelligence are at a 90% level. So here are two cases. One is an inbounds calculation. The other is an out-of-bounds calculation. The only difference between these two is that one or more of the data points for the case on the right fell outside the boundary model, whereas for the case on the left, all the data points remained inside the boundary models. And this is what the boundary models look like. For 4 variables, there's 6 boundary models. And if we took pretty much an incredibly unusual eye, extreme axial myope, flat Ks, very deep anterior chamber, for version 3 of what's currently available with the Hill RVF method, you can see that every single one of these data points are within our boundary model. So we have a 90% accuracy, even for an unusual eye like this. So where are we going with this? Well, I think the future of lens power calculation is going to be driven by evolving artificial intelligence methods. For the short term, I think we're going to see continuously improving accuracy. For the intermediate term, 5 to 10 years, we're going to be able to identify and incorporate new ocular relationships. And for the long term, I hope that there's going to be routine anonymous data sharing amongst ophthalmologists and also within industry. And I think what we're doing right now is we're experiencing a convergence of technologies. And these are the ones that are going to be left standing maybe in 5 years from now. I think ray tracing is not going to work because it depends on the effective lens position. Intraoperative aberrometry still has some use for the toric IOLs, but I think artificial intelligence and various hybrids are going to be what we're seeing. And the method that's the most flexible and sensitive is going to give us the best results. And I think artificial intelligence fulfills that. So right now, the average ophthalmologist is getting about 80%. And again, for those of you who track your outcomes, these are the numbers that you're seeing. 84% would be kind of the next tier up with theoretical formulas. This is achievable today with very careful measurements. It's okay. And then this is what we're hoping for with improved measurement accuracy. So this is, I think this is 80%. This is 90%. And then this is where I hope we can get as we go to transfer learning and some other improved measurement technologies. And eventually that elephant in the room will begin to fade away and we can concentrate on other things. Thank you.
Thanks a lot, Warren. So it was quite a great deal of artificial intelligence that we listened to. And my one question to you is, do you think, you just mentioned, do you think we'll ever reach a stage where we can calculate IOL with 100% accuracy for all the patients?
Yeah, this is a very insightful question. This is one of the best questions I could get. And the answer is yes, but not at the present. And what we need, the mathematics of this has gotten really good. And the old tired joke is you can make an artificial intelligence model for a bologna sandwich if you just have the right metrics. What we need is better measurement technology. And I think we all would agree that the Ks are still the weakest part of the Ks and the refraction. Those are the two weakest parts. For those of us that develop lens power calculation methods, these are the two areas that drive us crazy because they lack accuracy. I think if we can move away from reflective keratometry to something that's a little bit better, and then have automated refraction that's correct, we could take it up another notch. But to answer your question specifically, it isn't until we get to improved measurement technology that we're going to be able to improve things. So think back to the end of the 1990s. We had immersion, A-scan, and manual keratometry. What happened the moment we switched to optical biometry? Do you ever question the axial length when it's 24 millimeters? No, it's perfect. Well, we need that kind of accuracy for the Ks and that kind of accuracy for the refraction in order to see that quantum leap in accuracy that we had when we went from ultrasound to optical biometry. That's what I'm hoping for. Unfortunately, OCT is not the answer. Ks by OCT have really been a disappointment for a lot of us.
Ramesh, anything you want? Any other leads?
Yes, sir.
Yeah, Dr. Twinkle.
Yeah. Super talk by Dr. Varun here. My question is the transfer learning process, which is the new evolving one. Do you feel that it will incorporate the activity of the physics involvement in the deep learning?
I'm not sure I understood the question. Say once again, please.
The transfer learning process, which we are evolving, the limitation at present in the deep learning is the limitation of the physics involvement. Will it be take over?
Well, deep learning is nothing more than a form of pattern recognition at a very high level. That's really all it is. And if we give deep learning the right metrics, it can come up with the right answer. And the advantage of deep learning is it's not linear, it's highly nonlinear, and it can take place in multiple dimensions. remember, a lot of these deep learning models have 120 hidden layers and maybe use 5, 6, 7, 8 activation functions. So once we get the metrics correct, then we're going to take that next leap. And my father was a very famous doctor. In fact, I really didn't want to go into medical school because everybody said, "Oh yeah, you're Harry Hill's son." But what he used to tell me was that that 10 years from now, what we cannot live without, right now we don't even know exists. And I think the things that are going to be completely transformative for ophthalmology, right now we don't even know about. Like 10 years ago, were you thinking about quantum computing? Of course not. None of us were. 10 years ago, were you thinking about artificial intelligence? No, it's just that crazy guy Hill was doing that. And I think the future is unknown, and the future is going to unfold for us. And there's going to be a technology that shows up that maybe make all of this irrelevant. And isn't that the fun part about ophthalmology? I was a resident in 1982, the year that the IOL was approved by the FDA in the United States. I didn't even see my first extracapsular extraction until I was a chief resident. I mean, think of all the ways in which technology has changed since the 1980s. Think of how things are going to change in the next 40 years. So to answer your question specifically, well, the question was put previously, do you think we can get 100% accuracy? I think that's going to happen. But right now, we don't know how. And probably one of you is going to come up with the technology that's going to make that possible. And I hope I live long enough for that.
Ramesh?
Can I ask a question?
Yeah.
Please.
Amazing talk, Dr. Hill. How significant is the gender difference in IOL power calculation? Because that is included in Hill RBF formula. I just want
It is, yeah. Yeah. So once we got up to about 35,000 cases, we had enough data to be able to tease out some information. And it's about 1/8 of a diopter. Now, you would say, well, why does that even matter? Well, let's say you're putting in a multifocal lens, and the choice is between a 21 and a 20 diopter lens. And it's, we've all had those where it's been right on the edge, we're not sure what to do. That might make us choose. But 1/8 of a diopter here, and 1/8 of a diopter here, and 1/8 of a diopter there, that may add up to something meaningful. So the more of these that we can come up with, the better it is. And so male and female, exact same measurements, everything's identical. We're seeing 1/8 of a diopter difference, and it's real. It's real. And again, Dr. Henley, the PhD mathematician I worked with, was able to prove this. So it is real. And to his credit, Jack Holliday in 1998 suggested this as well. And so he was actually the first person to come up with it. And then all we did was just prove what Jack Holliday said was true. Jack is my hero, one of my heroes.
Without any biometry parameter difference.
That's correct. Male and female, it's about 1/8 diopter difference. It's not much, but you take a whole bunch of them together, and it may actually turn out. So we may find out. One thing we're working with right now is the scleral spur measurement. We now have some technology. The iStar from Hogstrite measures scleral spur to scleral spur distance. And we're looking at that in relationship to a bunch of other parameters like lens thickness or axial length. And it may turn out that that's a relationship that may give us another 1/8 of a diopter. Now we're at 1/4. Oh, now things are starting to matter. So we really don't know where this is going to take us, and we don't know what's important, but we just have to keep our eyes open and be honest. And honesty is the best thing. So here's just a funny aside. So I'm an air show pilot. I fly a military airplane 36 inches from another airplane in formation demonstrations. So we do close formation demonstrations. And people say, why do you do this? Well, my answer is, it has all the right things that matter in life.
I'm not able to hear you. Can you hear?
Yeah,
We can't hear
the numbers right or not.
We are not able to hear
And
you,
it does
Warren.
require your best effort. So,
Warren, sorry, the
can you hear me now?
last 30 seconds, we could not hear you clearly about why you
Okay, well, let me just go over that
chosen to
quickly.
fly close formation.
Okay, well, it's inherently honest. So I'm flying 36 inches from another airplane, and if you make a mistake, you're going to have a really bad day. And it requires your best effort. And lens power calculations is exactly the same. It's inherently honest. You either get it right, and if you don't, everybody knows. And it always requires your best effort. There's no making stuff up. There's no excuses. And that's what I like about lens power calculations. There's always a way to test if you're doing it correctly, because if you aren't, everybody knows. So
Warren,
there's no making stuff up.
A question for you. So,
Sure, please.
how do these lens power calculation treat different races, an Asian Indian as opposed to a Caucasian?
This is the other last 10 years of my life. You guys are giving me all the best questions. This is wonderful. Okay, so I've looked at, because I have these huge databases, I've looked at the Indian population, not at Dravidians, but the regular ethnic Indian population, Northern Indians. And I've looked at American blacks, and I've looked at Asians. And what I found was that the Han Chinese eye, not just the Asian eye, but the Han Chinese eye, which is mostly Northern China, is different than the European Caucasian eye. And it's different in several ways. One is the anterior chamber is more shallow. And what's the most common form of glaucoma in China? Of course, it's angle closure, isn't it? And then also it has a larger vitreous cavity. The problem I'm having right now is I've got a number of study centers in mainland China that have been feeding me information. The Chinese government has closed trans-border data sharing, the Central Communist Party. So all that's been shut down. I have 4 universities that are giving me some data, but they've been told not to do it. But I think the next artificial intelligence model that we're going to develop is for the Han Chinese eye. There are 1.2, 1.3 billion Han Chinese. And if we can show the difference, I think that'll be meaningful. The Chinese hate our formulas. Oh, they hate haggis. It doesn't work at all. The Chinese love SRK2 and SRKT. These are formulas not even from this century, but they like those. So what it tells us is that formulas developed against European Caucasian eyes are not necessarily really good for the Han Chinese eye. For the Indian population, it's about the same. I haven't seen any difference. But for the Han Chinese eye, it is different. So excellent, very insightful question. Very good. All right, should we get into?
I think we'll move
now
on to
this
the
is
next topic.
Yeah, so I hope I'm not wearing you guys out here. But
Well, we are enjoying.
Not at all, Warren, please.
It's
I'm having
privilege.
fun. Yeah, okay. So let me share my screen again. And let's see if we got this right. Here we go. Okay, and you're going to tell me if I'm doing this correctly here. Is that showing up correctly?
No, it's not showing up, Warren.
Okay, let's see if we can figure this out here. This should be okay. Okay, oh, let me share. Okay. Is that showing up now?
Yeah.
Okay, good. Okay, so as we talked about before, the problem with ophthalmology is it's full of ophthalmologists. And if you want to solve a problem in physics, optics, neurophysiology, might not want to ask ophthalmologists. You might want to ask mathematicians or physicists or neuroophthalmologists. And one of the journeys that I've been on for the last few years is understanding the human visual system. And there are a lot of surprises. And as ophthalmologists, we're really good at diagnosing diseases, and we're really good at the mechanics of surgery. But our education doesn't always include a lot of information about how the human visual system works. And I've worked with some neurophysiologists, and I've come up with some ideas that I've been so impressed with. I had this done for myself and also for my wife. The senior partners in our group have had this done for themselves, and we've stopped using multifocal lenses in favor of this. And we're calling it blended vision, what Graham Barrett calls modest monovision, basically the same thing. I'm going to show you how this works and the thinking behind it. And I have no financial interest in any of the things we're going to talk about. So let's just talk about some philosophical concepts. So for a long time, we've been concentrating on the technical aspects of what we do: biometry, keratometry, topographers, calculation strategies, and we've been focusing on what we are doing. Now, with refractive outcomes being highly predictable, we can now turn our attention to how we can effectively benefit patients by understanding the human visual system and understand really how we're doing this. And cataract surgery is capable of so much more than just achieving a planned refractive outcome. IOL-based surgery can also modify the human visual system. And the deeper question here is, why are we doing this? And I'm going to share with you some things that I've learned over the last few years that have had a profound effect on how we practice in our particular clinic. So we don't really need another diffractive multifocal IOL. And I think many of us would agree that every time a new multifocal IOL comes out, there's a wave of enthusiasm, and it's sometimes followed by disappointment. What we need to do is begin thinking differently about how we are doing cataract surgery. So the goals, I think, for all of us is we want excellent, seamless, uncorrected binocular distance vision, intermediate vision, and reading vision. And we also want spectacle independence for everything but really, close work, like 6 inches away, and functional vision that's really similar to the adult phakic eye. And of course, we're the sworn enemies of the light-associated dysphotopsia, rings, halos, glares, and streaks. And we don't want any compromise in contrast sensitivity, and with the possibility of enhancing contrast sensitivity. And the first thing to remember about the human visual system is it's a contrast sensitivity detection system. That's what the human visual system is. So anything that we do that gets in the way of contrast sensitivity is going to be a problem. So let's take a look at hard monovision, which is like -2 or -250 in the near eye, in blended vision. So for blended vision, we usually go for about -1 in the near eye. And compared to hard monovision, intermediate vision is excellent. Reading vision is surprisingly good, and stereo acuity is preserved. If you're -250 in one eye, you've lost binocularity. And binocular vision, the preservation of binocular vision, is really one of the keys to making cataract surgery work. And I'm going to show you a couple things about how this works. So this is what I'm interested in: -1 for the near eye, good intermediate vision, useful reading vision, and preserved stereo acuity. And I know what you're thinking right now. Well, how can you have reading vision if the near eye is -1? And this is where understanding the human visual system comes into play. And I'll show you some examples. Okay. So the first fundamental concept is vision occurs in our brains, not in our eyes. This isn't a piece of film in a camera. And so who's most likely to be able to function with blended vision? Well, we want somebody who's neuroplastic. And what that means is they have the ability to retrain neural pathways in response to an altered sensory input. This is a change at the level of the axon. And all of us may know somebody who, say, has had an injury. Maybe they lost their vision. And one of the things that people are often told is, well, I lost my vision, but my sense of hearing is so much better now, or I'm more aware of sense of taste or smell. This is neuroplasticity. And we can do this with the human visual system as well. We know that this process is very intense during childhood, up to the first 7 years. And neuroplasticity is not necessarily something that's age limited, and that's a common misconception that it is. And a significant change in neural input may also lead to an increase in neuroplasticity. And I think we can leverage this to enhance visual function by formulating a specific plan for what we do with intraocular lenses. So who's most likely to be neuroplastic? Well, those who enjoy working with puzzles, people who are consistently exercising their minds, playing games, solving problems, and are adaptable to different situations. People who continue to have a really good memory, people who are happy with life and a positive personality and kind of maintain a low stress lifestyle. And also individuals who do regular aerobic exercise. Now, if you look at this list and you think about, okay, I'm going to see if Mrs. Jones would like a multifocal lens, there's a lot of similarities here. People who have a negative personality, people with poor memories, people that can't solve problems. Often these people don't do well with multifocal lenses. And what we're doing really is screening for neuroplasticity. We just didn't notice it. And people need to have good binocular vision. 40 seconds might be a lot, but 60 seconds of arc stereo acuity, if it's possible to test for that, is another very, very good sign of a neuroplastic patient. We want to exclude anything that's going to get in the way, of course, macular disease, glaucoma, keratoconus, amblyopia. And then who are the reduced potential patients for neuroplasticity? Negative controlling personalities, very detail-oriented, people who have a stressful lifestyle, sometimes self-opposed. Again, these are people that would not do well with the multifocal lens. So we've been screening for these people all along. Opioid and alcohol abusers, really any substance abuse, may exhibit neurotransmitter inhibition, and I'm going to show in a minute why this matters. And then people with chronic depression and various forms of mental illness. Sometimes medication may be helpful, but if people are mentally ill, they're basically this is not going to work for them. So you want to avoid these types of patients, just as you would avoid these types of patients with multifocal lenses. So a second concept is if someone is not a candidate for blended vision, they're also not a candidate for multifocal IOLs. So multifocal IOLs are often a fallback position from blended vision. Well, these people are not going to do well in that. And as I mentioned, for decades, unknowingly, we've been screening multifocal IOL candidates for neuroplasticity and neuroadaptation. We just didn't know that that's what we were doing. So what is neuroadaptation? Well, neuroadaptation is where the nervous system adapts to a new stimulus, and this takes place at the level of the synaptic junction. And when we look at something, it's not just visual input that goes to the occipital cortex. There's no direct eye-brain fiber optic cable. There's a lot more involved in this. And there are significant interactions with numerous non-image forming pathways that control mood, behavior, cognitive function. So a lot of these things go through the thalamus, the amygdala, the prefrontal cortex, and also the perihabencular nucleus. And those of you who studied neurology know that these areas control mood, behavior, the ability to adapt to conflicting time demands. And think about the last patient who had a multifocal lens that didn't do well. Wasn't their emotional response almost out of proportion to what it was they were experiencing? That's because these non-image forming pathways are also involved. We want to preserve the signal to noise ratio, and this has some real important implications for debunking some of the things we were taught as residents, which were incorrect. Preserving contrast sensitivity is really critical to this process, and that allows for the suppression of background noise, and it results in an increase in contrast sensitivity. And any of you who do strabismus know all about suppression. You can have somebody with 40 prism diopters of a lefty exotropia, and they can suppress that. Well, we can suppress surrounding noise in a number of other ways as well. So this is important. So we want to have the highest signal to noise ratio. So this is actually my right eye. Okay. And I'll show you how this works. So over time, neuroadaptation combined with cortical summation, which means we summate the images for both the right and left cortex, enhances bilateral image processing. So I'm -1 in my right eye, okay? This is what the image looks like for me at 50 centimeters, -1. Now, take a look at this. This is what happens when I add my distance eye. And that's what's called the divergence paradox, which means that by adding additional information to the human visual system, I increase contrast sensitivity. Contrast sensitivity increases the same as resolution. So what we get is we get bilateral vision that's better than expected for the near spherical equivalent, and that's the divergence paradox. But it's important that people have binocular vision. Now, let's say that this doesn't become fully enhanced for a certain patient. Well, at the very least, what they're going to have is the same as an EDOF or a low-ad multifocal lens. So it still has some utility. We want to make sure we don't have any loss of contrast. And of course, this whole process doesn't give us positive dysphotopsia. And I really think in my heart of hearts, there are fewer challenges to the process of neuroadaptation than adapting to the typical diffractive multifocal IOL. Now, with binocular vision, reading vision is fine. I haven't worn glasses for 2.5 years, and I'm J1 at about 16 inches, 20/15 at distance. And I passed all of my Federal Aviation Administration commercial pilot exams for distance, intermediate, and near without correction. Also, small pupils provide an enhancement because that limits, it enhances depth of field. So neuroplasticity enables neuroadaptation, resulting in bilateral cortical summation. Now, the trick here is it takes about 6 to 8 weeks for this enhancement of vision to occur. So some people would say, well, I gave them a -1 lens in the near eye for 3 days and they didn't like it. Well, that doesn't work because this whole process may involve some additional neurons. It may involve additional neurotransmitter production. So this isn't something that takes place right away. And that's something you need to understand right from the beginning. So again, the preservation of image contrast is critical for the development of neuroadaptation. Now, one of the things we were taught as residents, at least I was, is that if you add positive spherical aberration or with the rule astigmatism, then the depth of field will be increased. And I'm here to tell you that I don't think that's correct. I don't believe that that works. And let me show you. So here's at a 6mm pupil, here's 0.275 microns of spherical aberration, and that's the population mean for European Caucasian eyes. Let's add spherical aberration. What happens to the image contrast? It goes down, doesn't it? Let's add 1 diopter with a rule astigmatism without spherical aberration. It takes away image contrast. Let's correct everything. Image contrast is better. So my experience has been that adding spherical aberration and adding with the rule astigmatism is not really helpful. And these patients need to have their astigmatism corrected. And if they have a normal spherical aberration value for their cornea, then add an aspheric lens that adds negative spherical aberration, like the ZC-BU lens or the SN60WF or one of the new Clarion lenses, because that's going to increase contrast sensitivity. Remember, the human visual system is a contrast sensitivity detection system. So here are some defocus curves. And this would be distance vision optimized with a binocular plano refraction, okay? And that's exactly what you'd expect to see. You know, as you get farther and farther away from distance, the acuity goes down, okay? This is plano and -1 blended vision. Isn't that interesting? So for common daily visual tasks, you're still in a completely useful range. Okay, so here's this would be a refractive EDOF lens. And what that gives us is a modest improvement for intermediate vision with binocular plano refraction. So it's a little bit better, but it still falls short. And this is what patients tell us. Here's a binocular diffractive EDOF lens, and we have light splitting. What that does is reduces contrast sensitivity. So multifocal IOL neuroadaptation failures are often, as we mentioned, associated with multiple non-visual symptoms. So anytime you have an incoming wavefront of light and you split it in half, by definition, you reduce contrast sensitivity. That's the way it works. So one of the reasons why people can read with diffractive multifocal lenses is it's a high MTF function. They're looking at black letters on a white background. Everybody sees the black letter in the white background, but in a more complex visual landscape, it's not quite as good. And then this would be for a trifocal, and trifocals are very, very popular, but it's at the expense of contrast sensitivity. So these work best in certain situations, but if the lights go down or the contrast between items is very similar, you're not going to get the same quality of vision. So a black letter on a white background and two atoms with similar contrast are completely different animals as far as the patient is concerned. So for successful blended vision, what you want to do is make sure that you set everything up for success. So you want to have normal biometry and calculation methods from this century. Do not use SRKT and Holiday 1. And have kind of normal biometry where you're pretty sure you're going to have correct outcomes. The distance eye is hard plano, no refractive astigmatism, no exceptions, and you correct as needed. And if somebody has half a diopter of astigmatism after surgery, you can do an LRI at the slit lamp. You can do whatever you want, but it needs to be hard plano to maximize contrast sensitivity. The near eye should be minus 0.75 to -1. We're going more towards -1 because I think that works better. -150 and -2 does not work. So no more nearsighted than -1. And no astigmatism, and of course, correct as needed. Now, for the near eye, a non-diffractive EDOF lens can enhance the process. And I've spoken with Doug Koch, and this is what he's doing, and he likes this a lot. So that might modestly extend the range of focus, and this would be for the near eye. But it has to be a refractive EDOF lens, not a diffractive, which would decrease contrast sensitivity. And you want to screen for higher order aberrations. These are always seen after almost all forms of refractive surgery because high order aberrations reduce contrast. In fact, the Zernike number is a direct relationship to how much contrast has been affected. So here would be somebody who had kind of LASIK that wasn't done very well, and you can see because it's red on one side of the corneal cortex and blue on the other, that you're going to have elevated coma, and coma is a form of irregular astigmatism. And avoid unusual eyes where we can't predict the refractive outcome, eyes with like keratoconus, extreme myopia, prior refractive surgery, eyes with poor visual potential. That's not going to work. So we have to limit this to people who we know are going to have really good outcomes. And then in our practice now, we're incorporating immediately sequential bilateral cataract surgery. You do both eyes at the same operative session. When I had my cataract surgery, my partner, Yuri McKee, did both eyes at the same time. And what it does is it hastens the whole process of neuroadaptation. If you wait 4 to 6 weeks between eyes, this can be difficult. How do you make a blended vision patient unhappy? Well, the near eye is too myopic. That's not going to work because you're going to break binocularity, or you fail to address all the refractive astigmatism. Or you ignore the loss of image contrast due to higher order aberrations. And very high coma and spherical aberration values associated with refractive surgery are exclusionary. We don't do this for these patients. And avoid the high to extreme axial myope and hyperope unless they had a contact lens trial lasting 6 to 8 weeks, because that's how long it takes. And then failing to consider occupational needs that may be outside the range. Do not make decisions quickly. I mean, it takes 6 to 8 weeks for all of this to occur. So in summary, It's comparable to an EDOF lens at a minimum or a low-ad multifocal, but it's often better. There's no loss of contrast sensitivity or stereoacuity as long as you keep the disparity between eyes, as mentioned. Neuroadaptation and cortical summation result in an enhanced defocus curve. And these defocus curves look a lot like low-ad multifocals. And we can often attain vision that's similar to the adult phakic vision. And we're now doing both eyes at the same operative session. That really speeds things along. You've got to hit your targets exactly with all refractive astigmatism corrected, and then avoid unusual eyes. And so neuroplasticity, neuroadaptation, and cortical summation, I think, is going to be the next visual frontier for what it is we do in ophthalmology. It's lower cost to the patient, but it's a lot of extra effort with less reimbursement to the surgeon. So this is probably one reason why this particular approach is not gaining popularity, because with a multifocal lens, you put the lens in, and basically wait for the credit card to clear, and you're off the hook. This requires a lot of extra time, so it may not be quite as popular. Thank you.
Thanks a lot, Warren.
Okay.
It was really wonderful.
Yeah.
So, Ramesh,
Let me
that is your
unshare
favorite
my
topic too. Yeah.
Can we unshare my screen here? So, Ramesh, are you doing a blended vision as well?
Warren, yes, Warren. For nearly 2 decades, I've been against diffractive multifocal optics in the human eye, because as we age and the pupil becomes smaller and the macula becomes weaker, it doesn't make sense to have a diffractive optics. So I've been using forms of monovision. 20 years ago, it was hard monovision, but in the last 15 years, more of -1 to 1.5. But like you said,
Yeah,
one is easier.
Yeah, when you get to -1.5, you're going to start to break binocularity for some patients. And it's real tempting, because let me just share one really important point that we learned the hard way. And that is, if you try and ask the patient what they need too early in the process, like at 4 weeks, they're always going to choose more minus every single time. And then you end up with too much minus. Make them wait 6 to 8 weeks, and limiting it to -1 really makes a difference. And now they say, "Doctor, I woke up this morning, I could read. I couldn't do that before." The stories we hear from, and you probably had the same thing, patients say, "Gee, this is like it was when I was younger." The problem is we can't get our colleagues to believe us, because everybody's
Follow the money, Warren. Follow the money.
addicted to the income.
Yeah.
And it's so much easier to put in a multifocal lens. Now we even take this one step further. I didn't mention this because you don't have this in India, but we use the light adjustable lens. So we can make things exact. Now, just tell you a real funny story. I have very unusual eyes. I have very steep corneas. I have a hot spot on my posterior cornea that almost looks like ectasia. I have a low Gould strand ratio, like what you see after refractive surgery. I'm an axial hyperope. I didn't even know how to do my own calculation. And so we got close, and we put in a light adjustable lens, and then we made it exact. But when the light adjustable lens comes to India, I think it's going to be transformative. Many patients want exactly the right outcome, and with that, you can do blended vision with very high confidence. And I'm looking forward to that becoming more available to everybody.
Warren, have you
Yeah.
noticed the shorter patients with a shorter arm and a closer reading distance, they tend to need a little higher power. I tend to choose 1.25 for them and not a 1.
Yeah, and that's a good point. I mean, that's why the 4-ad restore was so popular in people who were 5 feet tall, because they had to hold things closer. Yeah, that would be one example. But keep in mind too that the farther away you get from -1, the greater the chance of breaking binocularity, and it's a little different for each person. And this is, what do they say? Experience is what you get when you didn't get what you wanted. If you've been doing blended vision for 2 decades, you know where all the bodies are buried. you know all the things you can get away with and all the things you can't. And there's no hard and fast rule for this. It's based on experience. And experience is a wonderful teacher for all of us. And the moment we think we know everything, it's time to stop practicing ophthalmology because we don't.
True. True, Warren.
Ramesh,
Thanks a
can you
lot,
tell
Yeah,
us, Ramesh, how much extra chair time do you have to spend convincing a patient for blended vision?
Most of them are self-referred currently. In the initial
right.
years, it took a lot of time, but now they know that first eye is a seeing eye, the second eye is a reading eye, and they know they'll be fine when both eyes are done. So they have it in the mind. The relation has had it done, their friend has had it done. It's half the cost of a multifocal. So they're quite happy. Yeah.
How is it in
Right.
your
And the other
practice,
thing,
Warren?
well,
Sorry.
okay, just to piggyback on what Ramesh said, what you can also do is you can do the distance eye and have the distance eye exact, hard plano, no astigmatism, no exceptions. And then before you do the other eye, provided the acuity is good, do a contact lens trial at -1 or even maybe -1.25, 6 to 8 weeks. Do not do a 3-day trial because they're always going to ask for more minus every single time. So do a contact lens trial, but it has to be long enough. And at 8 weeks, you're going to get an idea as to how they're going to do. And if they don't do well, then you can do a refractive EDOF lens in the other eye, and that will help. That's what Doug Koch does. So there are a lot of different ways to do this. The important thing to remember is that cataract surgery is not about us. It's about the patient. And I know it's never been tried before, but we actually have to talk to the patient. It's a bold strategy, talking to the patient. And
Right.
everybody's different. Everybody's unique and individual. And some people want certain things, other people want other things. And to answer your question, Arup, it's a lot of extra time. If you do it right, it's a lot of extra time. And the irony is there's not a lot of extra reimbursement. And so that's why people kind of drift back towards multifocals, kind of one and done. You put it in, then hand them over to the optometrist, and who's next?
Right.
But it's not about us.
Yeah.
It's about the patient. And what do they say? When people come first, success follows. And Ramesh, I think you've discovered that, haven't you? Yeah, that the people where you get this right, they become an army of ambassadors for your practice.
Right.
Yeah. And just putting in multifocals is and nothing else. It's not a great strategy, I think. And Ramesh, people will be naming grandchildren after you.
That's when I feel I have to stop practicing, Warren. They're already bringing the grandchildren. I
Oh
suddenly know
no,
that I'm getting old.
you're not as old as I am, though.
You are an inspiration, Warren. Seriously.
Oh
After
no,
seeing you, I want to
no.
keep going. Yes.
Yeah. But anyhow, it's a wonderful thing. It's a lot of extra work. It requires, I think Ramesh, you would agree with me that in the beginning you're very steep on the learning curve
Yeah.
because some people do well, some people don't, and we really didn't know why. And it wasn't until years ago that I began looking at who was successful, who wasn't, that we began to put together these guidelines. And turns out they work. Not always, but they work because people are different. But so it's just another way to do things that I think if myself as an example, I have the vision of a non-presbyopic young adult. Wow. I like that a lot. And
One more
Well,
thing which I've noticed a decade or 15 years later, as these eyes become older, the lower at monovision no longer works. When the eye
right.
ages and they're not able to see
Mhm.
6.5, 6.4 or 20/20, when it comes down to 20/30 or less, it no longer works. They do need readers.
You're talking at it at near, yeah, and that's another very good point, and that is that before you do the surgery, we always tell them that if this doesn't work exactly as we want it to, it's going to give you distance and intermediate vision. So what I say is the good news is that you look around the room and every place you look, it's going to be in focus. Now, if you want to read something up close, you'll have to have some reading glasses, and they agree to that before surgery. And so afterwards, you remind them, okay, remember our conversation? They say, oh yeah, okay, I'm fine with it. If you
Yes,
tell them
Warren.
beforehand, it's not your fault.
Absolutely.
okay, Ramesh,
Yeah.
shall we move on to the next topic? Rolika
Yeah,
is here.
let's do
Rolika is
that.
looking at the time. So,
Okay, let's, okay. And again, as I mentioned, there's only one company that does this, so this isn't really a commercial presentation. I'm just using some slides from Huckstrite because they're the only people that do this. And this is going to be something I don't think anybody's seen before. So can we share my screen here? Okay, let's do this. Okay, and share. Okay. And you're going to tell me if this is coming up okay. Okay, can you see this correctly?
Yeah.
Okay, good. All right, so we're gonna talk about a new way to do biometry, and again, I'm going to show some slides from Hochstreit only because they're the only company that does this. It's something called Mandela scanning, and Mandela scanning is a different way to do OCT scanning, and the typical OCT scan is, I don't know, it's not always 16 radial scans, but it's like that. And what this scanning technique does, it's about 3,500 high-density nonlinear Mandela scans. And it's more than just scanning in one place. It allows a lot of interesting things to be done. And this is what we've been using now for about 2.5 years. And it allows us to do motion compensation because you have multiple scans all piled on top of each other. You can do topography with stunning resolution and also high resolution anterior segment scanning. Anywhere within the area of the scan is going to show up. So we do scanning, and each scan creates a segment, and then the segments are combined, and that gives us motion compensation and then high resolution of other areas. So they say this would be like 800 Mandela scans, and here's 3,000 Mandela scans. You can see how the resolution increases because they're all stitched together. And just another example of that. So this would be one scan. This is another scan, another scan, another scan. And do this 3,500 times, and what you get is a very high resolution image. So one of the very first questions that people always ask is, I've got a dense cataract, how does it do? And of course, the old tired joke in ophthalmology is the Bombay cataract, the white cataract. I'm not sure it can go through a white cataract, but it can go through some pretty dense cataracts. Ours is a referral practice. So a lot of what we do is for other ophthalmologists, and nobody's going to send us a normal eye, of course. So here's a 38-year-old lady with a prior retinal detachment, has diabetic eye disease, had a vitrectomy and developed one of those annoying post-vitrectomy cataracts. Her vision's hand movements, okay? This is the IOL master, nothing whatsoever, no signal return. This is the lens star, which, we love. And you can see even in the dense cataract mode, we get no reasonable data. And this is with this. So this is the right eye, which is normal. Here's the left eye, has a dense PSC plaque. And the retinal signal is reduced, but it still meets validation criteria. And when we look at the measurement summary page for this eye, we get 22.07. So in the beginning, I wasn't sure if this was really going to be accurate. So we would do ultrasonography on all these patients. And here's the ultrasonography on this patient, 22.07. So it does get, the dense cataract penetration is really quite good. Also, as far as measuring the cornea, because we have such a high density of measurements, we can get some pretty nice measurements. So we see a lot of unusual post-refractive surgery patients in our practice. So this is the Owlmaster lens star, absolutely nothing on the keratometry. This patient had, yes, wild RK. And with the iStar, with this measurement, we get a beautiful topographic map. We also get proper Ks, we get validated numbers, and we even get, oops, let's go back here. And we even get the Gould strand ratio and a bunch of other stuff. It's amazing. So no other device could actually measure this patient. And we get an elevated Gould strand ratio. Oh, and by the way, the patient has an unstable ocular surface. So when we increase the density of the measurements, what we do is we get a lot of extra information. And we can generate these the topographic maps. So it's absolutely no compromises, whatever. The topography is at 12 millimeters. Most topographers are 8 to 9 millimeters. So what I like is, I don't know how many of you have ever seen a true case of pellucid marginal degeneration. I probably in 40 years, I think I've seen 2 or 3. But a lot of times when people see the kissing doves or the lobster claw, they say, oh yeah, that's pellucid marginal degeneration. I would say 99 times out of 100, it's just keratoconus, it's not. But if you can see all the way down at the bottom and you can see the area clearly from the 4 to 8 o'clock position, 1 to 2 millimeters from the limbus, you'll be able to tell if it's pellucid marginal degeneration. So a lot of people would say, oh yeah, that's PMD, but actually, if you look at it correctly, it's just plain old keratoconus. We also have the same level of resolution for the posterior cornea. So this is 12 millimeters of the posterior cornea, and it's really good for things like ectasia because the resolution is so high. And for things like keratoconus, I don't know what it's like in India, but I spent a fair amount of time in the Middle East, and I was in Saudi Arabia and the UAE and Israel, and keratoconus in those countries is very, very high. It can be 17, 18, 19% in some areas. So having a real nice high resolution view of the posterior cornea is fine. And again, this is all by Mandela scanning. Everything I'm showing you is by Mandela scanning. So that's really all I wanted to share, was just that when you increase the density and make the strategy a little bit better, you can get more information. So let's unshare the screen here. And maybe you can unshare the screen for me. Yeah, I'm not unable to share it here. So are there any questions about this? It's pretty straightforward. But it's a neat strategy, and what it does is it just makes things so much easier. I'm not able to unshare the screen, so here we go. And they have a new version of this device coming out, the 910, and it'll probably be out in the beginning of next year. And it does even a better job, so which is kind of fun. Here we go. Let's see if we can stop the sharing. Okay, there we go. I've unshared the screen. All right.
So, Warren, do you feel with the advent of this device, our case will become much more accurate and precise?
Well, that's another good question. Remember, this is OCT, and OCTKs are not all that good, really. For topography, it's absolutely wonderful because it shows the power distribution. But for lens power calculations, remember, all the formulas are optimized against reflective keratometry. And reflective keratometry is still the standard for lens power calculations. And this particular device has the highest density for reflective keratometry of any device. It has 11.25 degrees between the measurement points, whereas things like the IOMaster 700 are 30 degrees, and they have to do a lot of iteration. So the reflective Ks are very good, but when looking at power distribution, the OCT is really the best method. And I hope in the future we find some ways to do better than just reflective keratometry. That's from 1859. It's not exactly current technology, but that's what we use. And so I would be against using OCT for IOL power calculations.
I had a question on the blended vision, sir. Yeah, in patients with
Sure.
regular astigmatism, can we use blended vision concept with toric intraocular lenses?
Absolutely. That's exactly what you want to do. The goal is no sphere, no cylinder, no exceptions. And if you want the other eye's -1, then of course use that with the toric IOL. And there were a lot of tricks to making the toric IOL work. Our practice was part of the original FDA study for the Alcon toric. In fact, I'm the author of the Alcon toric calculator. That was actually, I was part of the patent on that. And so we've been doing torics forever. And getting really good with the toric IOL is a key part for blended vision. And of course, with the rule of astigmatism, it's 1 diopter or more. Against the rule of astigmatism, it's half diopter or more because of the contribution of posterior cornea.
Okay, but thanks a lot, Warren. I just
Sure.
got into touch with Rolika, and then I think the next team is waiting for checking in. So
It's been a great pleasure being with all of you.
Warren, wonderful to have you with us, and that to such a odd hour at your time, in your time zone. And I'd like to thank Ramesh and all other speakers, Dr. Sandhya, Dr. Nirvana, then Dr. Twinkle, to join me for this particular program. And really, you have done a wonderful job. Thank you for coordinating the entire event.
Thank you.
And we need to take a picture, all of us. I think that was one of the instructions, right? Someone will take a screenshot.
Okay,
Done, sir.
There
you go.
Yeah.
Okay, Arup, well, you and I will see each other in London.
Yeah, at London, yeah, we'll meet each other. Rulik, you have taken a screenshot?
Taken, sir.
Thank you.
Okay, thank you. Thanks a lot. So we need to check out, and again, thank you so much, Warren, and rest of the team.
Okay, best wishes to everybody. Bye-bye now.
Bye-bye.
Thank you.
Dr. Sonam, would you like to share the screen?
Sure, Dr. Rolika, give me a moment.
Yes, sure. We can start whenever the program director would like to. Pravin, sir, up to you. Good evening, Shri Ganesh, sir.
Shall I share the screen now?
Yes, please.
Hello, good evening.
Good evening, sir. So I guess our speakers are all lined up. I think we got the session a little late. If everybody wants to settle, that's absolutely okay. And then we can start whenever the chair and the program director are okay with it. Pravin, sir.
I'll go through it and practice.
Pravin, sir, would you like us to wait or would you like us to begin?
Hi.
Yes, sir. Hello.
Um,
Good evening, sir. So, Dr. Sonam
Hi,
will
so-
briefly just introduce the session and hand it over to you. So, whenever you would say we can begin, we got the session a little late, so we can wait if you would like.
Perfect.
Good evening, sir. Good evening, Dr. Pravin. Are we waiting for a few more minutes, Dr. Rolika?
As per the chair and the program director.
Pravin, sir, shall we start or we wait for another couple of minutes?
I think we can start. Most of the speakers for the session are here, so I think we should start
Sure, sir.
on time.
Sure.
Dr. Sri, are we to start as well?
Yes.
A very good evening, everyone. I'm Dr. Sonam Yangzis, and we are here for this wonderful session on topic being the perfect cataract surgery. Can we truly achieve refractive nirvana? So it's a 45-minute session, and our program director is Dr. Vaddavalli, sir. And we have our chairman, Dr. Sri Ganesh,
And the panel speaker, Dr. Eric Rosenberg from USA, Dr. Jagadish C. Reddy, Dr. Priyam Gupta, Dr. Rushad Shroff, and Dr. Vardhaman Kankaria. We are all here for the session.
Thank you very much, Sonam. So we'd like to get and then especially Eric, for whom it's early in the morning, Jagdish, Vardhaman, and thank you to our chairperson, Dr. Sri Ganesh as well. Dr. Sri, would you like to say a few words about what we're trying to achieve in the next hour, 15 minutes or so before we can begin?
Thank you, Pravin. And welcome everybody to this session on the perfect cataract surgery. Today is the era of refractive cataract surgery. So when patients come in for cataract surgery, they not only expect good visual recovery, but also they expect freedom from glasses. And this can be achieved only with good refractive outcomes. So most of these patients expect both distance and near vision. And so all these patients have to be given options of the various types of lenses. There are various aspects of achieving a perfect cataract surgery, starting with the diagnostics and the pre-op assessments, ocular surface assessment, perfect biometry using the right formula, selecting the correct lens depending upon the lifestyle of the patient, use of toric IOLs to correct astigmatism, and also taking care of post-op issues to prevent unhappy patients. So there is quite a lot involved in achieving Nirvana. So welcome to this session, and I hope we have a very nice discussion on how we can achieve this goal of the perfect cataract surgery.
Perfect. Thank you very much, Dr. Sri Ganesh. And this session is not your typical session on ensuring that you get better outcomes with just plain cataract surgery. And I think what we've tried to do in this session, especially with our Stellar Starcast, is to push the limits of what is possible with edge case scenarios from the point of view of cataract surgery. So we do have briefly Dr. Jagdish Reddy, who's going to be speaking to us about where to expect the next biometry formula to emerge from. Then we have Dr. Eric Rosenberg, who's going to speak to us about a very, very exciting development about how you can operate without the need of a microscope. Vardhaman is going to answer the eternal question about trifocals versus EDOF and how do you choose in a patient. Then Dr. Priyam Gupta is going to speak about a very interesting scenario of how you can use a piggyback fake IOL with a refractive size. And then we're going to round her up with Rushad speaking about cataract surgery in keratoconus, which is becoming all too common. So I'd like to first introduce and invite Dr. Jagdish Reddy to speak on the first topic for today, which is how data science can influence biometry. And Dr. Jagdish Reddy is from Hyderabad, renowned cataract refractive surgeon, has more than 20 years of experience. Improving accuracy in IOL power calculations for cataract surgery. Dr. Jagdish, all yours.
Just a second. Thank you, Pravin. And it's a privilege to be part of this wonderful session. And thank Airways to have given me this opportunity. So I'll just share my screen. So can you see my screen?
Yes.
Yes.
And am I audible as well?
Yes. Perfectly fine.
Thank you so much. So I titled it as Data Science, Biometry, and Predictive Cataract Surgery. And I have no financial interest to disclose. And I'm very thankful for all the data and research that I did while I was in LV Prasad Institute, Hyderabad. So as Shri Ganesh did mention that cataract surgery is now refractive and predictive wise, and the outcomes wise, we look at as predictable as refractive surgery, where patients have become more demanding, and then we try to give them better visual outcomes with every eye that we operate. But I think it's very important for us to understand the future of cataract surgery, just not surgical excellence, but I think predictive precision is very important as of today. So we do see that we do an excellent surgery, but we do end up giving patients, some of them, some amount of correction post-surgery because they're not happy with what the outcome has been. So what do we do today? Do we really achieve Nirvana, like as the session titles? So let's look at what are the factors that would affect this and how do we improve this. So the outline of my presentation will go in this format. Let's start off. So definitely we know that we have evolved significantly in several aspects like biometers, premium IOLs, modern formulae, and the use of femtosecond lasers. But we do encounter even today residual refractive errors, and we do see unhappy premium IOL patients, some toric surprises, and outcome has been variable that we don't understand at times. So perfect surgery does not always produce perfect optics. So I think it's very important for us to understand and explain to our patients as well. So we looked at several aspects with the data that we had at LV Prasad Institute. And one of the important things that we often miss looking at is symmetry between the eyes. Let's look at what the data says. I wanted to really understand how this data would show us what the symmetry is and how do we use this for the patients to improve the outcomes. So most IOL prediction systems assume that there's a biological similarity between the eyes. I think the predictable anatomy can be a little variable. So I think we need to understand that the human eye may not be truly predictable. In order to answer this question, we went ahead and pulled out huge amount of data, about 35,000 plus eyes who were diagnosed with cataract and underwent cataract surgeries, and looked at their optical biometries. And we looked at multiple parameters like axial length, keratometry, that's mainly astigmatism, anterior chamber depth, lens thickness, and wide-to-wide diameters. And then if we look at, most of the times when we look at the biometry sheet, we always look at the symmetry in axial length. We don't give importance to other aspects of it. But here, if you look at most of the patients, the clusters has been pretty much comparable in normal axial lengths, but as the axial length increases, you can see outliers that are very prominent. And this is corneal thickness. Corneal thickness shows there's less scattering, and most of the patients have pretty comparable corneal thickness between the eyes. This is a scatter plot showing the anterior chamber depth. It also shows pretty much compact, but you do see outliers here and there, and it's been consistent from low ACD to high anterior chamber depths. And this was alarming for us to see the wide-to-wide being so scattered across various diameters. I think it's very important for us to understand wide-to-wide diameter dictates the capsular diameter and the effective lens position as well. So some of the formulas, like Barrett's formula, shows that wide-to-wide is an important parameter. And if this is not appropriate, definitely our accuracy or predictability on the post-operative outcome may not be appropriate. So I think it's very important for us to see this and compare between the two eyes. And it was also alarming to see the astigmatism profile. I think this is scattered everywhere, and a lot of patients had difference between the right eye and left eye, where one of the eye may not require a toric lens, but the other eye may require a toric lens here. I think adding the posterior corneal curvature, I think this would even be skewed. I think it's important for us to look at this as well. This data was really important for us to look at and educate not only ourselves, to the patients as well. So what clinical relevance does it have? It has a lot of importance here. So it affects the effective lens position predictability. Toric planning can be affected, and sensitivity to the formulas also changes. And refractive surprise risk is very high when there is too much of variability between the eyes. So just remember that a biologically asymmetric system cannot always be solved with symmetric assumptions that we make or the formulae that we use. So once we saw the data, we felt that, can we do something with this data? So, and then we started looking at how do we improve the refractive predictions with the biometry data that we have. We went back and pulled out all the data, even of the post-operative outcomes as well, and looked at certain things. So if you look at previously, we were looking at axial lens keratometry and look at a formula and then implant an intraocular lens. But now things have changed, and there's been a lot of things where when we were looking at things at multidimensional modeling systems, non-linear interactions that can happen between different parts in the eye, predictive analytics, and we've started using artificial intelligence assisted personalization of different formulae and the data that we get from the outcomes of our surgeries. So the more dimensions we measure, the less we guess, and we will be able to nail down to what we want to achieve. So when we look at the outcomes of cataract surgery, there are a lot of factors on your left, that is the preoperative factors that can affect the outcomes. And we do have intraoperative factors as well, and to dictate the postoperative outcomes. But in spite of us looking at several of these, we do see a variable postoperative outcome. There have been masters over the decades who have studied about these biometry values and come up with different formulas, which we enjoy over the years. And we always started looking at newer ones to see how we could improve our outcomes. So this is a table showing all the formulae and how they work. The concept changed from simple regression analysis to most recent data-driven prediction that we've been using in the recent times to give very good outcomes. So earlier, all these formulas have been working on giving us better effective lens position. So earlier, these formulas were using the fixed equations or assumed relationship between the structures and the data that is produced and the population averages to get the effective lens position. But newer generation formulae have gone beyond that, looking at pattern recognition, adaptive modeling, large outcome data sets, and non-linear relationships between different aspects. So the evolution of the formulae is essentially the evolution of our ability to predict effective lens position and nothing more beyond that. So as of today, which are the formulas that play well? So I think Barrett Universal 2 has been one of our favorites. We've been using it across the globe. And then we have EO 2.0. So it's been working on emmetropization-based approach, and it usually works well in long eyes. And Kane has been using some amount of artificial intelligence using the data and has been giving good results, not only normal eyes, but also ectatic eyes. Pearl DGS, we've been hearing a lot of about Pearl DGS from Damien Gatinel in this group, and using machine learning driven concepts, and it is definitely useful for outliers. And Hill RBF exclusively on large data set from the LensStar. I think this formula also has been doing well. If you look at in a nutshell, differences between top modern formulae have become smaller, and we are achieving a plateau when we look at the outcomes based on these formulae. So are we really happy with the existing precision? Should we stop exploring new options? Definitely not. With this question in mind, looking at the outcomes, there's still a scope where we can improve the outcomes. So we started working on a formula to see if we could improve the outcomes, use this biometric data to come up with something more meaningful. So we extracted all the biometric data from the biometric devices, and this was both retrospective and prospective data, and it was extracted into Excel sheets and then for an analyzable format. And this is the structure that we followed. We used all the biometric data from cataract surgery patients, excluded those who had poor vision, excluded those who had other complex comorbidities, and looked at removing the extreme variables in the biometry as well. And we also removed those who had PMMA lenses or small incision cataract surgeries. So we came up with plain fake emulsification with no complications. And we used this data, some data for training and some for testing. So we used the data in a different approach. We looked at what is the IOL power that we would be achieving, that IOL power prediction. And the second one is what is the residual error that we are looking at after we get the IOL power. Sorry. So this is the results of the proposed formula. So compared to other formulae that we analyzed as of now. So we looked at plus or minus 0.25. The number of the percentage of individuals that would fall in this group was significantly higher compared to any other formulae. But when we compare plus or minus 0.5 diopter, we look at most of the formulas were pretty much comparable. And we also compared this data with then published article from American Academy of Ophthalmology. We saw that the plus or minus 0.25 predictability was much better with the proposed formula, but otherwise it was comparable with what was published. So this is what we saw, like we did see that, I'm sorry. We did see that in a quarter diopter range, I think this formula did very well. In a half a diopter range, we did see that Barrett's were doing much better, but this proposed formula was comparable with other formulas as well. And we compared the same data with the same intraocular lens, that was published in the American Academy of Ophthalmology journal. And we did see that this proposed formula was doing much better than what was published. And it was good to see, and it was encouraging for us to work on this further. And we looked at a different lens as well, SA6080. We did see similar trends. In a quarter diopter, we've been doing pretty well. And then in a half a diopter, you can see that it's comparable to Barrett's, but there were other formulae which were doing better than what we saw here. And when we compared with the published literature, similar trends where this proposed formula was doing much better and compared to other formulae that has been published so far as per this article. So we also looked at normal range axial length, and we did see that the proposed formulae was doing much better in both the quarter diopter and the half a diopter as well. And the half a diopter is comparable with most of the other formulae. And in the shorter axial lengths, at a quarter diopters, we were doing much better. Whereas in the half a diopter, we saw other formulas doing much better. And some of the formulas were comparable with what we got with this formula. And we had very little data with high axial length. So we could see with the quarter diopters, we were doing pretty well, comparable with Barrett's. But there were other formulae which were doing even better, showing 95% of them being within a quarter diopter. So we also compared with...
Interrupt, Dr. Reddy, if we could wrap it up a little early, because we are running short of time since we have another session right after. Thank you so much.
Sure, certainly, I will do that. So we'll compare how this formula did with axial lengths, with various axial lengths with other formulas. It was definitely following the trend. Similarly, with calorimetry, we looked at it was definitely following the trend with which other formulas have been using. And with anterior chamber depth also, we saw a similar trend. But lens thickness variability also, we did see similar trend. Since all the formulas use the similar data, we're not able to see too much of variability that we usually notice. So the future is going to be like we may move from static formulae to continuously learning systems. From population averages to individualized prediction would be the way to go. From estimating outcomes to estimating confidence in our outcomes would be improved with time with the data that we have. And we would be looking at not just the smarter formulae, but a smarter ecosystem for us to reach where we want. So the next major leap, I would say, would not come for another equation of the formulae. It would come from better data that we need, and better characterization of the anatomy of the eyes, better understanding of the biological variability, and better prediction ecosystems that would help us reach the better outcomes for all our patients. Thank you.
Hey, thanks a lot, Dr. Jagdish Reddy. Dr. Jagdish is from Pristine Hospitals. And just one question. When is the Jagdish Reddy IOL formula coming out for use for everyone?
No, there's a long way to go. Like we are good with regular axle lengths. I think we're more short of data. I think pulling data for shorter axle lengths and longer axle lengths, I think would be more important for us to get this available for everyone.
Yeah, thanks a lot. I think very telling to know that you can probably, you don't have to memorize the names of these complex formulas in the future, and all of us will have our own formula based on the biometry that you use that is customized to your outcomes and your surgical steps as well in the future. So thank you very much, Dr. Jagdish Reddy. And coming up next, we have probably one of the most exciting developments in the field of cataract surgery that you've heard of in the last several years. I'd like to introduce to you Dr. Eric Rosenberg. Dr. Eric Rosenberg is a clinical assistant professor at the New York Medical College, comes from Long Island. And for several of you who follow ophthalmology on social media, you might have heard about this young gentleman who's been making waves by operating on a patient with a cataract without using a microscope and without using any of the traditional techniques that you would associate with cataract surgery. So, Eric, the stage is yours, and blow everyone away with your new technique.
Well, thank you for that introduction, Pravin, and thanks, Jagadish. That was an awesome review of the IOL formulas, and I learned something here today. I'm ready to use that IOL formula, so I appreciate that. Honored to be here with you all today, and we've been very excited about our newest development, our newest build, about using the Apple Vision Pro here. I'm going to share my screen, and I think video is probably the best way to handle this. So we're going to share this, and then we're going to go over here. And so my name is Eric Rosenberg. I'm a cataract, cornea, and refractive guy out of Long Island, New York. I like to dabble in a lot of the complex anterior segment as well. I helped co-create the Digital Clinical Committee of ASCRS with John Hovhanessian. And we firmly believe that the future is digital. There's a lot of technologies, and every time technology comes out, it helps to improve and make our field better. And everybody here is a testament to that. And I commend Pravin for putting together a really interesting group of speakers, because I think all these things play really well into one another. So I was a general surgeon before I did ophthalmology, and there was a motto in general surgery: if you can't see it, you can't fix it. So visualization is probably one of the most important things to our field, and is one of the slowest adopted things in our field, which is ironic. From going loops to the operating room microscope in the OR, that transition took 50 to 100 years. And so far, it's taken about 10 years on the digital landscape of switching from analog oculars over to digital ones. And if you look around the conference halls and the convention centers, you're going to see all these companies are now coming out with their digital products. The world sees what's coming, and it was the last key in the ecosystem of having that full interoperable system, of not having a digital microscope. So I think we're all going to be transitioning over to it. And not only is it better, not only is the depth of field, the magnification, the color enhancements, the digital enhancements, not only are all those things better, but they can be made much more affordable than traditional operating room microscopes. And now we're taking it a step further, and we're using spatial reality in the operating room coupled to the digital microscopes. And the reason for that is so you can have a full interoperable suite. So here's a little picture of me using the Apple Vision Pro for the first time. This was back in October of 2025 with my scrub tech, who was very much enjoying the experience. But you can see I still have the Ingenuity affixed to the Zeiss Lumera 700 in this particular room, which then goes to the operating room microscope. But let's see It's my pleasure to introduce you to a first of its kind in my new surgical cockpit. Using the Apple Vision Pro as the visualization medium and a specialized software we've developed known as Scope XR, these independent systems can be unified in real time. Scope XR enables integration of any digital 3D operating microscope with live biometry and diagnostic data drawn directly from the clinic's cloud-based infrastructure. In doing so, it redefines a surgeon's relationship with both data and the environment. Inside the headset, the surgeon's view is enriched but not obscured. Live surgical imagery is displayed in stereoscopic fidelity, overlaid with spatial anchored data, the same information once confined to secondary monitors. The information can be placed precisely where the surgeon expects them to appear, without interrupting concentration or sterile technique. Thank you for watching. So in that video, you're getting a first-person view. Did you hear the audio? Was that clear? Okay, beautiful. So in that video, you're getting the first person view of me wearing the Apple Vision Pro and doing a screen record. So what you're seeing there is exactly what I'm seeing. And yes, it's an overlay on current systems. And obviously, as this goes down this trajectory, we're going to see a modulation of what we're currently doing into something like this. And the Apple Vision Pro is just such a wild device. It's really ahead of its time. And what's funny was commercially, it wasn't really that well adopted because why? It wasn't great for gaming. The average consumer was finding it difficult. I mean, it looks a little bit clunky, right? I look a little silly with it on. If I walked to you in the supermarket and I had those on, you would probably run the other way. But, in terms of what its functionality and its capability, it's astonishing what it can do. And our old systems, the VR systems that were based out of, like, let's say Oculus and Meta and Pico, they were excellent at VR, but they weren't as good in the true spatial mixed reality realm. When you put on the Apple Vision Pro, you feel like you're in your OR, and there's a lot of hardware between your eyes and what you're seeing externally. For the first time ever, you feel like you are in your own environment, and it is no different than you opening up your own eyes and being like, hey, I'm in my room. Whereas, traditionally that hadn't existed. And now with the spatial overlays, we're able to actually recruit information, and in this case, hijack it from the Ingenuity and bring that into the Apple Vision Pro. I happen to have teamed up with a longtime Apple developer for 30 plus years, and we created this application called Scope RX. Obviously, I helped build it, so I have financial interest in that. But here's another view. Probably don't need audio on there. Here's another view of us overlaying all these imageries, right? So the Ingenuity 1.5 actually does iris registration. So you can confirm you're operating on the correct patient, procedure, site, eye, all in that initial picture, which takes the imagery from the Argos biometer in the office. So they're in the seated position. And then we have a digital overlay from that office to the operative microscope, and we can confirm that we're operating on the right patient. But more importantly, it accounts for cyclorotation. What lens did I pick? All these things are all heads up. They're all in front of you. And then if you want to take Dr. Reddy's, IOL, imagine starting to overlay some of these future progress. And you're right. The differentiation factor is biology. Biology is what makes every person unique. And we're going to start seeing those integrations not preoperatively, but intraoperatively as well. So let's break it down. This is us, right? We're in the middle of all this. We're in the middle of our EHR, all our diagnostics, the patient's asking us questions. We're trying to send information to and from our diagnostics. What IOL are we picking? Do we send it to our surgical coordinator, who then sends it to the office? We are so burnt out from the massive information that exists. And I don't know why, but we keep putting ourselves in the center of it. So now that we have a full intraoperative digital suite available to us, this is what I kind of see for the future of ophthalmology, where, hey, we just get to interact with our patient and all the data works seamlessly for itself and then gets integrated into our operative day. So we're going to have cloud-based systems that overlay. Now the EHR is going to be more a back-end solution instead of a front-end one. And then we can actually overlay all those matrices and metrics in the OR, and then we can actually have the systems cross-check whether or not we have those lenses, whether or not they've been ordered, whether or not, you know, the industry partners that we work with have that stuff in our office, and that'll all be seamless. That will be external to us, which is what it needs to be. We need to start interacting again with our patients because there's a lot of information that we need to communicate to them. So I'll leave you with this. This is a little video again explaining. Ophthalmic surgery has undergone rapid transformation driven by advancements in digital imaging, precision optics, and surgical data integration. Yet even with these technological processes, one challenge remains: bringing every piece of information a surgeon depends on into a single cohesive environment. Traditionally, an operating room is a network of discrete systems: the biometric workstation, the surgical microscope, the phaco or femto. Well, I might have broken it. Let's see. I was trying to annotate here, but my apologies. In recent years, ophthalmic fragmented. Valuable data. So while I'm holding it, you can actually see that I'm using Apple's back-end ecosystem to be able to FaceTime anybody into the OR in real time. That exists in multiple places, and in the preoperative clinic, on cloud servers, and on displays stationed around the room. Spatial computing now offers a solution for this separation. Using the Apple Vision Pro as the visualization medium and a specialized platform known as Scope XR, these independent systems can be unified in real time. Scope XR enables integration of any digital 3D operating microscope with live biometry and diagnostic data drawn directly from the clinic's cloud-based infrastructure. In doing so, it redefines a surgeon's relationship with both data and the environment. Inside the headset, the surgeon's view is enriched but not obscured. Live surgical imagery is displayed in stereoscopic fidelity, overlaid with spatial anchored data, the same information once confined to secondary monitors. The biometry, IOL calculation parameters, and lens choices, along with axial length topography maps, can be placed precisely where the surgeon expects them to appear, staying accessible without interrupting concentration or sterile technique. This integration supports a more natural surgical workflow. There is no need to divert attention to a wall display or rely on verbal updates from outside the field. Information becomes part of the visual space itself, enhancing situational awareness while maintaining ergonomic efficiency. Another dimension of spatial computing lies in its capacity. You see right here, I have all my biometry data. I'm not going to let it play out the entire time because I'm coming short on time, but you can see I have all my biometry data. I can interact with it while being sterile. I have my gloves on. You can scroll through it. Let's say, you know, I had a challenging case and I broke bag. I have all my data up, and that's it. So we'll shortcut through this. I'll do one more video. If somebody has an Apple Vision Pro on the other side, so you can be in India, you can be in Israel, you can be in UAE, you could be in Italy. If you have an Apple Vision Pro, you can actually come into my OR in an AI that Apple has built internally, and then you can actually maneuver in my OR and you can annotate on my screen. You physically don't have to be in another person's OR. I think that this is going to open up democratization of care and surgeries, whereas when normal knowledge sharing is us sharing surgical videos about how we do things, for the first time ever, we're going to be able to transport ourselves into somebody else's OR. It looks like you're there. You're going to be able to walk around, go over to the screen, say, hey, you know, Eric, I think you could do this a little bit better. Go under here, rotate like that. You know, or if you're doing MIGs, maybe you want to do it in, you know, rotate in superiorly. But here is Kevin Bulgari. He has an Apple Vision Pro. He's in my OR. He's actually wearing the Apple Vision Pro, but that's an AI avatar of him that's built by Apple. He's dialed into my OR, and he's decided to take a seat right next to me and watch my surgery in true stereoscopic 3D. So it's not like he's seeing a 2D image. It's not being broadcast, you know, in 4K 2D. This is 4K 3D stereoscopic view for anybody anywhere in the world coming into the OR. and being able to help, especially when we need it the most. So what I like to say is that the four walls of the OR used to be very, very tight and closed. I feel like we've just blown open the OR and made it accessible to all our colleagues and friends to make sure that we have the help that we need when we need it the most. So clarity isn't just seen, it's engineered. Thank you again for having me. I'm sorry for going a bit over there.
No worries, Eric.
Yeah.
I mean, just wow, this is something that I actually, like you said, probably going to blow open the world of teaching, the world of collaboration. And I think very, very exciting to also know that it might be able to cut costs and will be a great tool, especially for developing countries, to be able to ensure that you can do things right and also learn things without boundaries as well. Thank you for pioneering this. And I'm sure this is going to become very, very sought after in the next few months or even years or so. Thank you so much for your time and lovely, lovely talk. Thank you.
Thanks for having me.
Dr. Pravin,
Thank
sir,
you. I
can
know
I
you
add something?
have, yes, of course.
Yes, sir. So I just wanted to add that so this is actually a very useful tool. We landed up using it in endoscopic DCRs as well. So in in that way, you don't have to be worried about your neck. It's ergonomically stable as well because you can easily sit and look through. You can have the videos playing on the side while you can train your fellows or residents, and as you put in the team as well, that they could see your surgery live. And it kind of reduces the cost specifically in US because over there the entire tower of endoscopic DCR is more expensive. So I know that this is like it was good to see that this is being applied to cornea as well. So it's like it's around $3,000. That's the entire system. So we don't need the external tower, which is approximately $22,000 over there. So that's the difference that we were able to achieve with Apple Vision Pro endoscopic DCR. So I think that's a very good and very convenient thing. So just wanted to add that.
Absolutely. That was one of the first papers that came out was actually for oculoplastics and the Apple Vision Pro. It was brilliantly done. And then, while we were playing with it, I saw the paper come out. I was like, yes, like other people are getting this. But that's why I thought it was prudent to team up with Apple developers, people who have been doing this for 30 years, because it can act as a screen, but it can act as so much more. And that's what we want it to be. We want it to be a window to everybody's OR. We want it to be an interconnection device just as much as it helps us. And you're right, talking about a commercial no medical commercial device in the US costs $3,000. $3,000 is the screw that you need in order to, screw it to the wall for the US ecosystem. But more importantly, right, it also allows us to be able to go and to teach without physically being there. And that's been one of our deficits. When we go over and we do mission trips, there's economies of that don't necessarily work. We're using borrowed things. Now we're going to be able to build out, infrastructures that are going to exist for these places that don't otherwise have access to care. And hopefully it's going to be a better world for all of us.
I just have a comment to make. I think this is a very exciting development, and it will be very useful for training, because what can be done is with the diagnostics, you can make a digital twin of the eye, and you can have an overlay of the surgical steps, a guiding step-by-step technique for surgery. And then if a resident or a fellow is wearing this, and then he has the guidance as to how exactly to go about, and it's going to guide him step by step. So that is very exciting for training. I think it would be a great tool.
Absolutely. So we actually did the same thing, that we kept the usual video on the side because you can have multiple screens on it. So we kept the usual video where, this is the video with all the steps in place. And then the surgeon was operating and the fellow was operating, looking at that video side by side. So that was very helpful in training as well, as Sir said.
Perfect. I think that's really exciting. We probably need to move on to our next set of talks. Thank you so much again, Eric. I know you have to be somewhere else. So thank you for your time in the morning. And I'm sure we'll have you back on in the very near future. So coming up next is probably a talk that all of us probably need to listen to, just because of the fact that it promises to clear so much confusion in the world of custom IOLs and advanced technology IOLs. So we have Vardhaman Kankaria, good friend of mine and fellow from one of the most prestigious institutes in the world, Bascom Palmer and the University of Crete. Vardhaman is the head of the Asian Eye Hospital in Pune, and he's here to be speaking to us about how do you choose between a trifocal lens and an EDOF lens, and what conversations will you have with the patient before you make that choice? Vardhaman.
Yeah, thank you so much, Pravin and AIOS team for having me here. Been very exciting to listen to both Jagdish and Dr. Eric. I think both of their talks were super futuristic. Mine is going to be more basic, so I'm going to talk to our, let's say, comprehensive ophthalmologist to probably go through this dilemma of choosing the lenses. One second, I think. Continue to share. Yeah, I think my presentation is being seen?
Yes, sir.
Yeah, all right, sure. Thank you. Right. So basically, friends, as we all know that the cataract surgery now has definitely gone in the era of the refractive cataract surgery. Now, gone are the days when patients desired only very good, excellent, uncorrected distance visual acuity, but now they want spectacle independence, especially now with the acceptance and also long-term, let's say, success seen with the LASIK surgery itself. They definitely want to translate this into the cataract procedure. But the most important thing is, of course, the selection of suitable IOL, because that always remains the cornerstone for very happy patients' outcomes. And these patients are actually very demanding. So let's look at this case. This was a 70-year-old female cardiologist who had come to us for second opinion. She had recently undergone a bifocal implants in both her eyes elsewhere, but have been really devastated with the quality of vision, have gone to almost every clinic in the city and elsewhere. She used to be very happy with her contact lenses when she used to do monovision in the past. But unfortunately, after her cataract, she had to undergo cataract procedure, and her surgeon did propose to her to have independence from the glasses intact and the contact lenses now to have the bifocal implants. This patient, when she came to us, had a uncorrected vision of 612 and 10, 618 and 10 in right and left eye, was best correctable to 69 and 6 in both eyes, but was very, very unhappy with the quality of vision, even with the spectacle correction. And so basically, ultimately, we had to go through and exchange this bifocal lenses for her with the monofocal plus implants, and did a monovision for her. So why this patient did so poorly is depicted in this photograph. This is her fundus photo. You can actually see a lot of RP alterations in both eyes and some drusen's when you look at the OCT, along with some epiretinal membrane formation in the left eye. Of course, this poor quality vision because of her macula then got compounded with further reduction in contrast sensitivity with the multifocal implants, and she was very dissatisfied patient. There was a study from Bascom Palmer Institute done by one of my good friends and co-fellow at that time, Dr. Gibbons, under Dr. Kendall Donaldson, and they looked at the causes and correction for dissatisfaction after implantation of presbyopia correcting intraocular lenses in about 74 eyes. They did see that the most common reason for dissatisfaction remained as the residual refractive error and dry eye. However, many of these patients required IOL exchange, almost 7% of them, and almost 1/3 of them remained dissatisfied in spite of the treatment which was offered to them. So the role of IOL selection and the patient assessment to rule out these patients is really, really crucial. Before we go to selection, I think let's understand how the optics of these lenses work. Before going to the trifocals and EDOFs, let's understand where it all began, which was the bifocal lenses. The bifocal lenses have the optics in which you have a typical monofocal aspheric lens, which is then added with a cuneiform plate. This cuneiform plate has the diffractive ridges, and as you can see, this diffractive ridges is going to actually it is going to cause deviation of the intermediate and the near objects so that they can be focused onto the retina. There are going to be, of course, two different images which will be formed because of the same reason. And there is a physiological separation of one image so that we can actually achieve a clearer image for that particular distance, for example, for distance and for near. Both the height of this ridges decides how much deviation is going to happen. Therefore, as you can see in this lenses, there was a phenomenon called as apodization, which means there is a progressive reduction in the height of the ridges. So basically, increase in height deviated this rays more. Therefore, for near convergence, the nearer or the central part of the lens was used, and as you went away from the center of the lens, as the stapes became less and less acute and more flatter, the distance objects were actually focused pretty well. And this is one of the reasons that when you actually have a patient with bifocal who goes in a very dim condition and the pupil becomes bigger because of the mesopic conditions, scotopic conditions, they actually have a lot of rays which are going to the distance and not so much onto the near versions, and therefore they have poorer near vision. And that's the reason we always ask them to have very bright light whenever they want to look at near objects and read up front. The width of this diffractive steps also governed the addition. Therefore, in the past, as you know, we had multiple choices of near addition with this diffractive lenses of +4 ads, +3.5 ads, and also +2.5 ads as well. The couple of lenses which were very popular were Acrysoft Restore and the Technics Multifocal, no financial interest. But both these lenses had the same profile, and both of them did have many happy patients, but actually had a disadvantage of having poorer intermediate vision, photic phenomenons because of this after images, and also the secondary images being formed because of multiple foci and splitting of the light, and decrease in the mesopic contrast sensitivity. At least to overcome poor intermediate vision, there was a new lens which came, and this was called as the trifocal lens. The trifocal lens has had a very interesting design in which, as we have seen, two cuneiform plates, one for distance and near with the same apodization, and the second one for distance and intermediate. When they were superimposed together, it actually gave a kind of modified cuneiform plate, which could actually now give 3 different foci instead of 2, so that we have one additional focus for the intermediate. And this was the basis of the trifocal lenses. But because of the same design, the splitting of the light, multiple foci where we have to do a like a physiological separation of the extra images. There were, of course, photic images and photic phenomenons in the form of halos and glare, which was seen. We still had slightly better utilization of the light compared to the bifocal lenses, but there was still a lot of light being lost in this process. And these patients also did suffer from decrease in contrast sensitivity. There have been multiple commercially available trifocal lenses. In the right patients, they have actually done pretty well. But the disadvantages of, so as you can see, this is the defocus curve of the bifocal lens, and you can see also the trifocal IOL, and you can actually see that the intermediate focus is actually missing when it comes to the bifocal one, but in the trifocal you have more smoother transition of the vision, but still with the same issues of halos, glare, decrease in contrast. And actually, definitely, it is very important that the selection of the eyes have to be physiological and anatomically almost near to normal otherwise. So to overcome these issues of this photic phenomenons, then we have a new lens called as the EDOF lens. So this EDOF lens, instead of having a multiple foci, actually had a principle in which you had a single elongated focal point from far to near, at least functional near vision, to enhance the depth of focus. This was achieved by 2 different designs. One of them was the induction of the spherical aberration. Some lenses also utilize the pinhole effect. But we have been largely using the hybrid designs in the form of either the Acrysoft VVT, which was a non-diffractive EDOF lens with the wavefront shift mechanism, and also the Technics Pure C now, which has been recently launched. This is basically a refractive EDOF lens. There have been very good studies, one by Dr. Vasavada et al., which have actually looked at the contrast sensitivity loss between when you implant a EDOF lens in a normal eye versus the eye which has early AMD changes. And they could showcase that the retention of the contrast sensitivity was very similar in spite of early AMD profile in these patients, thus showing a good selection for EDOF lenses for patients with early AMD. And similar outcomes were seen by Jeewan et al. When the patients were looked at in the form of having early or low-grade ERM versus when these lenses were implanted in a completely normative, in a normal eye. However, of course, there are studies which have shown dissatisfaction with the implantation of these EDOF lenses. One of the largest series comes from University of Maastricht, from Professor Newitz, and they have actually looked at 73 eyes. Of course, the most common reason for dissatisfaction always remains as residual ametropia. Therefore, what you have heard from Jagdish, to have a very accurate biometry is very, very crucial. But secondary reasons which are drier, which are easily correctable and have to be, of course, looked at. But two important things about EDOF: one is the waxy vision, which happens because of the spherical aberrations, inductions, and loss of contrast in some patients. And the second were the dissatisfied patients without any objective findings. And this were named as expectation mismatch. So expectation mismatch clearly means that these patients were not really offered enough counseling. So just last couple of slides, of course, it is very important to avoid this dissatisfied patients in both trifocal as well as the EDOF lenses. Your preoperative assessment has to be very, very important. And gone are the days when we used to do just a slit lamp biomicroscopy and examination for these patients. Now we have to ensure that they are not suffering from any dry eye. Usually, of course, you have to ensure that the biometry is very, very accurate. Always ensure there is no other comorbidity. So you have to do this by undertaking corneal topography to rule out any irregular astigmatism at the level of cornea, macula OCTs, because there are a lot of eyes which actually may have a very subtle or mild retinal condition going on that you will miss when you're doing just a slit lamp examination for these patients. There is a very nice study, again, published from Bascom Palmer. They have seen that 28% lesions were missed by even trained retina specialists in the let's say, event of having cataract in the eye. And of course, rule out any fuchs with the help of specular microscopy. If you have access, make sure that you look at corneal aberrations and also the angle kappa and chord mu, because this remains as one of the important selection criteria. As important it is for you to understand in terms of the ocular dynamics, it is also important that you understand the patient's personality, to understand what are the requirements from the patients, how is the lifestyle, how much night driving this patient is doing, what kind of profession, is there any micro vision aspect in the form of microsurgery, or the patient is a jeweler. And always make sure that you have realistic expectations, because as we have seen, large amount of these patients with EDOF were actually dissatisfied because of the expectation mismatch. So this is what you have to avoid. So one of the things that we do at our hospital is actually using this DEL questionnaire. This definitely lets us understand patient's expectations and the patient's lifestyle very well. What is patient is able to accept as the, let's say, drawback of this procedure, or as the compromise. Because we always tell patients, whenever it comes to the presbyopia correcting lenses, there is no free lunch in optics. That means you have to sacrifice something or the other. So of course, we do choose the trifocal lenses for patients who are requiring maximum or looking at maximum spectacle independence, and they read a lot up close, but are not really into a lot of nighttime driving. They're motivated patients, but realistic in their expectations. They have accepted that there is going to be halo and glare phenomenon, some decrease in contrast. And but we have to ensure always that they have a very, very healthy ocular surface and the macula. But if the patients are into nighttime driving, are not ready for the nighttime glare and halos, or has any early ocular comorbidities, it is always err on the side of the EDOF lenses, which gives you a very good range of vision and maybe a lot of, let's say, very good functional near vision as well. And they're ready to use a small add-on +1 diopters in this kind of cases. So I'm going to skip some of the cases in want of the time. But I think the most important thing remains is the counseling, because that is the cornerstone of avoiding patients because of the expectation mismatch. So thank you again. Thank you, Pravin, and thank you to AIOC for this opportunity. Thank you.
Thank you very much, Vardhaman. And one question before we move on to our next speaker.
Yeah.
What is one question that a patient, if they ask you, hair stands on end and you say, hey, no, I'm not putting in a multifocal lens or a trifocal or a readoff for this guy or girl?
Yeah, so I think I'll say that patients, when they have the vibe, when they actually say that I want 100% spectacle independence, like like which is perfect, and I'm not willing to use even a small spectacle number for fine activities. I think that's the time when we will not offer them these lenses. Yes,
So 100% is the catchword.
catchword, yeah, for me.
Nice. Dr. Sriganesh, any questions or anything that you would like to add?
Yeah, I think times are changing, patients' expectations are increasing. I'm actually removing more of the diffractive trifocals than I'm putting in nowadays, because there are a lot of so many issues, biometric errors, residual refractive errors, and dry eye, ocular surface, so many issues, macular pathology. And these lenses are being overused without proper assessment, and it can cause a lot of unhappiness. In fact, just last week I exchanged 3 trifocal lenses. So it's, I think, very important to assess the patient. In our clinic right now, we have started doing the trials of custom lens AI, which is a new AI software developed by Milind Pandey from UK. And there you actually put in all the details, the lifestyle of the patient, put in all the diagnostics, and then it does an analysis and kind of gives you a recommendation for what kind of lens would be suitable for this patient. And we've just started that. And then it also shows you, pictures of how the visual quality would be for distance, intermediate, near, night vision. So then it translates to a good counseling tool also, and the patient can have a kind of realistic expectation as to what he can get after the surgery. So this is something we are looking at. But I find that the most satisfied patients are the ones with the EDOF, with the mini monovision, because the human eye is never meant for multifocality. It can't, many of the patients can't kind of overcome this 2 different foci and 2 different images. And though the companies tell you that there is like a 15% light loss in diffractive lenses, if you have like a multifocal and 2 points of foci, 20% loss would be only about 40% for each foci. So at any time for a particular foci, you'll be getting only 40% light. That's why the vision is so waxy, and if there's any small macular pathology, it gets magnified. I find that my happiest patients are the ones with EDOF lenses with a mini monovision, a micro monovision of about 1.25 diopters. Most of them are spectacle independent, and they get neuroadapted very easily, because spherical aberration is something that the patient is used to. The eye has spherical aberration, the brain can filter spherical aberration, and it's very easy to get used to it. And some amount of anisometropia is common in the population. Many of them don't wear glasses because of some. So this is something which is kind of natural, and the patients accept that short neuroadaptation period, unlike the multifocal and diffractive lenses.
Yeah, I know we are running short of time, but I would like to second Dr. Sriganesh's idea of the mini monovision. So one question, sir, if it's like you aim for 0.75 diopters of myopia, or
Yeah,
even up to -5, it's -1. It's only up to
no,
0.7.
depends. See, most of these lenses, now the EDOF lenses would just need about 1 to 1.25 diopters of myopia in the non-dominant eye. I mean, if you can check the dominance, it's fine. Otherwise, always the right eye, the first eye to be done is corrected for distance, because the distance vision is very important for patient satisfaction. The second eye is corrected for slightly for near. We keep a residual target of about -1 to 1.25.
Okay.
And with that, most patients are very comfortable.
Okay.
Yeah,
Thank
just to add one thing, because with the EDOF,
if you don't mind, maybe we should move on. We
perfect.
have about
Okay,
15
perfect.
minutes left and 2 talks to cover. We'll take questions in the end if we have time. So the next topic we have, again, something that probably is not mainstream at all, and is alternate approach to a refractive surprise. And we have Dr. Priyam Gupta from LV Prasad Institute. Dr. Priyam Gupta is a cataract and refractive surgery specialist from LVPI, and she's going to be talking about using a piggyback phakic IOL. Can't be called a phakic IOL anymore in this scenario, for a refractive surprise. So Dr. Priyam Gupta, over to you.
Yes. So thank you. And it is a very big privilege for me to be part of this program and to hear such great talks. And at the outset, I would like to thank AIOS and Dr. Pravin for giving me the opportunity to really speak on this very interesting and evolving topic that is a fake piggyback IOL. And today, through a challenging real world case, I would like to discuss and show how piggyback phakic IOL can be a very effective solution for managing significant post-operative refractive surprises. So this 42-year-old male who was a software engineer by profession actually presented to us with a diminution of vision in the left eye for 2 years. This was affecting his activities of daily living. He was a known high myope in both the eyes with right eye and isometric amblyopia, and interestingly had undergone both eye radial keratotomy as well as a trabeculectomy surgery. And in the right eye, prior to presentation, 2 years prior to the presentation, had undergone a cataract surgery and was using scleral contact lenses occasionally. So in the right eye, post the cataract surgery, his BCVA was 20/100, and in the left eye, it was improving to 20/30. So now we're going to be concentrating on the left eye. So over here, we can see that this gentleman has a superior flat conjunctival bleb with a large superior PI. There are approximately 22 RK scars, and there is a significant nuclear sclerosis with a posterior subcapsular cataract. Other than this, the IOP was within normal limits. There were open angles on gonioscopy, and the fundus was unremarkable. So we decided to go ahead with the cataract surgery in this patient, and we got the corneal tomography done, which demonstrated a very irregular astigmatism and an irregular corneal surface, where the flat keratometry readings were about 17 diopters and K2 was about 33.8. We got an IOL master done for this patient, and the axial length was around 27.45 in the left eye. And because of the flat keratometry readings, the IOL master was unable to pick up the keratometry findings. And from the tomography, we've actually inputted these readings into the IOL master to calculate the IOL power. But again, because of the flat keratometry readings, we were not able to get reliable calculations through the Barrett-Truquet or even with the ASCRS calculator, the Holiday and the Hagees. So even before entering the operating room, we know that the refractive predictability in this eye is going to be poor. So we actually used the SRKT formula and got an IOL power of 35. And to keep him slightly myopic, we chose 38 diopters, which is implanted. So we used a single piece SA6080 through a temporal clear corneal phacoemulsification. This was implanted. And though we took all the precautions, at 6 weeks, we were quite surprised to find that this patient actually on retinoscopy had a power of -11 diopter sphere, -6 diopter cylinder at 175. So let's take a pause here and try to understand that what is the cause of the refractive surprise in this eye. So we know that there are various causes for refractive surprises, which include preoperative, intraoperative, and postoperative causes. But in this patient, these were the possibilities that there was an extreme of axial length. There were 22 to 24 RK cuts, and there was a significant amount of flattening. Because of the flattening, there were also not very reliable IOL calculation formulas which could be used to come up with the power. And we already know that in post-RK eyes, there is again an array of difficulties that we do face while calculating the IOL power because of the altered anterior-posterior corneal relationship. They have a lot of irregular astigmatism. They're prone for more hyperopic refractive surprises, and they also show diurnal variations. Also, intraoperatively, some of these scars can open up, and then we need to take sutures for them. And planning incisions based upon the number of RK cuts is also something which challenges us. So now in our patient, we got a very high amounts of ametropia. So now how do we really tackle this? So these were the following options that we did consider. So conservatively, spectacle correction would not have been ideal for this patient because of the very high residual error that the patient had. And contact lens was again not taken as an option because the patient was not very happy and had previously has had contact lens intolerance. So the next option which can be used in refractive surprises include corneal-based procedures. But again, in our patient, there was a very high refractive residual error, and it was a very flat and in irregular cornea. So again, LVC was definitely not going to be possible in this case. So that left us with lens-based procedures. IOL exchange, again, was not ideal in this case because of the unpredictability of the IOL power that was to be inserted into the eye. And also, it would warrant a lot of intraoperative manipulations. And also, if there is a lot of time which has already elapsed between the primary surgery and the IOL exchange, because of capsular adhesions and fibrosis, it can get further complicated. So the option that we had left with us was a piggyback IOL. And this offers several advantages over the others because it is a reversible procedure. The IOL calculation is much easier because it just depends upon the manifest refraction of the patient at that point of time. There is less intraocular manipulation because the lens is placed in the sulcus, so we are not really touching the primary IOL, and that also leads to less intraocular manipulations.
Deve ter uma sessão anterior à nossa. Bom.
So basically, for the sulcus placement, we know that there are various options which are available. And some of the common ones which are already used are the Sulcoflex and the Sulcofix, which is by the Rayner and the Care Group. But we less commonly, the ones which are not actually considered as a piggyback IOL include the IPCL and the ICL. So now these we know have very good efficacy and refractive stability and good outcomes in patients with phakic eyes in high refractive errors. But they've not really been given or have been used as an off-label use for the treatment of the piggyback IOL. Now, because of its structure, this can be placed in the sulcus and it is stable. And in fact, this also offers more advantages than the other IOLs because this provides a larger range of power that can be corrected, which is for sphere as well as for cylinders. And also because there are various sizes which are available, depending upon the white to white and the ACD, we can actually choose the size that we want to implant. And this also reduces the risk of complications such as vaulting and rotations in the postoperative period. So in our patient, we got the repeat refraction done, and we got the topography and the A-scan repeated and digital measurements. And we ordered an IPCL for this patient. And according to the company's suggestions, a 14.5 diopter sphere with a +7 diopter cylinder at 85 with an overall length of 12.75 millimeters was what was provided to us. Now, this patient actually at 6 weeks did very well and had an uncorrected visual acuity of 20/25. The IOP was 10 millimeters of HC, and the vault, that is the distance between the IPCL and the anterior lens, which was in the back, was around 1 mm. So many reports have been published previously where we have used these ICLs as a piggyback phakic IOL, and they have done extremely well. And the most recent publication has actually come up in the year 2025 in the Journal of Refractive Surgery, where it was actually a literature review which evaluated these phakic IOLs as a piggyback IOLs in 170 eyes and showed that this is a very viable option for enhancing vision and improving patient satisfaction. So I think I just want to end by saying here that if selected well, piggyback phakic IOLs are a very predictable correction option for pseudophakic ametropia, which has minimal intraocular manipulations and excellent visual rehabilitation. So this can truly help bridge the gap between a pseudophakic ametropia and take us towards refractive nirvana. Thank you.
Thank you, Dr. Priyam Gupta. That was an exceptional case, and thank you for sharing the outcome so lucidly. We probably won't be able to take questions because we have time for one talk. And if we have time at the end before the next session starts, we'll circle back for questions. But thank you again. Would like to introduce Another young, excellent cataract and refractive surgeon, Dr. Rushad Shroff. Rushad is a cataract, cornea, and refractive surgery specialist who works at the Shroff Eye Center in Delhi and has done some seminal work in the area of cataract surgery in patients who have keratoconus, an area that we are going to be facing more frequently in the future. So, without further ado, Rushad, over to you for your talk on the subject.
Thank you, sir. Thank you for those very kind words of introduction, and thank you for having me here in this webinar. I'll just share my screen. Okay. Is this visible to everyone?
Not your slides. We see.
Yes. No,
Yes.
it is okay.
The slides are visible?
Yes.
Yes.
Yes,
Yeah.
it's visible.
Okay. Thank you. Thank you. So I'm going to be talking about biometry in cases with keratoconus, and that really has kind of been the holy grail, so to speak, in keratoconic eyes. And the reason that keratoconus is an issue with regard to biometry is that the morphology is a problem. So mild, moderate, and severe keratoconus behave very differently. Mild behaves almost like a non-keratoconic eye, whereas the more advanced it gets, the more difficult the biometry actually gets. So the overview of this talk is that why is IOL power calculation in keratoconus challenging? What are the assumptions in KC that where it violates all the rules of biometry? When do we actually plan cataract surgery? Of course, choosing the right formula, because we have various different formulas, and that is, the crux of getting it right. And a couple of case examples to just take you through that. So, like I mentioned, the morphology is an issue because the astigmatism is very irregular. The curvature is not the same along all the meridians. There's a non-alignment of the visual axis and the steepest portion of the cornea. The keratometry measurements themselves tend to be non-repeatable because either the tear film is unstable, a decentered apex can cause this. These are very often contact lens wearers, which causes warpage, and it's difficult for these patients to take a contact lens holiday. So because of this being a continuum, this is why IOL power calculation is challenging. The assumption that KC violates in terms of biometry is that the refractive index of 1.3375 that we use tends to overestimate the IOL power. The measured keratometry may not be the same as the keratometry in the visual axis, and that can lead to errors in biometry. And these errors are not uniform across the cornea because the meridians has different keratometry values along this. Apart from that, the axial length and anterior chambers tend to be deeper and longer in these eyes, and that itself has been shown to have a bearing on effective lens position. So all of this tends to cause issues in biometry. Typically, there's an overestimation of the corneal power and an underestimation of the IOL target power, leading to hyperopia. Now, when to actually plan cataract surgery for these patients? When there's a visually significant cataract, and the keratoconus should be ideally stable when we're going ahead with a cataract surgery. There are certain preoperative considerations to keep in mind. So, the first one would be contact lenses, the keratometry, the right IOL power, and what is actually the right IOL in these patients. So, contact lens holidays are important to get more accurate keratometry values. The good thing for us is that scleral lenses, which a lot of these patients are on, require less of a contact lens holiday because they do not touch the cornea as such. They tend to vault higher. And you can relax this if the patient is comfortable with their contact lenses. That's one of the most important questions in these patients when you're planning a cataract surgery. So if they are comfortable in their lens, you do not want to put them off their lens after the cataract surgery, so you can be a little more relaxed with regard to contact lens holidays. Now, which keratometry to use? There's often a debate about Scheimpflug versus optical biometers or OCT-based topography and keratometry. Typically, what is seen is, and this paper wonderfully showed this, is that the IOL master generally measures a significantly greater corneal curvature compared to the pentacam or a corneal topographer. And that's important to keep in mind because ideally in these patients, you want to take the lowest K from multiple devices that you're using for measurement to decrease chances of hyperopia. So that is one very important point to keep in mind, that you would tend to use the lowest keratometry values to avoid hypermetropia. Now, looking at the right IOL power formulae, various different formulae have been described in literature. The keratoconus formulae like the Barrett, True-K, and the Kane tend to do very well overall. Out of the older formulas, the SRKT, by virtue of causing more of myopic surprises, tended to do better because it would counteract the hyperopia in these patients. And this was a nice paper in the American Journal of Ophthalmology that looked at severe and non-severe keratoconus and the formulae that worked well in this. Universally, what was seen is that the Barrett keratoconus with measured posterior corneal astigmatism tended to do well in both the groups. The caveat here being that they took severe keratoconus as a value greater than 50 diopters in one meridian in terms of keratometry. So that is not strictly speaking as per the Amsler-Krumig grading. Of course, we see way more severe keratoconus than that. So overall, based on a review of literature, your keratoconus formulas tend to do well as the keratoconus becomes more severe. In less severe keratoconus, because the morphology may be almost regular, you can even get away with something like an SRKT or with the traditional formulae. The Kane formula is another one which is available readily online. It is important to remember that Kane itself is an AI-based formula that does a modification of the keratometry values. So remember that you should not input total cornea values. You're just inputting the anterior K values in the Kane. And the Kane, of course, also has recommendations as per the target refraction based on the keratometry. So if the keratometry is less than 48, which would be a mild keratoconus, aim for the actual value given by the formula. If it's 48 to 59, they recommend between minus 0.5 to 1, and anything greater than 59, about a minus 2 to 2.5 diopters of myopia. The Barrett True K keratoconus is also a good formula. It's based on the double K method, and the keratoconus modification actually helps to give good results. Now, regarding IOL selection, normally the cornea is has got a positive spherical aberration. In these cases, there's a negative spherical aberration. So you'd want to take an IOL that has a zero spherical aberration, ideally, to not worsen the negative spherical aberration from the cornea. Pinhole lenses abroad have been in vogue for keratoconus, and they tend to do well. However, these have not been available in India. And it's better to avoid things like a multifocal IOL because the cornea is very, very irregular. While considering toric IOLs, important to check whether a patient is using scleral lenses. If they're happy with it, do not go ahead and do a toric IOL. Otherwise, you'd change the axis of the astigmatism. Always tell a patient that it's a debulking procedure and you're not promising them spectacle independent or contact lens independent vision. And it's always important to underpromise, over-deliver, and counsel regarding the possibility of an IOL exchange. Now, this case example very nicely illustrates what I wanted to highlight. This is a fairly severe keratoconus with a Kmax value of 62 diopters. I put IOL master values at two different time points, and you can see here that there's a variability in the keratometry values from 57 and 63 to 53 and 56. You would generally choose the one, like I was saying, with the lower keratometry. So that was the one that we chose for inputting in the various calculators. The Kane, as you can see with the keratoconus modification on, it gave us a value of about 4 diopters with a target refraction of -2 because this was a severe keratoconus as per the Kane. That was our rationale for targeting this. With the Pentacam data, again, it was fairly similar. It came to 4.5. The first scan was with the IOL master data. The Barrett keratoconus with the predicted posterior corneal astigmatism showed us a value of about 2.5. And when we did with the measured PCA, that can be input. Now you have this on the Barrett online calculator where you can actually input this data. You can either choose measured posterior keratometry values of the cornea on the Pentacam or the IOL master and input this. And again, it showed us about a +3 diopter lens. Again, with the IOL master values, with the predicted PCA, it was fairly similar. It was about 2.5. And with the measured PCA with the IOL master, it went to about 3. Just showing you that you should take information from multiple devices before actually going ahead. Now, this is a case with the other eye of that same patient with even more steep keratometry values. So the Kmax has gone to 77 in this patient, and he wasn't keen on getting a transplant, which is why we were doing this. In these kind of cases, the calculators, you can't actually input the data. So the maximum value in the Barrett is 60 diopters, and in Kane is about 65. So you would have to then switch to standard case, which is using 43.25, which is what we did, as this patient was happy to use his clear lenses later on, and we implanted a plus 13 diopter. So we implanted a plus 4 non-toric in the right eye and a 13 in the left eye. The right eye did pretty well with a residual cylinder of 1.5 diopter cylinder, and he almost achieved 20/20 vision. The left eye actually had a little bit of a myopic refraction, but he was okay with that. This is just to summarize our results, and we've seen that with the Kane and the Barrett, across keratoconus plate, these are our values that we've got with regard to our residual errors, and we've been reasonably okay. Of course, nowhere near as good as a normal eye, but reasonably okay in terms of our results. So to summarize, the standard approach leads to hyperopia, always target myopia in these patients. A rapid acquisition biometer, which causes less variability from the tear film, is important. Compare multiple keratometry values, choose the lowest measured K. For mild keratoconus, any of the formulae do well. For severe, up to about 60 to 65, you can use the Kane and the Barrett. For very high keratometry values, standard Ks are more important. Target myopia, not only because it's important because of the hyperopic shift, but also because it's more useful unaided vision, and it's easier for them to input and fit their contact lenses if they have some amount of myopia. Under promise and over deliver, and remember, contact lenses are the best ally. Thank you so much for a patient listening.
Perfect. That's again a wonderful talk, Rashad. Thank you for telling all of us the best way to calculate an IOL in a patient with keratoconus. And like I said, this is a scenario that is going to become more and more common in the near future. Thank you very much. Before we close, wanted to invite Dr. Sri Ganesh for any comments about any of the talks. I know that we are slightly over probably, but a few minutes
I'll keep
of your
it short.
time.
Yeah. So I think wonderful talks regarding the new advances and how to attain refractive nirvana. Nirvana probably is attainable in normal cases, but when it comes to cases like RK or keratoconus with irregular corneas, then it's not only the biometry and formula, but we also need to look at different types of lenses. You don't have the pinhole intraocular lens in India as yet, but we can do a pinhole pupilloplasty. That's what we do for irregular corneas, and this gives us good results. Aim for about -1, 1.5 and do a pinhole pupilloplasty, and that gives good results. So overall, I think it's very important to take all factors into consideration and plan the surgery, take the patient's expectation and lifestyle also into consideration, use newer diagnostics, technology, newer formula, and I think we will get there one day.
Thank you very much. And thanks to all the speakers on this session, Jagdish Reddy, Eric Rosenberg, Vardhaman Kankaria, Priyam Gupta, and Rushad Shroff. Thank you very much for all your wonderful talks. And over to you, Rolika and Sonam, for the next session. Thank you.
Thank you, sir.
Thank you so much, sir. Thank you very, very much for a wonderful session.
Shall we have a group picture, Norika?
Yes. Please go ahead, take a screenshot.
So thank you so much for your attention and for the speed of this.
I'm somehow not able to take a screenshot.
Don't worry, we can take a screenshot of the session. We can go back into it and take it. Don't worry.
Great.
Yes.
Thank you so much.
Thank you, everyone. So we have with us the next session, Dr. Titiyal, sir. A very welcome to you. And over to you, sir.
Yeah, thank you. Thank you so much, Rolika. I think we're just going to start this session, and I see Dr. Boris already there. Good morning, Boris.
Good morning. Good morning.
Seeing you after a long time, looking good.
Yeah, thank you.
Yeah, I think this particular session on premium IOLs is going to be very exciting. We are looking for bettering the optics of these IOLs, benefit in terms of quality of vision through these lenses, and make their quality of life also better. So today we have to cover all these areas of recent generation intraocular lenses, various situations, and we have gamut of international and national faculty for today's program. I see Dr. Nanavati also there. Good morning. And I will invite our moderator, Dr. Parinita Sahai, to introduce faculty before we start the talks.
In the meantime, good evening, everyone. I would like to share the slides
Yeah.
for the current session.
Yeah, go on.
Until we have Dr. Pranita with us. So this is our session for today, Premium IOLs, headed by Dr. Jeewan Titiyal, sir, co-chairing by Dr. Rohit Om Prakash, with convener as Dr. Namrata ma'am, moderated by Dr. Pranita Sahai. And we have with us some wonderful panelists, Dr. Manpreet Kaur, Dr. Praful Maharana, Dr. Sridevi Nair, Dr. Shail Vasavada, and Dr. Tushya Om Prakash. So over to you, Dr. Pranita, without wasting further time, since we're right on time, it's 6 o'clock. And we have a couple of wonderful speakers with jam-packed schedule.
Thank you, Dr. Anu. Thank you, Dr. Titiyal, for inviting me for this session. And without much delay, I would like to invite our first speaker, Dr. Professor Jeewan Singh Titiyal, sir, who's going to give us an overview of the premium IOLs. We all know Professor Titiyal is the current president, and he is the current president of AIOS. He's a senior consultant at the Agarwal Eye Center in Delhi. Was the former chief at RP Center, AIMS, New Delhi, and has over 400 publications, multiple citations, over 6 books published, more than 50 orations and keynote addresses, and he's among the top 2% of the most cited researchers in 2021 onwards, ranking in the ophthalmology in India. According to the Stanford University list of top 2% most cited scientists in the world, he has 2 patents to his credit and multiple international awards that he has achieved, including the Service Award by the Asia Pacific Academy of Ophthalmology, the Senior Achievement Award by the American Academy of Ophthalmology, and APO. And he's the first Indian to perform a live surgery in ACRS in USA itself. He has national honors, including the Padma Shri by the President of India, and in 2014, and the P. Siva Reddy International Award, which he received by AIOS in 2021. And with that, I would like to hand over the task to Sir for his presentation on the overview on premium IOLs.
Thank you. Let me share my talk. Yeah. Yeah, thank you, Pranita. Can you see my slides?
Yes, sir. Yes, sir. We can see it.
Thank you again. I'll be very brief because these would be subsequently covered by various other speakers. No financial disclosure from my side. As far as intraocular lenses are concerned, I consider they are the vision changing after cataract surgery with their invention. Today, we are looking for a minimally invasive and safe implantation of these lenses with enhanced visual outcomes, especially looking for making people least spectacle dependence, if possible, and customizing these IOLs with the patient needs. New generation IOLs, you can say they have definite advantages. We're looking for a greater independence to the spectacles, improved quality of life, customization as per the patient's requirement, definitely a better visual outcome with the newer, digital lifestyle now for our patients. But these lenses do have their own disadvantage also. They are with the higher cost, sometimes not covered by insurances. The visual side effects are still there: halos, glare, sometimes difficulty in the night vision driving. Patient selection therefore becomes a very critical, because some of the premium IOLs may not be suitable for some of the patients. The term neuroadaptation is also true with these newer generation lenses. There's a definite period for people to adjust to these lenses with a neuroadaptation. So if you look into a key consideration before we look into these implantation of premium IOLs, will be a good ocular health, especially ruling out patient with the posterior segment disorders like macular degeneration, glaucomatous field defects, or a patient's lifestyle where patient maybe a night drivers or a reading maybe their actual profile of their profession. Expectation of patient is very important to understand. If look into these considerations today, if I can summarize, the best all-rounder is EDOF IOS, the extended depth of focus lenses, which balances the quality of vision and very fewer side effects. If somebody wants the best reading glasses, then maybe the newer generation trifocal lens may be better for these cases. For a precision, maybe if possible, light adjustable IOLs, if it is available for everybody with low cost. And for our toric lenses, which are the compulsory composition with the newer generation IOLs as such. But looking into monofocal IOLs, I think the remarkable achievement is very nice MTF after implantation with a very nice mesopic contrast with these lenses. Excellent distant visual acuity, minimal visual disturbances. But these lenses do have disadvantage of patient requiring glasses all the time. But there has been a sea change in their IOL designs and materials in the past many decades, right from the preventing the occurrence of visual axis opacification. The square edge design, which came in 1995, textured or optic edge by Hoya lenses to reduce the photic symptoms. Then, more importantly, recent times surface modification like UV ozone treatment with Hoya Vivinex lenses. Heparin surface modification has been there to decrease the inflammation related to these IOL surface. So this is evidence that this modification has really given the uh, decrease in the PCO formation with the sharpest IOLs. Hydrophobic materials have definitely lesser PCOs, therefore less requirement of YAG capsulotomy in immediate few years of implantation. This is one publication from my student where she looked into a heparin surface modified lenses and diabetic patients, and we found that these lenses do give a lesser inflammation intraocular and lesser deposition in the lens surface also, and less PCO. This is a study we conducted in patients who undergone Vivinex Hoya lenses with a posterior surface ozone treatment to enhance the attachment of the posterior capsule towards the posterior surface of IOL. And we found that as time passes, the PC optic opposition increases. You can see at 2 years, we had a 75% PC was opposed to the optics posterior surface of the IOL. Therefore, this would decrease the chances of PCO formation. In fact, we had around 7% of cases having a PCO. Of that, all of these patients had non-adherence of a posterior capsule to the optics of IOL. This indicates that if you have the opposition of a posterior capsule to the posterior surface of the IOL, the visual quality is also better, and the requirement of YAG capsulotomy is almost nil in 2 years. Now we have at least 5-year study, and actual YAG capsulotomy rate is very less. So these modifications would definitely enhance the visual axis clarity for long term. There has been various filters incorporated in IOLs, right from the UV blockers to blue blocking IOLs. Now we have violet light filtering chromophores in Technis lenses. They all are designed to increase the contrast and decrease the long-term the damage to the posterior segment macular areas also. We still keep seeing IOL opacification, especially with the hydrophilic lenses, and they require subsequent challenges to remove them. This is one of my case where Patient had the hydrophilic lens, and post DSEC surgery, with the interaction of air bubble with the surface of IOL, it gets opacified. So we have to be very, very clear which type of lenses to be chosen in these cases. Silicon lenses, again, they have a surface haze. The Acrosoft lenses had the issues with the surface of haziness coming, both anterior and posterior surface of the IOL. A lot of glistening with these lenses, which we have seen here in this particular slide. If you see, this is the glistening which was visible in the Acrosoft lenses, which increases with time sometimes. And this is the haze which we have picked up in a lens. In fact, as time passes, you can definitely say how many years back this IOL may have been implanted inside the eye also. Therefore, they came with a new material, which is now a clear on lenses with a decreased chances of glistening and surface haze. This is a multi-centric study published from India, where we found that at 1 year there was no glistening in these cases, and the PCO was also not there in these cases. None of the patients required YAG laser capsulotomy, and good MTF values also. The material-wise, there has been a sea change, improving the quality. While the optics-wise, there has been a concept of premium IOLs to improve the optimal visual quality. Toric lenses, if implanted correctly with the image-guided systems, the quality of vision is far better than the manual marking in these cases. I think all multifocal cataract surgery had changed the EDOF lenses would require the toric lenses as such. If I say this is the requirement of trifocal lenses to be used, if they are right. Surgery wise, again, as I described earlier, all trifocal lenses or ERB lenses has to be perfectly placed. Therefore, if you have access to a femtosecond, I'll just shift to the next slide because this is second laser. And if I summarize the initial my presentation, would monofocal lens would be there, or the modified monofocal plus lenses would replace the trifocals EDOF lenses? I'm not sure. This may be not true. I can say modified monofocal lenses definitely will replace the monofocal aspheric lenses, but trifocal and EDOF lenses are their own space as such. The recent concept of using monofocal plus or enhanced monofocal lenses are there for most cases, but they're always looking for those patients where you have the diabetic retinopathy or a patient with glaucoma. Would these lenses be there suitable in these cases also? That's a question mark. We have done a study recently where we looked into outcomes of these lenses with the J&J enhanced lenses in diabetic retinopathy patient without maculopathy or a patient with glaucoma without the field defects. And we found that the results were quite good. The MTF values, the color contrast in diabetic patient was good as a normal monofocal lens in these cases also. But there has to be study to look into its role in a patient with a treated maculopathy patient or a patient with some sort of defect in a glaucoma fields. That would be the challenge which we going to face because large number of patients will be there, and these lenses may work or may not work in these areas also. My last few slides on I know which are going to be a future talk of some of our presentations. This is how we are looking for today. We have three definitive IOLs to be provided to our patient. You have a enhanced monofocal IOLs, EDOF IOLs, or a multifocal IOLs. The first thing we are looking for today is intermediate vision. And we know that multifocals and EDOF lenses will provide better quality of vision. Same is true with the contrast also. If you have multifocal, contrast goes down, monofocal with the highest contrast. So any patient who requires a better contrast, like a night drivers, maybe you should opt for either monofocal lens enhanced or a EDOF lens rather than trifocal lenses. The night vision is also very important consideration. Same thing with the contrast in these cases. Patient satisfaction depends on how well you have counseled your patients. Now we have the standard monofocal lenses as a baseline, and if you compare them with the newer generation EDOF lenses like Acris or BVT, definitely intermediate vision will be better with these EDOF lenses and better acceptance. The POC IOL from J&J, which is also EDOF non-diffractive full optic lenses, has the advantage of lesser photic symptoms, better quality of vision for a near and intermediate also. Binocular implantation with little micro monovision, patient can see N6 for near also with good quality of vision. Now they have enhanced their Technis Synergy lens to a Technis ODC lens, which has a better, excellent light transmission. The light transmission in ODC has increased up to 97%. Similarly, the Panoptics from Acrisoft lenses are coming out with the Acrisoft Pro, which also has increased their light transmission, and they have realized that all these multifocal lenses would are definite challenge with the poor contrast, and that has to be improved to get a better night performance. So I would understand today if you have summarized the entire patient selection flow chart, it depends what is the patient's requirement, what is the comorbidity. Accordingly, you have to choose the lens per se. To look into a night drabus, maybe a monofocal plus or a EDOF lens will be required. Patient with a compromised ocular comorbidity like diabetic retinopathy, then you have to go for either the enhanced monofocal or the pure aspheric monofocal lenses. The future is definitely going to change with definitive customization of these lenses, with looking into a total refractive apparatus of one particular eye and customizing them to a personalized way of manufacturing these IOLs. I think this summarizes my talk, and thank you, Panita.
Thank you so much, sir, for that comprehensive overview. I think that's a good start for this session, and with that, we'll be able to carry forward the discussion. If we have any comments to ask from sir.
We can have, as the next presentation goes on.
Okay, so our next presenter is an eminent speaker who's going to be talking about IOL selection in keratoconus patients. And for this important topic, we have with us Dr. Mayank Nanavati, who has already joined here for the session. He has an FRC of and a PhD from London, has done an MRC of, and he's working as a senior consultant at the Brighton and Sussex Medical School in UK. He is currently the Honorary General Secretary of the UK and Ireland Society of Cataract and Refractive Surgery, and is a section editor also for iJournal, and he has various association with the Royal College of Ophthalmologists, including as a scientific committee member, as an examiner for the Certificate of Laser and Refractive Surgery. He is also part of the National Cataract Workforce Committee member at the Royal College of Ophthalmologists, and has received various awards from the American Academy of Ophthalmology, and also is an editorial board member for the International Journal of Keratoconus and Ectatic Corneal Disease, which makes him just the apt person to talk about the IOL selection in keratoconus patients. With that, I would like to hand over the dais to Sir for his talk on IOL selection in keratoconus patients.
Thank you so much. Can you hear me?
Yes, sir, we can.
Can you see my presentation?
Yes, we can. And if you could make that full screen. Yeah.
Yeah.
That's perfect.
Is it okay now?
Yes, sir.
Yeah. Thank you, Professor Sharma and Professor Titiyal, for your kind invitation. Thank you, AIOS, for inviting me to talk. My job today is to give you an overview of intraocular lens selection in keratoconic patients. These are my unrelated financial disclosures, but I may talk about some of the technologies which I've worked with. So the agenda of my talk is to give you a brief about what happens in keratoconic patient when we decide cataract surgery, what biometry should be used as of today. It will change after 6 months or a year, what lens options we have as of today, and the decision framework we have. So this presentation basically is an overview of our own publication, which was published early this year. You can refer to this publication if you have any other details to search for. So why keratoconus complicates lens selection? There are simple things which complicates the IOL power selection. One is the irregular astigmatism, progressive ectasia, a thin stroma, and unpredictable refraction. And we know that 1 in 2,000 patients walking into a clinic will have keratoconus in general. Our cornea clinics are full of them, actually, as you already know. And 15 to 30% of these keratoconics will develop early cataracts. The jury is still out on why they do develop early cataracts, and they do have up to 4 or 5 diopters and sometimes even more of astigmatism based on where the cornea is.
Now, the basic principle of the IOL power calculation is based on how it works, basically. So basically, you know that keratometry measurements are quite essential, and in keratoconus, keratometry measurements are not as precise, and therefore it overestimates the keratometry power, which means it makes the lens power slightly on the myopic side of the diopter in terms of selection, and therefore you end up with hyperopic surprise after the procedure. So what is the keratometry method which is more accurate? The standard keratometry, which was used in the past, overestimates the K reading. It ignores the posterior corneal surface and is not suitable for moderate to severe keratoconus. For mild keratoconus, you may get away with that. But tomography-based device or OCT-based devices, which are popular nowadays, gives you the full total corneal power measurements, which will mean that you'll get an anterior and posterior corneal measurements in these patients. And therefore, they are more preferred in ectasia patients and in patients with irregular cornea of any kind. Now, as of today, Kane keratoconus formula is considered to be the best for keratoconus IOL power selection. Abulafia and Koch adjustment will be probably next, and Haigis and Barrett's 2K are still okay, but avoid SRKT. But best choice will be Kane keratoconus formulas. In future, the AI-based formulas will be taking over, and these are just based on the evidence as published of today. As I said, actually, this may be completely different in 2 years' time because AI is taking over most of our diagnostics. Regarding the lens selections, Professor Titiyal has given a very nice overview of the lenses available in the market for keratoconus. Monofocals or enhanced monofocal will still be the best choice. You can get away with EDOF lenses such as POCs in mild keratoconus, but generally speaking, monofocals would be the safest bet. Now, toric lenses, it's a debatable issue. We have published on this, and I'll be sharing my publication in the next slide. But basically, the aim here is to correct the astigmatism, which is regular. If the patient has regular astigmatism in the center of the cornea and has got mild and stable keratoconus, then you can certainly use toric lenses. But the prerequisite here is the patient should have a history of best spectacle corrected vision of 20/40 or better. So if the patient says my vision was never good with glasses in the past, then they are not a suitable candidate for toric lenses because toric lenses will not give the same quality of vision as they achieve with the contact lenses. Of course, the risk of rotation, abrasions, and keratoconus progressing in future will apply to these cases, so stability is important. And this is what we published in past outcomes of our own patients, but key take-home message is ask the history to the patient. Was the vision better with glasses in the past? And if the answer is yes, then only the toric lenses are likely to give you a desirable outcome, but still they might need some correction. Also, I've learned over years that you work with the optometrist who's dealing with the contact lenses for these patients, because if they've got very high astigmatism with slightest misalignment of the toric lens, they can get huge visual issues. So it might be best to just use the non-toric versions of lenses and ask them to go back to the contact lenses they were using after the surgery. What about multifocal and EDOFs? Generally, they're contraindicated, but in very mild keratoconic cases, and if you're confident about the outcomes and spectacle corrected vision is better, then you can obviously use an EDOF lens such as a POC. What about cross-linking? If the patient has got history of progression and is still progressing, then cross-linking is essential. We do epithelial off Dresden protocol at Brighton, and we wait for at least 12 months following cross-linking, have at least 3 visits with pentacam scans and tomography scans to just make sure that nothing is progressing, and then we embark on the cataract surgery in these patients. What about the post-operative rehabilitation? For mild keratoconus, you can have glasses. They do well with glasses for near and also for distance. If there's mild residual astigmatism, moderate ones can tolerate up to about plus or minus 1 diopters, but glasses, contact lens will still be an option. But the key here is to work with the optometrist to ensure that you have given the right choice, and if they need a contact lens later, it will be the best choice. Again, this is IOL selection algorithm. The key take-home message is ask about the spectacle corrected vision before the cataract development, as they will not achieve the same vision as a contact lens. This is a key evidence summary, which I've just mentioned. So K in keratoconus formula still remains best as of today. I'm emphasizing that because that might change. And post cross-linking, you have to wait for at least 12 months for that to be stable and avoid multifocal lenses. Again, this is the paper, which if you want to refer for further details, there's a QR code for scanning. It's freely available online. We also developed a web-based tool in Brighton. This is our own tool, very complex. Actually, I'm not expecting you to read this, but basically this is translated into a freely available software for any juniors who want to,
as you see here, this is
who want to refer to this. Basically, it gives you a kind of live map, and you can select what kind of patient you have, and it will show you what options the patient has based on cataract, when you do the transplant, when you remove the sutures, when the astigmatism becomes regular or irregular, and whether you want to offer any options apart from lenses such as excimer laser treatments in these patients. I'm not going to go through the demo of that tool because that's freely available online. This is the publication of that algorithm I've just shown you. And this is the QR code to use that algorithm. It's completely free to use for anyone across the world. So key take-home messages: use tomography or OCT-based biometry, apply the latest formula, keep knowledge updated because the formulas keep on changing. They will change every 2 years. Monofocals are the best, and counsel the patient about realistic expectations. Thank you so much.
Thank you so much, Dr. Mang, for giving us that wonderful overview. Obviously, IOL selection is always a challenge in keratoconus patients, whether to go for toric and non-toric, and you've beautifully highlighted all the points. Sir, would you like to make any comments? Dr. Titiyal, sir?
Yep. Can you unshare your presentation? Yeah, thank you so much. I think it was a wonderful, the brief, algorithm to how to go through in these keratogenic patients. You rightly pointed out if you have a mild to moderate cases, the things are quite simple. Like most formulas might give you some sort of achievable post-op refraction in these patients. But difficulty comes with when you have a very advanced keratoconus, people who have had a very poor, as you rightly pointed out, the visual acuity before they develop cataract in these cases. Totally dominant on contact lenses. So sometimes what I have done in these very advanced keratoconic eyes, because I know that they have been using contact lens for a very long time, I normally go with the uh, surgery with a simple monofocal lens and leave everything to the contact lens subsequently because they are well adapted to contact lenses. And that I think is a very important point because the best visual acuity will come with contact lenses in these very advanced keratoconic eyes. The one thing which we always talk about to look into central 3 millimeter or 2 millimeter EKR values, use that as a guideline to select the keratometry. So sometimes even that is also very challenging in these keratoconic eyes. So I keep telling my patient, okay, there'll be a huge surprise and you still may have to use glasses if possible, otherwise go for contact lenses. But it is I know, difficult task to achieve a good outcome in this case. But as said, these patients are very poor in this optics. So whatever we do, they are not going to get a very sharp vision. But I've seen patients benefiting with the cataract surgery as such by decreasing the load of refractive error and subsequently doing a little bit of a spectacle or a contact lens care. Okay. Thank you. It was a wonderful presentation, Mayank.
Thank you so much.
Thank you so much, sir. In paucity of time, we'll carry forward the discussion later. And next, I would like to invite our next speaker, who's an eminent speaker and is going to be talking about clinical insights into Vivinex Geometrics and Vivinex Impress IOLs. Dr. Sergio Quito, who's a master's and doctorate in ophthalmology at the Polis Eye Hospital in Medicine, at the Polis School of Medicine, and his specialization in the cornea at the University of Southern California, Downey Eye Institute at Los Angeles. He is also an advisor in the for cornea external eye diseases and a cataract department at the Hospital de Clinica de Porto Alegre. He's a postgraduate professor of the surgery discipline at the URFGS and partner director and co-founder of the Ophthalmo Centro. Has multiple books, multiple papers published in national and international journals, and he's an editor of 3 books in ophthalmology as well. He is a member of the editorial board of 6 national and international ophthalmological journals and coordinator of the Cornea Commission of the SOBLEC, which is the Brazilian Society of Contact Lens, Cornea and Refractometry. He's been the past president of the Brazilian Cornea Society, and various innovative techniques, that is the mix and match technique of IOLs, which is practiced by a lot of us, was initially given by Dr. Sergio Quito. With that, I would like to hand over the dais to Sir for his talk on Vivinex Impress and Vivinex Geometrics and Vivinex Impress IOLs.
Thanks a lot for your kind invitation to share our experience with you with Hoya, Geometric and Impress IOL. Can you see my slides?
Yes, sir. If you could just make that full screen. Yes.
Okay, so I'm gonna tell you why it's not going forward.
So just click on the screen and then yes, it's perfectly
yeah. Okay now. So why I choose now pairing approach? So I started my journey 20 years ago with the multifocal IOLs, mixing the IOLs, because we didn't have a nice IOL to achieve very good vision in all distances. So we started with back in time with Resume and bifocal techniques, and then we mixed with other technologies, including EDOF in one eye, in the dominant eye, and with the bifocal in the other eye to achieve very good vision in all distances, also with Symphony and Vivity, and then also with trifocals. The first trifocal we had in Brazil in 2016 was the Panoptics, but some patients had not a very good near vision and they needed more light to see clearly in near vision. So I kept mixing with a bifocal in the other eye. So I did this with all other trifocals we had and still have in Brazil. And in October 22, we had the chance to start implanting the Hoya trifocal, the geometric trifocal here. And I started mixing with the one that I knew that the near vision is excellent. It's a Technis ZMB with +4 add. And then I started to see that patients with geometric had also a very good near vision. So I didn't use ZMB anymore. Recently, Johnson & Johnson launched the Odyssey here in Brazil, and it's a great lens, but still many patients complain that the near vision is not as good as other trifocal like geometric. And in some cases, I had to mix this Odyssey with the Geometric Plus. I'm gonna just tell you what is Geometric Plus in a minute. So in June 23, we started implanted here in Brazil the Geometric Plus. So it's the same platform that you already know, the Vivinex from Hoya. The add is exactly the same, 3.5 in both lenses. The difference is the energy, the light energy distribution. So I always chose the dominant eye for far and the non-dominant for near. And I still do this. The Geometric Plus gives 10% more energy for near, so I always prefer to implant the Geometric Plus in the non-dominant eye, but there are some papers, some published papers saying that this is not necessary anymore. So what's the difference between Geometric and Geometric Plus? So Geometric IOL gives around 22% of light energy for near and 50% for far. And Geometric Plus increased from 22 to 32% for near, so 10% more light energy for near. So at the end is exactly the same, but the energy distribution is a little bit more. So this 10% came from the far. So a geometric delivers 50% for far and geometric plus 40 and more energy for near. So the light energy distribution profile is a little bit different because of the height of the rings. So the add is exactly the same. And with this, these patients have a much more comfortable reading tasks. So when we combine in both eyes, it's like a mix and match, but with the same platform from Hoya. So they call pairing approach. So in this situation, we have very good vision in all distance. So geometric for far, intermediate, and also for near, but the plus IOL delivers more energy for near vision and a little bit less for far. So this is a great combination, and that's why I currently choose this situation. So my experience with geometric, all patients, including mixing with some other IOLs, is 160 patients. And the spectacle independence is very high, around 95 for far and 81 for near, and 92% of satisfaction. When I compare both groups, one group that I implanted geometric, no geometric plus, no other IOLs, just geometric in both eyes. So this was 58 patients, 96% of spectacle independence for far and 81% for near. So you can see in some patients I had to prescribe reading glasses with 96% of satisfaction. If we analyze J2, we increase 81% to 96% of satisfaction. So it's a very good satisfaction index. But when I implant geometric in one eye and geometric plus the other eye, pairing approach with 25 patients, I can see that the near vision increased a lot, 100% instead of 80%. So much better. And this is not a better J1 vision. Of course, as in all trifocals, we need normal eye, precise biometry, precise surgery, and we can expect less eyeglass independence. But the patients have better reading speed, better comfortable reading, less light dependence. So this is pretty good, and less tiring along the day. So this is a very excellent option to correct presbyopia. The injector, you already know, it's very easy to use. I'm not going to go with this because it's the same of Vivinex. And to conclude, the Vivinex Impress is a monofocal plus, the same platform that has this concave up and concave down inflection areas in the 2.0 millimeter central millimeters that extend a little bit the focus so the patients have a better intermediate vision. So you can see here comparing with a monofocal into the focus curve. And when we compress to the eye hands, Impress delivers a little bit more intermediate vision. So I'm very, very satisfied with this platform. It's the same thing, the time is up. So I'm just conclude telling my experience that many patients are glasses independent, even with the monofocal plus. It's not EDOF, it's almost EDOF. Of course, we have to analyze pupil, astigmatism. And when we do a mini monovision, plano in one eye and half a diopter of myopia in the other eye, many patients achieve J2, J3 without glasses. So this is my experience in these patients that we had performed hyperopic LASIK. This is a very nice lens too. So it's a nice option as a monofocal. It's still monofocal, but it can reduce glass independence for far and intermediate, with the advantage that these patients have no halos and glare. So thanks a lot for your kind invitation and for your attention.
Thank you so much, sir. Thank you so much, sir, for beautifully highlighting all the important points of when to select which IOL. And are there any questions, sir? Would you like to raise any comments?
No, it was very beautifully presented, Sergio. The results you have shown us actually, it reflects the advantage of this, geometric plus for near, which was little, earlier desirable from these trifocal lenses. We was trying mix and match, mini microvision in these lenses. With this new concept, people had done so well. Just for my experience, sometimes, the first try, normally I go with the, geometric lens. If patient is happy with only geometric for distance and near, but second eye, you can go for either geometric or geometric plus. Both combination can be given, but with geometric plus, patients are much more happier because it gives you both the advantages. And I've not seen patient complaining of halos and glare. In your series, there were less than 3% cases, and that is what I've seen also. Hardly any patient which I have complaining of halos, which is quite common with the full optics lenses sometimes. I think the lenses are very good. Any other comments?
Yes. Since geometric has only 8 rings, so it delivers less halo and glare. And I prefer to start with the geometric plus, so the patient has the wall factor for the year.
Okay, thank you. Yeah, Pranita.
Thank you so much, sir. In paucity of time, we'll continue with our next speaker, who is Dr. Gaurav Luthra, sir, who's going to be talking about the extended depth of focus IOLs. How do they help? Dr. Gaurav Luthra, sir, is a director at the Drishti Eye Institute in Dehradun, Uttarakhand. He's done his post-graduation from Maulana Azad Medical College. He's also an honorary FAICO. He has held various important positions in the past, including that of President of IRSI, Honorary Secretary of the Uttarakhand Society of Ophthalmological Society, Member Scientific Committee of AIOS, and Co-Chairman of the Trade Relations Committee and Grievances at AIOS, and President of the Dehradun Ophthalmic Society, and various other positions. He has various publications in peer-reviewed journals. He's an excellent cataract surgeon and has performed live cataract surgeries at various platforms. With that, sir, I would like to invite you for your talk on EDOF IOLs.
Thank you, Dr. Pranita. And I'm happy to see Boris, my dear friend. And thank you, Dr. Titiyal, sir, and hi, Rolika, and everybody else. I'll just share my presentation. Hopefully. Yeah, okay. Okay. Is it there?
Not yet.
Not yet. I don't know what all it's showing. I'll stop sharing and maybe I'll come back.
Oh, nice.
You can make that full screen, sir.
Yeah, I was trying to do that. Is it better now?
Yes, there's full screen now.
You have the full screen. Hi, Dr. Namrata. Thanks for including me. Yes. Okay. So I reworded it because I thought I can best share my experience with some of the new EDOF IOLs, as Sergio shared with his IOLs recently with the geometric Hoya. And let's see if I can move this forward. Okay. So I think this session is on premium IOL, so I don't have to really talk a lot about this, but patients' expectations have been growing over the years, and because of a lot of refractive surgery being done by cataract surgeons as well, they obviously feel that our clinics advertise spectacles freedom to a large extent, and they assume that cataract surgery also, and rightfully so. We have been able to, with all the advances in biometry and IOL selection, and lots of improvements in IOL power calculations and our surgeries, we do bring a lot of good spectacles independence to majority of our patients. And I most often get to hear that when you tell them about some of these premium IOLs, that my neighbor got operated last month with a very basic surgery at a very basic hospital, doesn't wear any glasses. How come I have to pay so much for a premium IOL and still not get, like, if you tell them some of the limitations, they are not too happy to hear them. And many of these cataract patients will actually be surprised when you tell them that to be able to read, you'll need a special lens, because they say that right now I can see my phone and I read everything without glasses prior to cataract surgery. So it becomes a little difficult to explain, and I think building the right expectations is so important. And of course, most patients want to see well for all distances after surgery. And yes, modern trifocal and continuous range of vision lenses like the Geometric and the Odyssey and the Symphony, sorry, the Synergy and the Panoptics, they've all made things so well, but then with all those limitations, because nowadays, in fact, you do have some patients walk in, and the moment you start talking about IOLs, the first thing they say is, "But I hope you're not going to put a lens with those rings." I don't know where they get to read about it, but even before you say anything, they've already told you that they are wary of getting any lenses with those diffractive rings over there. Of course, I do use quite a few of those anyway, but people who need great good near vision, they will do well only with those lenses. But I think intermediate functional vision has become even more important than the near, with our dependence on computers and smartphones, and intermediate vision has really become the predominant thing. So we obviously cannot implant, diffractive multifocal lenses in all patients. Many of them will be wary of glares and halos. Some of them do a lot of night driving. There will be other pathologies, macular pathologies and corneal pathologies and glaucoma and other things which will preclude use of multifocal lenses. And we do have an increase in the number of our multifocal implants as well as of the EDOF lenses in the last few years. And almost 50% of our patients do get one of these implants now, because of wider acceptance and improvement in the quality of lenses that are available. So, as I said, that there's these fears that the patients have, but they really want good distance vision, and they also want good intermediate vision. And many of them actually won't mind. Now, if you counsel them, they will not mind wearing a small par for fine print reading at close range. I think the market for presbyopia correcting IOLs is rapidly growing, and even the enhanced monofocals have really made things good, because many patients who were previously getting monofocal implants now are able to get some kind of functional intermediate vision as well. And I think the new generation EDOFs have really filled a big gap between the diffractive multifocals and the enhanced monofocals, and they've really made life much easier. So there's some of the lenses that are available. I have used a few of them in the past. Nowadays, I use mostly the Pure C ever since it was launched in India about a year back. I'll talk a little bit more about Pure C. I have previously used a bit of the Vivity with very good results in some patients, and occasional patients who were not satisfied much at all. So especially with sometimes their distance vision was not as good as they would want it, in spite of being almost plano. Yet all lenses have their limitations, and Pure C has been a good addition to this whole armamentarium of lenses that we offer for presbyopia correction. It has an anterior optic which is similar to the Technis, and the posterior optic is where they've made some changes, which the change in design also gives tolerance to refractive errors. It's basically an enhanced design of what is seen on the iHands, and this is what they've done on the Pure C. That's on the right side, and the posterior surface has this small change, continuous power change, which was also seen in a small way in the iHands, but it is more kind of enhanced in this Technis Pure C. So it does not have rings, but it does allow good vision. So the monofocals, of course, don't give you that great focus at different distances, but the EDOF lenses tend to give you fairly good distance, and in fact, excellent distance and intermediate vision, and even some limited functional near vision, especially in good light. So this is the difference in the change in the lenses that we have seen. The multifocal, of course, has steps which you don't have on the Pure C, and that's why you see very few dysphotopsias with these lenses. Now, this is how the curves measure up the defocus, and you can see that the Pure C looks like it's performing pretty well and close to the Symphony without having the rings which the Symphony had. And Symphony being a great lens, yet occasional patients would have problems with the Symphony. Again, as I see in my results as well, the Pure C tends to have much better and more consistent intermediate vision than what we saw with the iHands, because with the iHands, some patients would get only very little intermediate vision. And of course, it's much better than the Technis monofocal. And you can see there on the curves over there. And distance is definitely comparable. In fact, as one of these studies showed, that the Technis Pure C had slightly better distance vision than even the iHands. Again, I think the dysphotopsia profile is pretty good amongst all these lenses. So I don't know where that sound is coming from, but I'm hoping it's not from my computer. And the tolerance to defocus is pretty good on the Pure C lens, as you can see over there. And even under defocus, the Pure C tends to perform fairly well, which is also what I see recently. We've started using the Odyssey, and I have no financial interest with Johnson & Johnson. So, but I do enjoy using their lenses. So again, tolerance to hyperopia to an extent, and even to myopic refractions has been fairly good with this EDOF lens that I've been using, and I've used about 150 of them in the last year or so. And so you can see over there that almost 100% of patients did not need glasses for distance, and they were fairly satisfied with their distance vision. Some of the studies which have again compared, the tolerance to refractive errors with the Pure C and the quality of vision as well. So in our experience, I think, especially now, this is one thing which I definitely feel that it's only when you get a bilateral implant, then this lens comes into its own, because with unilateral implants, some of our patients actually initially in that first week were not very happy with their intermediate vision, and some of them actually needed an add of almost 1.5 to 1.75 for near. And the moment the second eye was done, their comfort level improved drastically, and their add also for N6 at 33 came down to just about plus 0.1 or so. So it's very important to use this implant bilaterally. For that goes actually for almost all EDOF lenses, and distance acuity has been good. We have seen patients, some of them not using any near correction at all because they're happy with their binocular vision, and we don't see any significant complaints of dysphotopsias. Also, this also expands the indications, because with subtle macular pathologies and early glaucoma where you would not want to use diffractive multifocals, I think some of our post-corneal refractive surgery patients with well-centered ablations and minimal corneal aberrations have done well as well. And even with higher refractive errors, we have had fairly good results. So I think with that, I would like to finish by saying that I think one of the new EDOF lenses which I'm happy with, and I think this is the way to go. And if it continues to improve, we will use less and less of our trifocal lenses. It gives good distance at all, good vision at all distances, and bilateral implantation is the key. I think with that, I'll stop. Thank you.
Thank you so much, sir. And sir, any comments from your side?
No, I agree fully with what Gaurav talked about. My experience was bilateral implantation of POC lenses have really done well. Let's go to next talk.
Yes, sir. Thank you. So our next talk is going to be by none other than Dr. Boris Malyugin. And as you all know, sir is an eminent cataract surgeon, and he's working in the field of cataract and implant surgery at S. Fedorov Eye Microsurgery State Institution in Moscow, Russia. He's the past president of Russian Ophthalmological Society and is well known for his development of the Malyugin ring, which we are using day in and day out in non-dilating pupils. And his other innovations include surgical techniques and several microsurgical instruments, including the modified CTRs and IOLs, etc. He has received multiple international recognition and honors from leading professional organizations, including AAO, American Society of Cataract and Refractive Surgeon, including the Binghorst Medal and the Pearce Medal by the United Kingdom and Ireland Society of Cataract Refractive Surgeon, and the Binghorst Award by the European Society of Cataract and Refractive Surgeon, and the list goes on. Dr. Malyugin is a prolific researcher and educator and has multiple publications to his credit, and he's also mentioned in the Ophthalmologist Power List among the top 100 eye doctors in the world in the year 2018, 2020, and 2025. So with this, I would like to hand over the dais to Dr. Boris Malyugin for his talk on premium IOLs in non-dilating pupils.
Thank you very much, Dr. Sahai, for your kind introduction. I'm happy to see my old friends, Dr. Titiyal, Dr. Namrata Sharma, and definitely Gaurav Luthra and many others. So I will be sharing with you some of my thoughts on premium IOLs and small pupil cases. As you know, toric IOL alignment and rotational stability are essential to achieve optimal intraocular astigmatic correction. And we know that small deviations from the intended axis can meaningfully worsen refractive outcomes. 30%, 10% of rotation give us the decrease of refractive goal down to 30%. And with bigger degrees of rotation, we can virtually eliminate all the toric effect. In small pupils, visualization of the toric IOL axis marks is definitely compromised, and that makes intraoperative manipulations more complex due to restricted manipulations. So to summarize that introduction, I would like to say that the small pupil is a known obstacle to proper positioning of the multifocal IOL lens. Here you can see the maneuvers that can be done by the surgeon. The surgeon is now using Coughlin hook to expose the area of the toric IOL marking that you can see here, and to verify the proper positioning of the IOL. So that's definitely requires some additional manipulations here. So my technique is based on the device that I designed quite a while ago, and it requires certain surgical steps. Primary alignment. First, the toric IOL is aligned in a standard fashion following implantation. On the next step, viscoelastic is being removed from the retrolenticular space. We know that this step is very important because accumulation of the viscoelastic in that space facilitates IOL rotation in postoperative period. So under irrigation, toric IOL is realigned if necessary in the intended axis. And then, as I mentioned to you, viscoelastic is already being removed from the capsular bag on that state. And then small amount of cohesive viscoelastic is introduced in front of the lens to facilitate safe disengagement and removal of the pupil expansion device, and then final OVD removal is performed. So these are the surgical steps here. You can see that the marking of the steep meridian was performed, and during the procedure the pupil starts to constrict. There was no plan to do any pupil expansion device at the beginning of the case. However, progressive constriction make it necessary to mechanically expand the pupil. So following that, with some caution not to catch the anterior rhexis, the lens was removed, and now you can see that toric IOL is being implanted into the capsular bag. Following that, we definitely will be able to visualize all the markings as shown here, and to place the IOL almost in a perfect position. I do prefer to remove viscoelastic from behind the lens first, and then rotate the lens under the irrigation. But that is definitely dependent on the type of the lens that you're using. Following that, viscoelastic is reintroduced into the anterior chamber, and the pupil expansion device is removed. And this is more or less the final step of that procedure. At that time, you may consider verifying the proper positioning of the lens. And as you can see here, there is relatively good alignment, and sometimes there is a need for some adjustment of the lens position. So we did some study which is limited in numbers. However, that was done by my colleagues, and there were a couple of eyes that were served as a control, and we studied the differences in IOL alignment and positioning. And this study demonstrated that average rotation in our technique was almost negligible comparing to the more significant one in the control group, and definitely we didn't leave it as it is. That position, that misalignment was corrected at the end of the procedure, but as I told you earlier, that these were additional steps that we would like to avoid. So the conclusion from that study that this technique improves visualization and lead to more accurate IOL alignment and position, and it was safe and effective solution. And I do think that this technique can be applied to any pupil expansion device that is currently on the market, just following the same sequence of steps help you to avoid additional maneuvers. And I would like to acknowledge my co-authors of that study from my department at UCLA. And I would like to thank you very much for your kind invitation and for having me in this prestigious meeting. Thank you.
Thank you so much, sir, for highlighting those crucial points of how we can achieve a better alignment in these patients. We have with us Dr. Namrata as well. Sir and ma'am, would you like to make any comments? Sir?
I think, wonderfully shown the technique, for getting toric and a small pupil. I appreciate your point, Boris. After the toric lens is implanted, I also do it. First, I remove the viscoelastic from the, underneath the IOL from the back, then stabilize the IOL in a proper axis. Then, inject the viscoelastic over the IOL and iris surface so that you may have a maintained anterior chamber. Then remove the expander or hooks, which I use sometimes. Then you have now only viscoelastic over the surface. The IOL will never rotate. Just take out the viscoelastic with aspiration, which can be bimanual or a coaxial, and that really does wonderfully well. Just one question, Boris. All these cases where you use these expanders, do these cases have slightly more inflammation in the post-op, or they are almost similar?
So basically, I do not see a lot of inflammation, but that's definitely depending on the patient and some underlying conditions. So if it's intraoperative floppy iris syndrome, you do not expect more inflammation. So if that is the patient with pseudoexfoliation or previous uveitis, and definitely manipulation on the iris will increase the inflammation. And I treat these patients slightly more aggressively with the topical steroids post-operatively, while just a regular IFIS case, I'm not changing my topical regime for these particular cases.
Okay. Thank you so much, Boris, for being with us today. Thank you.
Pleasure.
Thank you, Dr. Boris. So with this, we'll move on to our, sir, if you could unshare this slide, please. So with this, we'll move on to our next speaker, that is Professor Namrata Sharma, ma'am, who is going to be talking about dissatisfied patients after premium IOL implantation. Sir, if you could unshare these slides. Thank you. So Professor Namrata Sharma, ma'am, she is currently working as a professor in the Cornea, Cataract and Refractive Surgery Unit at RP Center, AIIMS, New Delhi. She's done a fellowship from Moorfield Eye Hospital in London and is currently the chairperson, Scientific Committee of AIOS, and also the treasurer of APU and the past president of CSI and president of the EBA, past president of EBI. She has 2 patents to her credit, and she's been the first Indian to be inducted as the director at large at international members in the Cornea Society International of USA. She has multiple international awards to her credit, and she is also a section editor in the Cornea and External Eye Disease in the BJO. And she has over 682 publications in international peer-reviewed journals, has authored 19 books, and is a part of various instruction courses at various international and national platforms. She is enlisted into the top 100 powerful women ophthalmologists in the world world and also in the top 2% scientists, according to the 2023 Stanford list of the top 10 highly cited ophthalmologist researchers in India. And with that, ma'am, I would like to hand over the dais to you for your presentation.
Thank you, Dr. Pranita, for your kind introduction. And I would like to thank Professor J.S. Titiyal, sir, for making me a part of this, very important section on premium intraocular lenses. So, my topic of my presentation is the dissatisfied patient after a premium IOL implantation, and it is important to ensure a happy and a satisfied patient after any kind of pseudophakia. Now, there have been advances in the cataract surgeries, particularly flex, and patients do have high expectation because they pay a lot for the surgery itself, for the premium IOLs as well. And there's a wide range of IOLs which are available, although each of them has its own pluses and minuses, but patients may be dissatisfied after the implantation. So the causes of patient dissatisfaction include the unwanted images, the poor IOL selection, residual refractive error, poor quality of vision, posterior capsular opacification, and the vitreoretinal pathology. A poor ocular surface is important, and tear film is an important component of optical system. Dry eye is the most common cause for patient dissatisfaction, and preoperative treatment of ocular surface disorder is required. As far as the counseling is concerned, it is important to explain the patient about IOL options and expected visual outcome. And I think this is the most important part of the whole exercise. The surgery itself is not such a big challenge, I think, as far as phaco and IOL is concerned, but it is the counseling which is the most important. Need for near glasses after monofocal IOL and near glasses may still be required for sharper near vision despite multifocal or EDOF IOLs. The unwanted images that can be there are glare, halos, starburst phenomena, dysphotopsias, and reduced contrast sensitivity. And this has been also studied in various studies. So you can have positive dysphotopsias in 50% of the cases, which does resolve over a period of time, and also negative dysphotopsias in 15%, and they may be symptomatic in 2 to 3% of the cases. So positive dysphotopsia is when the patient sees them as bright artifacts, and the symptoms are arcs, streaks, rings, and halos. And negative dysphotopsia is when the patient perceives shadows or dark areas, usually on the temporal field. And the symptoms are blurred vision in temporal field as well as shadows. So these are just pictures to show how halo, rainbow glare, or temporal shadow will look like. Now, dysphotopsias are multifaceted optical phenomena, and the incidence varies from 33 to 78%, and they are affected by IOL edge design, refractive index of the IOL, and orientation of the IOL. So the dysphotopsia can be positive, such as this, due to internal reflection when the ray approaches the IOL at a critical angle at which light internally reflects rather than refracts. And there is going to be an angle which is least for the acrylic IOLs. And negative dysphotopsia can also occur mainly because of the shadow from the IOL edge. Apart from this, although these are supposed to be the etiology, but essentially it is multifactorial. So for the positive dysphotopsia, risk factors are high refractive index of IOL like acrylic, square edge, optic concentrates, the stray light as crescent or ring in the retinal periphery. And management is no intervention. You can counsel the patient, neuroadaptation, and in very rare cases, you may do IOL exchange with PMMA or silicone lens. Now, this is to show how the IOL design can actually cause dysphotopsias. So the sharp edge of the IOL can cause the occurrence of dysphotopsia, whereas the smooth edge will not cause it. Negative dysphotopsias can occur because of the IOL-related factors like high refractive index, transparency of peripheral nasal capsule, IOL edge design, edge smoothness, and edge thickness. The anatomical considerations are when the angle alpha is more than 5.2 degree, interaction between the anterior capsular rhexis and the IOL, distance between the iris and the IOL, amount of pigmentation, the small pupil, if there is corneal edema from the clear corneal incisions, prominent globe and shallow orbit, and amount of functional nasal retina as well. And the management of this is reassurance and neuroadaptation. And if it doesn't work, then you can do reverse optic capture. That is, you raise the optic edge above the anterior capsule with a haptic in the bag. Then people have even described neodymium YAG capsulotomy of the nasal capsule so that it removes the reflection of the anterior capsulotomy edge on the nasal retina. Then in the bag, nasal optic truncation, because this results in irregular edge and increases the light scatter. IOL exchange. Ciliary sulcus placement of the IOL is also known to decrease dysphotopsia, and piggyback IOL in the sulcus, which decreases iris to IOL distance and conceals the capsulorhexis. Just to show how the reverse optic capture and the nasal optic truncation would look like. Now, this is the neodymium, the negative dysphotopsia ring, or the ND ring, which has also been described, and this was described by a senior resident from RP Center, Dr. Pravin. And basically, what is done
emulsification incision is
basically what is done is that after the the neodymium ND ring is taken, and this is then placed inside the cartridge, and it is implanted very much like the way you would implant the intraocular lens. And this is then placed in such a way that it causes the stretching of the capsule, and as a result of which the ND, the negative dysphotopsia is eliminated. Now, apart from this, there can be residual refractive error which can be there, which can also occur after premium IOL implantation, which needs to be taken care of. And post-operatively, you can see that there may be IOL surprises, such as occurred in this patient, and then you have to exchange the IOLs because of the aberrations which are present, and this is actually what the patient sees. And this is yet another patient where the angle alpha was high, and which again caused increased in the higher order aberrations because of the high angle alpha. And again, this has to be kept in mind. Then toric intraocular patients can also be unhappy. And this is mainly because of ocular surface disorders like dry eye or epithelial basement membrane dystrophy, Salzmann nodular degeneration, pterygium, irregular astigmatism, or again, large angle alpha. And in these, all these things have to be either addressed preoperatively, or with irregular astigmatism and large angle alpha, one should avoid toric IOL. Then there can be large decentered capsulorhexis, which can be risk factor for IOL rotation or tilt, especially after toric IOLs. And post-operatively, surgical intervention may be required for poor IOL centration, or if there is rotation which is required as indicated by the eye trace, and even posterior capsular opacity, for which the YAG has to be done. So this is just to show the circular central rhexis and the decentered capsulorhexis, and this is a decentered toric IOL because of the subluxation which was present, and although the CTR was placed inside, but still you can see that this is a decentered toric IOL. And this is 15 degrees rotation, which is on eye trace required, that would change the cylinder post-operatively. And although this is not too much in use, but we have done cases with the ORA so as to allow toric IOL rotation. And our aim is to get the endpoint of NRR, or no rotation required, which again helps to titrate us and tell us that we are in the correct direction as far as the axis is concerned. Then apart from this, even in multifocal IOLs, there can be dissatisfied patient, because these are pupil dependent and they are highly sensitive for lens centration, against intolerance to the kappa angle, and there can be halos and glares and even loss of contrast sensitivity. So I think good preoperative case selection is very important in these cases. Patients with maculopathy, with dry eye should not be selected. And we have to check the IOL type in the other eye also, whether monofocal or multifocal, as well as ankle kappa. Then again, same features which we discussed earlier, like dysphotopsias can be present even with this, and so can PCOB, and all these problems have to be addressed. And of course, the posterior segment pathology plays a very important role, because sometimes the cataract is so dense that you are not able to assess the epiretinal membrane or the cystoid macular edema, and macular OCT should be done in all these cases. And one should avoid multifocal and EDOF lenses in patients with macular and optic nerve diseases. Then there are various studies which have clearly shown that there are reasons why the patients are dissatisfied. For instance, in this study, residual ametropia was the commonest cause, followed by the dry eye disease. Whereas in this study, the major cause again was similar, and PCO was also there in some of the cases. And this was the international consensus guidelines by the Asia Pacific Academy of Ophthalmology, which again concluded that ocular surface disease, retinal optic nerve pathology, large pupils, and residual astigmatism of more than 0.5 diopters and inaccurate refractive outcomes are the ones which lead to patient dissatisfaction. These are the older lenses, but as obviously expected, patients were more dissatisfied with Restore than with the PanOptics. And sometimes everything is right, but it is the wrong patient. The surgery may be perfect, the excellent outcomes may be there as predicted, but the patient is still not satisfied. So it is a challenging discussion after the surgery. So it is best done pre-operatively, and then do all you can after surgery to optimize their outcomes given the inherent limitations of the currently available intraocular lenses. So to conclude, I think pre-op counseling is most important message to prevent having a dissatisfied patient. A good case selection would be the one where the patient is not very demanding. And of course, the perfect cataract surgery and a perfect intraocular lens implantation still may not ensure that the patient will be satisfied after IOL surgery, given the choices of so many IOLs, whether multifocal or EDOF or extended range of vision. Thank you very much for your kind attention.
Thank you, Namrata, for a very extensive talk on a difficult subject, and difficult to make people understand also. Thank you again. And I think let's go to the last talk from Cell Vasolda. Dr. Panita.
Yes, sir. So our next presenter is Dr. Shell Vasavada sir, who's going to be talking about premium IOL in difficult situation. Dr. Shell Vasavada sir is a senior consultant working at the Raghudeep Eye Hospital. He's a postgraduate from Ahmedabad and has done his fellowship from Raghudeep Eye Hospital and in general ophthalmology from LVPI, followed by a 6-month fellowship in cataract from the prestigious Mohan Eye Hospital in USA. He has his degrees of DO, DNB, FRCS, and FICO, has over 20 peer-reviewed publications and various awards to his credit. And with this, I would like to hand over the dais to Sir for his talk on IOLs in difficult situations.
So much, Dr. Pranita and Dr. Titiyal sir, for this kind invitation. We've learned everything about the all new IOLs, how to counsel, how to calculate even in difficult situations, which IOL to put in which eye. But still, you can still encounter complications during surgery. So I'll be sharing a couple of situations where premium IOL was planned and the capsule gives way. This was a 30-year-old male complaining of glare while night driving and had bilateral posterior polar cataracts. And having learned all the principles of posterior polar cataract surgery from Dr. Titiyal, we could manage to, surgically do it quite okay. So we prefer doing the, cylindrical lens division in these situations, which acts as multiple areas of delineation without having to actually do any form of hydrodelineation. And we use very low parameters in such eyes because here is the eye where we don't want too many fluctuations to be occurring. So I'm using an intraocular pressure of 30 and a flow rate of only 20 cc per minute and an appropriate vacuum. And because this was a very young patient, 30 years of age, you can notice there's hardly any power that I need to do. And you can notice here with the rings, you can actually scoop it out. It's like scooping out an ice cream from a cup. You can scoop out these rings one from the support of the other because these are vertical cuts made by femtosecond laser. Having removed all of that, now what we are doing is we are creating a communication between the anterior and the posterior compartment. This allows fluid to start trickling out. What was described now, what is now described as the escape sign by Dr. Bobby Osher. And now at this point of time, even if you have to come out and do hydrodissection, there will not be any raised intralenticular pressure leading to posterior capsule blowout. Always and always maintain the chamber before removing any instrument in a posterior polar cataract. You don't want the chamber to shallow. And because this was a soft epinucleus, I decided to go ahead with bimanual IA to remove this thick epinucleus, although removing epinucleus can be challenging. So in slightly older patient, I would have just done some hydrodissection and removed it with the phaco probe. But even if you're not normally using bimanual IA, I think these are the cases where you should use, because you will avoid chamber fluctuations and you can access the cortex from all sides without having any issues. And we were able to prevent any complications from occurring, and you generally normally have sometimes some of these central plaques which ideally you should leave away. But in early enthusiasm, I thought, let me give a very clear visual access to this patient, and I'll just pick it up without actually touching the posterior capsule. And where nothing existed, I've created this vertical slit, which is typical of a posterior polar defect typically when it occurs. And this patient, we had counseled for a multifocal toric IOL, being young, being no experience with presbyopia. Now, having committed this blunder, we need to stay calm. So first I'm injecting dispersive viscoelastic, and then I'm injecting cohesive viscoelastic, because I want to try and still salvage this posterior capsular tear that has occurred. So what I'm trying to do is, and you can notice the patient is moving a little, anxious 30-year-old male. I'm trying to convert this tear into a strong posterior capsular rhexis margin, because if I can have rounded edges on both sides, this capsular PCCC can act as a solid support in which I can still go ahead and place an IOL in the bag. So always use micro incision rhexis forceps and grasp and regrasp at different points to try and convert it. So I've successfully managed to do it on one side, but I have to also make sure that I do it on the other side. So this side is stabilized, and now I'm using an instrument in my right eye to try and stabilize the globe, so that even if he moves, I don't need to advertently catch the vitreous. So fortunately, I've now been able to convert this into a PCCC, rounded margins on both sides, and now I'm not worried about this rhexis or this PCR running away at any point of time, and I can still go ahead and implant the IOL in the bag. So going ahead, and these are the eyes where you do need a good cohesive viscoelastic sodium hyaluronate base, making sure that the IOL opens gently, and I'm pushing it nicely, slowly into the into the capsular bag. The haptics, they give you a lot of time when you inject under viscoelastic, the hydrophobic acrylic IOLs. They unfold very slowly, so you have a lot of time to manipulate. I'm actually seeing the placement axis through my digital Varion in the eyepiece, and I'm making sure that I put it in place only about 10 degrees off, so that I don't have to rotate very much after doing viscoelastic removal. Always, of course, this is not the case where you're going to go behind the IOL. Just tap the IOL and make sure most of the viscoelastic comes out. But you can notice how easily the cohesive viscoelastic comes out as one bolus, and this is how the patient was on the table at the end of surgery. The most important question would be, how does this IOL behave in the long run? And this is 1 week post-op, and this is now 2 years post-op. The IOL is perfectly in position. He has a clear visual axis. The toric has not rotated in spite of a PCCC. So except for me and my assistant, nobody knows what happened to this patient intraoperatively. And this is another case planned for a second eye flax with a toric IOL. Everything has gone off perfectly, nice centered capsular rhexis. The last fragment has been removed well, and we are going ahead with IOL implantation, which is in this case was a T3 power in this situation. And as you can notice, this is all in retrospect. The plunger is actually overriding on the optic, which ideally should not be, and so I'm facing some resistance in injecting. But sometimes overconfidence takes over. So I think I thought maybe I'll get away with it. I know I'll go slowly, and oops, a jerk has occurred. But still, I'm not very worried, because I've injected it under sodium hyaluronate. So I think everything is still going to be okay unless I saw this. So now I have a situation with a toric IOL inside the capsular bag, single piece, and PCR extending right up to the equator, and there's no way I can convert this into a PCCC because it's going outside up to the equator. So what are my options? Explanting it can be even more traumatic. There's no vitreous prolapse at the moment. So I decided to, since I have a small centered capsular rhexis, to attempt what is described as reverse optic capture, which means here my optic haptics are going to remain inside the capsular bag, and I'm popping out the optic above the anterior capsular axis. And having done that, I realize now the axis is not proper. So I'm now first adjusting the axis, put the IOL back in the bag, make sure that the axis is well aligned again, and only then now popping out the optic above the anterior capsular axis. And you'll see a large kind of a dumbbell, because the optic haptic junction of a single piece is quite large. Always inject triamcinolone in the end to make sure that there is no vitreous prolapse. Fortunately, it wasn't in this case. And always never let the chamber shallow, because if it's too tight or it's too loose, the reverse optic capture can still come off. That's a danger of reverse optic capture. Fortunately, the patient did very well post-operatively. Such patients will develop maybe a full PCO, which can be yagged quickly. So thank you so much, sir, for this patient, everyone for this patient listening.
Thank you, Shal. Wonderful videos and wonderful teaching. Thank you again. I think, we have already overshooted the time. And now I can say this was a wonderful session. And we'd like to thank all the participants, especially Dr. Mayank Nanavati and Boris and Sergio, making a wonderful presentation as international speakers. Our own speakers did wonderfully well. I think people will go through these talks subsequently also through AI's website, and more and more people will benefit. Thank you, all of you, for making this very successful session on a premium IOLs. Thank you, Dr. Naranda, especially Dr. Panita, for wonderfully conducting and moderating this session.
Thank you, sir. Thank you for the opportunity.
Yeah.
Thank you so much for inviting. Thank you.
Mohan, all yours. Sorry, we have taken a little
Thank
more.
you, sir. No, I think you are on time, sir. We are 7:30 we are starting.
Okay. Then you came
Another few minutes time. If you want, you can have some discussion.
All yours, Mohan.
Thank you, Namrata. And Rolika is there. Who's Pranita is there? Pranita and Rolika. Who's going to coordinate?
Good evening, sir. That's
Good
me.
evening, sir.
Yeah, good evening.
Karan will
Hi.
Yes, sir. Good evening, ma'am. Good evening, sirs.
Good evening.
Yeah, good morning, Kevin. How are you?
I'm doing well. Good evening, Jeewan.
Yeah,
Good to see you.
Bye.
Good morning, Kevin, and good morning, George.
Good
Thanks
morning.
for coming. Thanks. Hi. Nice to see you.
Oh, George is for your session. I thought George was for our session.
George is always with me.
Okay, see you.
Kevin also. Yes, too good. And we've got Ashraf Armia from Egypt also very soon. He'll be joining us. Good. Hi, George.
Hello.
How are you?
Kevin, how are you?
Fine, boss.
George.
All fine with you? Yeah.
Good.
And what about the chairpersons? Sugas Aldipuka, Sujata, and Shail is already there. Sugas and Sujata.
Hi.
Yeah, is there. Sugas is there?
Hi. Hi. Hello, sir. Dr. Kevin.
Good to see you, Sujata.
Hi.
Hi, Shahil.
Hi, Sujata. I've not seen you for quite some time.
Good for me.
Anyway,
Good evening,
we'll
everyone.
start.
Hello, everyone.
Yeah, good evening.
Yes, we'll start
Hi,
sharp on time.
Rolika.
So we have, hello. We'll start sharp on time. So we have 4 minutes. So if anybody would like to share their screens, they're most welcome.
I think George would like to share your screen and make sure everything is working, because you are the first speaker and followed by Kevin. And then Ashraf can also join. I think Shail, you have already done it, so no problem.
Okay.
We have another few minutes to go.
Okay, do you guys see this?
Yes, absolutely.
Yes, sir, all good.
Absolutely. Put the slideshow, yeah. That's fine,
Look.
fine.
George, that looks like the American side of the falls. How come you didn't shoot the Canadian side?
Because then you'd have to cross over to America to shoot the Canadian side and spend the
Canadian side is
$250 bill.
absolutely amazing. Canadian side, no? Absolutely amazing. Okay, Kevin, you'd like to share your screen?
Sure. I think George has to unshare because he's
Please,
blocked.
George, can you unshare and then come back?
There you go. Did that unshare or not?
Yeah, I'm good.
You're good.
Are your slides working, sir? Kevin, it's fine.
Yeah, we're good.
Okay. Rolika, we can start exactly at 7:30.
Should I share the
Sure, sir.
screen?
That will be
Should I
perfect.
share that PPT
Karan.
that you had shared?
Hi, Karan.
Hi, sir. Good evening, sir.
Good evening.
Sorry, I was actually
Good day.
yesterday I was in Kathmandu. Today only I just landed. For one day I had gone.
Really? Gone for some study?
No, sir. There was a Bio Nepal. They had their first inaugural meeting, so they had invited.
Yeah, you were telling me last time when I met you.
Yes, sir. Yes, sir. Yes, sir.
Yeah.
I'll just
Good.
share this till that time.
Mm. Yes, sir. We just have an opening slide. So Dr. Karan and Dr. Krina are here, and
Yeah,
they're the
Karan.
session coordinators and here to help you all. And
Yeah.
Krina can help out with the timer for the sessions. Is that okay?
Yeah.
ma'am.
Yeah, Rolika, I thought we'll have. Shall we have the discussion at the end, or you want after every talk?
As per your choice, sir. You're the program
I think
director.
after every talk we'll have the discussion. It'll be better. And
Sure.
10 minutes talk and 5 minutes discussion. That's what we have kept.
So 10 minutes talk and 3 minutes discussion. And the
3 minutes.
cases are for 5 minutes each with 3 minutes discussion.
Yeah. Cases can be even for 4 minutes. I told Shail also, no problem.
Okay, sure, sir.
So 10 minutes talk and 3 minutes discussion. That's fine. We'll have a
Yeah.
discussion at the end of each talk, but I would like all the faculty to stay on till the end so that we can have some good inputs from them as well.
Sure, sir. And Dr. Karan will be just opening the session and handing it over to you, sir. Dr. Karan, if you would like, we can start at 7:30 sharp.
It's 7:30. I think, sir, we can start the session.
Yeah.
You'll be introducing everybody, sir?
Yes.
Yes. Okay.
Shall I start?
Yes, sir. Please go ahead.
Good evening to all of you. On behalf of the All India Ophthalmological Society, I would like to welcome all of you for this AOS International Ophthalmology Conclave, which is around the world in 20 hours, and we are having excellent sessions starting from yesterday. And today we're going to have a very, very important topic and excellent faculty as well, difficult situations in cataract surgery. And I'm the program director, Dr. Mohan Rajan, and we have the chairman for these sessions, Dr. George Beko from Toronto, Canada, and we have Dr. Suhas Haldipukar from Bombay, Dr. Sujata Mohan from Chennai, India, Dr. Shail Vaswada from Ahmedabad, India. They are all the panelists for this particular session, and we'll begin the talk with the first speaker, Dr. George Beko, who doesn't require any introduction. As you know, Dr. George Beko is a very famous ophthalmic surgeon in anterior segment, in cataract, cornea, and refractive surgery. He is also the professor in the McMaster University, and he practices in St. Catherine's in Toronto, and is also attached to the University of Toronto as well. Very dynamic surgeon, excellent speaker, a very, very close friend of all of us. over to Dr. George Baker, who will be talking to us on subluxated, dislocated cataracts. Should the bag be preserved? It's a very important topic. Over to you, George.
Okay, are we up? Is it up?
Yes, sir. We can see your slides.
That's fine, sir.
Great. Well, thank you very much. And Mohan, thank you very much for inviting me to be a part of this session. I'm honored to be speaking to you. And today I'll be talking about subluxated and dislocated cataracts. Should the bag be preserved? I have no financial disclosures. Just by way of introduction and for definition, decentration refers to the misalignment of the lens from the visual axis. This occurs in about 20% of cases, but is not visually significant for us. Subluxation refers to the partial loss of zonular or capsular support, and dislocation refers to the complete loss of zonular capsular support. So in terms of dislocated cataracts, there are a number of different causes or entities that are associated with dislocated cataracts. The most common is traumatic. So here's a case where the patient presents with a dislocated lens. And as soon as we see that, we start thinking about the possibilities of the tools and things that we may need to deal with this. This includes iris retractors, capsular tension rings, segments, hooks, and the femto laser. But what we fail to think about is all of the gymnastics that are going to be involved in dealing with this if you try and preserve the capsule, and more importantly, the amount of time that it's going to take to do the case. And if you speak to my colleagues or if you start thinking about this, most people will allocate somewhere between 90 minutes and 2 hours to do a case in which there's a dislocated cataract. So we need to ask ourselves, what is the function of the lens capsule? Well, it protects the lens from infectious viruses and bacteria. It's capable of participating in accommodation by changing the shape and surface of the lens. It provides epitopes for promoting regional growth, cell growth, and migration and differentiation. It provides a reservoir of sequestered growth factors that promote differentiation of the lens cells. And it provides support for the intraocular lens following cataract surgery. This is in the case of an intact capsule. So what happens after cataract surgery? And we've, in traditional cataract surgery, well, once you remove the lens fibers, the capsule loses its function. It starts to atrophy and fibrose. If you look at the lens capsule in cataract surgery, it decreases in size by 1.5 millimeters at 6 months due to fibrosis. And placing a CTR doesn't really stop that. You still get a decrease in the size of the lens capsule with fibrosis. So what starts out looking like this ends up looking like this with a lot of fibrosis and atrophy and problems. And the lens capsule can actually fimose and cause severe problems, although the majority of cases will not be as severe. So the question we have to ask ourselves is, if we preserve the lens capsule, what are we gaining? Actually, we're not gaining much because it has lost all of its function. So, in this case, you would be thinking about using iris retractors, capsule retractors, a CTR, and then putting in some segments as well. And as I said, you're thinking about doing a case that's going to take you anywhere from 90 minutes to 2 hours. From my perspective, because there's nothing to be gained from doing this, I would rather remove the lens and proceed with a scleral fixation technique. So in this case, this is a case that I did about 6-7 years ago. At that time, we were doing the glued IOL technique that Ammar has taught us. So we've gone in, we've created our flaps, we've created our sclerotomies, go in with viscoelastic and bring the lens up into the anterior chamber with the goal of emulsifying it in the anterior chamber, do the scaffold technique, so the IOL is inserted into the anterior chamber over the iris and under the lens, and then phacoemulsify the lens with the scaffold, protecting any pieces from falling into the posterior pole. So here we go. We do this, we emulsify, and you're all familiar with this technique, so there's not much to explain. But the important thing is it's a technique that I'm familiar with. It's a technique that doesn't involve a lot of gymnastics, and it allows us to place the IOL in its position behind the iris. So again, going in and passing the haptic out through these sclerotomies. And we'll do that on the other side. And this, by doing this, we're able to do the case in a relatively short time. So the total time for me, I went back to the original video, was about 35 minutes to do the case from start to finish. Not 90 minutes, not 2 hours, and it doesn't involve any devices that aren't already present in my OR. Let's go on to the next case. So here's another case that presented with a subluxated traumatic cataract. The patient had had a global rupture from trauma. It was a 180 degrees limbal rupture with extending posteriorly 9 months previous. The eye was repaired and has healed quite well. And now he comes to me with the cataract. And in this case, because it's a subluxated lens with some support, I thought, well, I'll go ahead and try and stabilize this and save the lens capsule. So putting in some capsule, the idea was to put in some capsule retention hooks and then to put in a modified Cioni. So that was the game plan. These are things that we have in the OR. And so we start the case and go in. And initially, I'm trying to puncture that anterior capsule. No luck. Try and grasp it. And I spent about 5 to 10 minutes trying to do an anterior capsulorhexis without any success. At that point, I decided, well, this is not going anywhere. I'm not gaining anything, and decided to convert to an intercap technique. So I extended my incision, brought out the lens. I then placed the suture to close the wound and do an anterior vitrectomy. And the plan then is to put in the IOL. The reason I didn't do the scaffold technique is because I've got quite a bit of the iris missing, and I didn't know that I would have the support. So that's why I converted to the intercap. We then convert to a Yamane type technique, and we have the lens in good position, stable. The patient didn't have the finances for an iris prosthesis, which would have been the ideal thing, but he has done quite well and is seeing 624. The reason he's not seeing any better is because he has some retinal scars. So getting back to this, should the capsule be preserved? Well, all of the functions of the lens capsule are lost once we have no zonular support. And we have a lot of potential complications. We know there'll be corneal edema, there'll be increased IOP due to the manipulation of the tissues, and this can be temporary, prolonged. Cystoid macular edema is a concern. Ptosis because of prolonged speculum use. And for the patient, there's increased discomfort and prolonged recovery in all the cases in which we try and preserve the capsule. But more importantly, is there an increased risk of endophthalmitis? Well, if we look at routine cataract surgery and we culture the aspirate, we see that there is some contamination in about 43% of cases. So in our routine cataract surgery, there's already the contamination of the eye with Staph aureus. How many colony-forming units do you need for endophthalmitis? You need 1,000 if the posterior capsule is intact. You only need 14 if the posterior capsule is not intact. So there's a high risk of endophthalmitis in these prolonged cases with in which there's no barrier to the posterior pole. And then is there an increased risk of retinal breaks? Well, we know that prolonged intraocular surgeries increase the risk of retinal breaks somewhere between 3 and 24%. And over the lifetime, about 40 times higher risk of retinal detachment. So for me, preserving the capsule provides no benefit. And what I recommend is for people to learn how to fixate the IOL. Gabor Shirath introduced the intrascleral fixation to us approximately 20 years ago. Amar Agarwal has given us the glued IOL technique. Shin Yamani has given us the flange technique. And it's important that we learn these and use these. And these are techniques that we can incorporate and use in a shorter period of time with less complications. And if you're going to use this, the one thing that I'm going to recommend is that you go back about 2.5 to 3 millimeters in order to avoid the arterial arcade and any vitreous hemorrhage. So thank you very much for your attention, and would encourage you not to preserve the capsule as it has no benefit for the patient. Thank you.
Thanks a lot, George, for a very, very, what do you call, illuminative talk, I would say. You have expanded the indications for a glued IOL and SF IOL. The question I want to ask you is that in younger children, do you think that preserving of the bag is better than putting as SF IOL? I want the opinion of George, I want the opinion of Kevin, and also the other panelists also.
I'm sorry,
Younger children.
with handicapped?
No, younger children. If they have a subluxated cataract, like a Marfan syndrome, is it worth preserving the bag and putting a lens in the bag then, because you are not violating the posterior segment at all. So you are doing only the, you are compartmentalizing the eye. So that's the reason why in the long-term results, we have seen that long-term results, whatever you have done long time back, still the patients are doing pretty well. So I was wondering whether it's a SF IOL or a glued IOL in younger children. Of course, adults, I fully agree with you, you can sacrifice the bag. But I just want your opinion on that.
I think in children, it's I would not preserve the bag. I think my big concern is not only is it not providing any function, but my big concern is the fibrosis that occurs, and we can see this fibrosis, and it's very, very advanced. And when you have these children, I mean, trying to deal with that fibrosis means another surgery, means another problem. So I would not encourage you to do that.
I think we have a long-term follow-up of patients with subluxated cataract, pediatric cataract, who underwent lensectomy with a glued IOL, a secondary IOL fixation, and they have been doing extremely well. So I would be on the side of Dr. George Baiko, saying that I don't think we need to preserve the bag, and particularly in a subluxated cataract in children, because in these children, the cataract is so soft and you can easily, lensectomy can be done, and a secondary IOL can be implanted.
A quick comment from Sugas, if he's there. Sugas, can you make a comment on this?
Well, my only concern in such cases, especially when you are dealing with young children, is that like if you give away the bag and fix a lens like scleral fixated lens, and when the child grows up, and it grows up with a big refractive error, so at that time the IOL exchange is a difficult proposition. So they are only left with whatever refractive procedure that you can do for them.
I think it's a very important point.
Yeah. Otherwise, if you can do a good scleral fixated by knocking off the bag, I think I kind of agree with that.
Quick comment, Kevin. Kevin, what is your take on this?
Yeah, there are a lot of factors that go into it. If the child is quite young, let's say less than 3 years of age, the refractive issues are so huge as they grow. I think it's better just to leave them actually aphakic. Don't put a lens in at all. If you can keep them in contact lenses until they're, say, teenagers or later teenage, then you can go back in and you have lots of options for putting a lens in the eye when the eye is fully grown. Even the later children, as George has mentioned, Suhas, the capsular fibrosis issues are very real. You're basically, if you're putting a lens in the bag or preserving the bag, you are going to be doing another operation on that eye at some point to deal with capsular issues or lens power issues. So, and whether you preserve the bag or not, I'm kind of 50-50 on this. If the bag is centered in the pupil, it's just unstable, but it's centered, but you can get away with preserving it. I kind of like to do that for, mostly for the issues about endophthalmitis. But you have to be super aggressive at polishing the capsule, make sure those lens epithelial cells are off the anterior capsule, and you'll find that the bag will stay relatively clear long term. Now, 50 years later, there's got to be a dense submarine ring. We all know that. But maybe 20 or 30 years of a lens in the eye, especially if the patient is monocularly has a cataract, those eyes don't do well from an amblyopia perspective, so they're actually better off with a lens in. If they're bilaterally with cataracts, then you're better off just doing what George mentioned. So it's complex. It's complex. It really depends on age, status of the lens, and other things.
Absolutely. I think it's a very beautiful lecture and very beautiful comments as well. And we'll go on to the next talk by none other than Dr. Kevin Miller, a very good friend of ours. And Kevin Miller does not require any introduction. He is one of the top guys. Very rarely you see a combination of everything, a good clinical guy, a good surgeon, a good researcher, good academician, good speaker, and he is a professor of clinical ophthalmology at UCLA, and was also with the Jules Stein Eye Institute, and a great guy. And he's known for his complex cataracts situations or surgeries for that matter. And today I think he's very appropriate. This session is very appropriate for him. Today he's going to talk to us on iris repair in complex situations. Over to Kevin. Please share your screen.
Thank you, Mohan. I think, George, you're still sharing your screen, so if you can hop out.
Yeah, that's fine.
How do I do
George,
that?
please stay back and have some discussions. Thanks a lot, George.
I'm just trying to figure out how to unshare.
At the bottom, it will mention stop share, or at the top when you put your mouse, when you move it up.
Yep, got it. There you go.
Perfect. Perfect.
Sorry about that.
There we go. All right, everybody can see this?
Yeah, it's fine.
All right. So thanks thanks for inviting me to speak at the All India Society meeting. I'm president of ASCRS this year, so I'll send a greeting from ASCRS. Thanks for involving ASCRS in your meeting. These are my financial disclosures. None of them are relevant to this topic. So I'll quickly fly through in 10 minutes these issues: iris prolapse, bleeding, eye atrogenic atrophy, iridodylisis, peak pupil sphincter tears, and trauma. There's many more things you could talk about, but time is limited. So we've all experienced this particular problem. I was doing a lens exchange here. So this is going to be, I'm taking out a multifocal that's causing dysphotopsia problems. And in a lens exchange, you don't want anything to go wrong. And here I have iris prolapse of all things on the temporal side of the iris. So, it's being pushed out by viscoelastic. So I'm going back there trying to get the visco out of that nub, and you never want to take a sharp pokey object like a dissection cannula and push it in. But it wasn't going to go in. So what did I do? I just changed my microscope position. I just went superiorly now, and I'm just going to let the iris hang out in the incision. And as long as you don't go poking at it, it'll just stay there. It'll be happy, and it won't get all mangled. So you can come to a different location. I like to refold lenses when I do a lens exchange. But whenever the iris is prolapsing and the chamber shallow, I just prefer to cut them out. You don't have, iris prolapse problems. If you try to refold the lens, now oftentimes the iris will come up. So now once the lens is out, I just use a little viscoelastic and push that prolapsed iris back in. And the case just goes from that point on. It's basically a normal case with zero iris atrophy. even though that iris was sitting outside the eye for a little while. So here I'm putting in my 3-piece lens. This lens is no longer available on the market, but it's a nice lens with a rounded edge. So notice the iris over there. You can't even tell anything ever happened to it. Now here's a case where it didn't go so well. I don't know if Boris is still online, but this is Boris's ring. Here's, I got, you can see there's some iris atrophy down here. I was pretty careful to try to minimize the iris atrophy, but the iris just once the iris comes out, it's like the incision's like a magnet for the prolapsed iris. It just wants to keep coming out. So here I am putting the lens in. And I got a little more, I'm losing a little bit of pigment now from the iris. And this is in the temporal aspect of the iris. So, it's going to cause light to come into the eye, because the lid fissure is there. I'm going to release the distal ring. Always release the distal ring first, push the proximal ring in. Now I'm going to put more viscoelastic in below. Never use instruments to poke the iris in. It just doesn't go well. Now I'm getting the injector caught up on the iris. I'm going to sweep it off if I can. That left ring always catches you. So, not pretty, but once you recognize iris prolapse, just do everything you can to minimize the subsequent damage. Now, iris bleeding, we've all experienced this. It's usually self-limited. It stops more quickly if you can inject an agent that constricts blood vessels like epinephrine. We don't have phenylephrine in the US, but many countries do. Raising the IOP also helps, but this usually is self-limited. It goes away. This is the one problem you want to avoid at all costs. And it can start with iris prolapse or your phaco probe hitting the iris, and that's iatrogenic iris atrophy. If the defect is large, you don't really have an option. You don't have many options. You have cosmetic or artificial pupil contact lenses, which in my experience don't work very well, or an iris implant. You cannot close this defect with sutures. So this is the second patient I ever performed an artificial iris on. She was 11 years old, playing with some scissors, accidentally stabbed herself on the nasal aspect of her left eye. You can see the defect that she had. Are these pictures interfering with the right side of your screen? Or are you seeing the whole screen?
It's okay, sir.
Is it
It's okay.
blocking?
No, it's okay.
Okay.
Yeah,
Well,
we're seeing the whole thing.
Oh, you are? Okay, good. So you can see that she subsequently, many years later, had cataract surgery, toric lens put in, 2020 uncorrected, yet miserable because she couldn't drive at night. And you can see why, because light was hitting the edge of the lens implant and the capsule outside the diameter of the optic. And so every light she looked at had a beam through it, could not drive. And I had experience doing one artificial iris prior, a human optics, so I thought maybe she'd be a good candidate for iris in the sulcus. And here she is afterwards. Very nice functional pupil, cosmetically look great. If you look at the full face photo, you can hardly tell. There's some pigment on the cornea, but if you look before on the full face picture, look after, at conversational distance, you can't tell anything is wrong with her eye. And functionally, which is the most important thing, she's 20/20, no glare at nighttime. So functional irises are very useful in situations if you have a large iris defect. Now, here's the case of just a simple sphincterotomy. The surgeon was taking out vitreous gel, got too close with the vitrectomy probe to the iris, and it's like the iris is like a magnet, or the probe is like a magnet for the iris. If you get close to the iris and you have the port turned towards the iris, there's a good chance the iris will just jump into the vitrectomy probe, and that's what happened here. So it's a large, sphincterotomy. So I closed it. You can see the after picture here on the right. Always criticize, always kind of critique your own surgeons. I just placed one more suture. It would have been around her pupil. And that's always the challenge when you're doing these cases. Do I put one more suture and then one more suture and then one more suture? At some point, you just have to call it quits. But in retrospect, I wish I had put one more suture in. Here's an example. This is a different case, but here's an example using the Siepser sliding knot technique. So there's Siepser, there's the mechanical. And you could have used either here. I kind of like the Siepser. So you go in one side, you go through the other side, and you make sure you dock to a cannula, because you don't want to go try to push that needle out the incision. If you catch corneal fibers, you won't be able to pull the suture back in and tie it. MR has popularized the single pass four throw pupiloplasty technique. I think that's a great, at least short-term technique. We don't have any long-term follow-up to see if those sutures are going to unravel. So I'm still tying a second and third knot just to make sure I don't ever have that problem. But that's an innovative way of doing this. Here's something you won't see very often. This is a lady who underwent cataract surgery elsewhere. She was a hyperope. She had a 31 diopter lens, and during her surgery, her right eye iris prolapsed through the incision. Now, it doesn't look that bad in this photograph, but I'm going to show you another picture where she has iris transillumination throughout the entire temporal aspect to her iris, and she's miserable with just the glare. So this is what the temporal iris looks like in retroillumination, like how to fix this. Now, you could put sutures to this and bunch it all together, and that would work. But at the time, I had access to a Morcher modified capsule tensioning with a single 90-degree occluder pattern. I thought that would be a good solution for her. So I reopened the capsular bag, put the Morcher device in, oriented the paddle behind the transillumination defect, and here she is post-operatively. You can barely tell any difference in the cosmetic appearance of her eye. But if you look at the bottom right-hand picture, you'll see the glare or the reflex off the central edge of the Morcher device. You can see it just a little bit of a arc-shaped thing in the pupil. But if you shine the light in through the pupil like I did before, you'll see that there's no translucency. Now here's an example of a patient who had the same. This is the same ring, just a different patient. This is a really old video, so the video is kind of choppy, unfortunately. But you have to, when you put these things in after the fact, you can see there's capsular fibrosis. So I'm doing this way after the initial surgery. You have to initially open up the capsular bag with a lot of viscoelastic. So we got to viscodissect open this thing so that the haptic travels all the way around without getting caught up on fibrosis. And then you dial in the haptic side first and leave the occluder paddle for later. These things, they say that they're very brittle and that they snap. I've never had a single Morcher device snap on me, and I've put in 70 or 80 of them, so I've not had one snap. You don't want to rip the capsular excess, so I usually take like a Kugelin hook, push-pull hook, and then make that my artificial capsular excess. So as I'm advancing this thing, I'm advancing it against the hook now instead of the capsular excess. Takes the tension off the capsule, and then the paddle takes a 4-millimeter incision to get it in. So it's a pretty generous incision. And then once the paddle is inside the eye, now unfortunately these devices were taken off the market about 2 years ago. The European Union decided, in its infinite wisdom, that Morcher needed to go back and do safety studies. When these products have been in patients' eyes for 40 years, it's just insanity. The bureaucrats, unfortunately, have taken over Europe. So these products are no longer available, but they're great products. So you orient it under the defect. So this is that same patient, not the video patient, but the same patient. And I'm going to show you the next picture is with the paddle in. That's the retroillumination shot. No light coming in through that defect. So that's was a nice option. I come up. Iridotomy is easy to close. There's the after picture. Just did one of these 2 days ago. Here's another device, Morcher, that's useful for sphincter defects. And but they don't. This is 25 years later. The whole capsular bag complex failed. We ended up taking it out, putting in an anterior chamber lens, and I closed the defect with sutures instead. And iridodialysis, you've all seen this. I will skip through that. Peaked pupil, it peaks because something's either pulling on it or pushing on it. So it's usually vitreous, clean up the vitreous. Sometimes it's a haptic that's tucked into the peripheral iris. Isn't it? These problems don't go away after surgery. You got to deal with them during the surgery. So that's a quick fly through of some common iris problems. Sorry for going over, Mohan, but I'm happy to entertain discussion.
I think that was a seriously amazing and incredible videos, Kevin. What fantastic postoperative results. This iris implant you are talking about in the last case, can we leave it in the sulcus instead of putting it in the bag?
Are we talking about the human optics one or the Morcher one?
The last one. Black one,
Yeah,
yes.
the modified capsule tension rings just almost by definition have to go inside the capsular bag. If you put them in the sulcus, they're undersized, so they'll rattle around. They won't stay positioned. So all capsule tension rings have to go in the bag. Mortier did make devices for the sulcus. You could suture them in or put them in passively. The same with human optics. You can put them in the bag. You can put them in the sulcus passively, or you can suture them into the sulcus. So you have lots of options. The problem with human optics is they don't have an integrated optic. We've been trying to get them to do that for years, but it's a mom and pop company. It's small. They don't have the resources. So maybe one day they'll have a little on ends you can kind of clip, with flanges that you can just clip into the pupil. That would be nice, but that doesn't exist. Reaper has that. Optec had that. Mortier had that, but so far not human optics.
We see a lot of patients who are on Urimax or Flomax in your country, but Urimax here in India. So the iris starts prolapsing, and we try to push the iris back through the same port, and the iris gets damaged, and there is an iris defect. How do you avoid this, and what is because we see a lot of patients who are on anti-prostate agents, for that matter, tamsulosin. So is there any trick you have in mind?
Lots of them. So the first trick is ask the patient. I ask every single patient, are you on one of these alpha-1 receptor antagonists? It's amazing how a third of my male patients are on them, and about 1 in 100 female patients are on them. So the biggest thing is knowing ahead of time so that you know what you're up against. So when you have an IFUS kind of situation, you go low flow, you keep the IOP down, you don't overfill the eye with viscoelastic. What pushes the iris out is viscoelastic. So you get a lot of high viscoelastic under the iris, and out comes the iris. So you just kind of make sure the viscoelastic goes on top of the iris and not under the iris. So knowledge of what they're on is the most important thing. Next thing, never stretch the pupil if it's an IFUS patient. The iris is already floppy. You stretch, you make it floppy.
Yeah, absolutely.
I used to use a lot of rings and hooks and to stabilize. I almost never use them anymore, but if you have a really floppy iris that's just coming straight down, it's floppy, just put a ring or hook in and just get the iris, out of the way. The last thing you want, we have a lot of blue eye patients in the US, and you can get away with a lot with a brown eye patient, but you don't get away with anything with a blue eye patient. So you got to be really, really careful. Just never, never, ever get iris prolapse in any eye, but especially a blue eye. But knowledge is the most important thing, and how you deal with that. We hit them really hard with dilating agents, mydriatic agents, and that usually helps.
George,
stopping it doesn't help. if they've been on for 3 months, stopping the drug does not help.
No, I don't think so. I don't think it's good. George, any take on that? How do you manage this IFUS in your practice?
My assumption is everybody's on those medications, so I don't bother asking them. I just treat them as if they have that. And my phaco technique is a low flow type of technique, so it deals with these patients. If the iris starts to prolapse, I agree. I mean, you don't push it back. You go to another incision and you let some of the viscoelastic out, and allow that iris to come back into the eye. And if I'm having a lot of problems with the first eye, I automatically, in the second eye, go to a Malyugin ring to stabilize that iris. So first, assume that everybody's on it, and second, be prepared to use the Malyugin if you need to.
I think it's better to be safe than sorry. Quick comment from Suhas, Sujata, and Kiranjit Singh. Shail also. Quick comment, one-liners.
Speaking about these IFUS, normally I put those patients on atropine 3 days before, and just before starting, I put epitrate to strengthen and dilate that pupil, and then of course my mainstay is going for a dispersive viscoelastic. Followed later, if the iris doesn't behave well, then I'm absolutely liberal with using a BX ring that we have, so delicate and nice one to expand these pupils, and it seems to work good for me, and we never get iris prolapse at all.
And Sujata? Sujata is there?
You're muted. You're on mute.
Yeah, okay. So if there is an iris prolapse, what I would try to do is push the iris back using a cohesive a viscoelastic. And once I enter the chamber, I'll never come out till I finish the surgery. So that's one thing, we should not go inside and coming out. And you can use through the side port, you can use a second instrument to push your iris down or inject viscoelastic through the side port just to push the iris down. This is in probably very early cases, but if it is very bad and is continuously coming out, then it's better to change your site of incision.
I think you'd prefer to use dispersive like Viscoat, which is very heavy, and will push the iris back rather than a coercive, and will stay there as well. And Shail, you have anything to add quickly?
Just two more things. Even in a non-IFIS case, if the patient is a heavy breather, obese, such incidences can occur. So the first thing I would do is just loosen the speculum also, because quite often a very tightly opened speculum also leads to these issues. And whenever there's an iris prolapse, I avoid repositioning it from the same incision. Make another side port, go from the opposite area and use a viscoelastic on top of it to try and bring it in rather than swiping it. Swiping it will lead to a lot of pigment release, or pushing it or swiping it will lead to a lot of pigment release.
Because we need to, because the next talk is probably an overlap of this, because Ashraf Armia, we are running out of time. Ashraf Armia is the next speaker. He's going to talk to us on small pupils and phacoemulsification. Ashraf, are you ready with your talk? And
Yes.
Ashraf is a really fantastic surgeon, consultant cornea, refractive, anterior segment reconstruction, and he's a top guy from Cairo, Egypt, and is very, very popular in India because he comes for a lot of our IRSA meetings as well. And I have the pleasure of doing the OPL along with Ashraf Armian and winning it also. And Ashraf, over to you.
Thank you so much, Mohan, and thanks for the invitation. It's really an honor to be among you all. I will summarize because the topic that you mentioned to me is the IFS, the intraoperative floppy iris syndrome, and also the small pupil. So I will divide the presentation into two parts. So the first part is I have no financial disclosure, but these are my disclosure to companies that I have consulted. So as I'm happy that Kevin also and everyone talk about the IFS, in my opinion, we can divide the IFS into the epidemiology and the biomechanics and the management of the IFS, and depends on where it comes from and how we are going to manage before and after. Also, if you found that the iris is a poorly dilated pupil and there is an progressive intraoperative meiosis and marked iris below prolapse, this is an IFS and you should highlight if you don't have a history. Very important also the repulsion mode, because the repulsion can close the pupil easily and make it the pupil, the size is very small, and once you touch the iris, in these cases, this is the danger part of the procedure. There are two ways during the phacofluidics. It's longitudinal and torsional. Some of them are superior, but some of them have drawbacks in cases of IFS. The drawbacks of the longitudinal, that the lower fragment removal efficiency and the fragment risk getting trapped in the irrigation. The torsional, the drawbacks of the torsional in these cases, considerably high risk of inducing adhesion mode and high root staining, and this can make the iris comes easily. Very important to adjust the fluidics, because as much as the fluidics is very well controlled, the risk of catching the iris or even have an iris prolapse is less, not no, but it is less than according to how you are going to control the fluidics. Tamsuline alpha blockers, it is one of the most important. And the second is the imipramine, and the last is the chlorpromazine. But 4.28%, not percent, the triple greater odds in cases of IVIS or taking tamsuline, and the IVIS is very high. And it can happen in male and female, and this is very important because some female are on alpha-1 antagonist, and you should report it in the history. For the sake of the time, very important, equalize the pressure, reduce the anterior displacement, gentle milking of the iris is important, and strictly avoid aggressive stretching. The OVD is very important, especially if you can do a soft gel. And if you found that the iris comes a lot, proper suturing and leave it for 1 week does not make any problem. The main also core principle, the Thamsulin, as we said, the fluid and the misuse of the fluidics and the trauma of the iris can initiate the floppy iris syndrome. Let's go, and these cases like this, oops, it's a floppy, but I touched the iris, and this is the issue. This is the beginning of the problem. Oops, again, this is the beginning of the problem, but you touch the iris, this initiates a lot of complications. I'm trying to restart the fluidics again, changing, but I'm trying to bring the piece inside in the center of the eye, but as you can see from the side port, even the iris start to get out. As someone said, that if you are going out, this happened, don't go out until you finish. This is what I'm trying to do. I'm stabilizing the phaco probe in the middle and bringing to change the fluidics, the pieces to the tip of my phaco probe. Very important when you go out, don't go directly, because if you go out directly, don't go, see, this is what happened, slowly, because this will make the fluid okay, and you can see the iris is back because everything is calming down, so the iris coming back. But in spite of this, I put visco dispersive over the iris in the areas that started to be out as a mechanical tamponade. Another case, the same, everything is okay, going okay, and during the hydrodissection, during the procedure, you can see now the iris start to be angry again. Okay, so this is what happened during how I am inside the eye trying to divide and conquer. The iris started to be out here from the side port, injecting visco. This is what I said that is wrong. You should come from the side, as Sahil said, and sweep the iris. This is the most important, because if you go through the wound, you are making too much trauma to the iris. And injecting healing to high visco to press the iris. And once you go in, don't go out again till you finish. This is the most important. If you went safely inside, don't go out unless you finish. And this is what I did, but the iris started to come again, even during the IA. So at this stage, I wanted to leave it like this as a plug for the eye. And once I finish, the iris still out. I'm trying to sweep the iris again, and the iris is back and everything is okay. This is one of the cases. I don't have, I want to the second part of my talk, which is the small pupil management. This is one of the most important. If you are an expert, you can do it without assistance, or if you want to try. So these cases, pupil is very nice. Pupil is okay at that side, but you are going to see that the pupil are going to start closing at certain points. And I decided not to use anything. So the most important trick, small groove in the middle and divide in two pieces, stop and shop. And as much as you divide in the center of the pupil and bring the pieces in the middle of the pupil, you can manage the case without dilatation of the pupil. But this is very important, that don't go behind the iris edge. If you go behind the iris edge, the problem will start. Injecting more visco to push the iris back and rotate the other piece, and always catch it and bring it in the middle and finish it. This is one of the cases. And also another case, if the pupil is small like this, you can finish it and everything is fine and everything is okay. But some cases are not like this. So we should think about the small pupil coming from either anatomical, from the CNI, from the previous uveitis, angle closure, glaucoma management also trigger the small pupil or pseudoexfoliation. Also, very important preoperative, it is a very small pupil, go for cyclopentolate, tropicamide, and phenylephrine. And then 3 weeks prior to the surgery, you should stop mycotics. And this is what I think about that the small pupil apply mydriatic visco. Visco is very important to let the pupil proceed. And let's go for surgeries because I know that everyone liked surgeries. So in my opinion, one of the things that you can do, manual stretching, is very crucial and very easy. But if you have something like this, small pupil, you should remove the synechia before you start. Iris hooks is a good option. I usually use it. In some cases, if I found that the sphincter of the pupil is not so good, so I'm using the iris hooks to stretch the pupil. But don't stretch too much in the first two. Put the 4 and then slowly stretching till you reach the size, appropriate size. Expanders are very important. And I'm using from the Malugan ring. You can see in these cases, you put the Malugan, you put the leading hook first, and then with the second. Usually I direct the Malugan, especially in these very myotic pupils. Very important, yes, to direct it, and then you put the third. You can finish your cataract very easily and remove it easily, as Kevin showed. Also, the eye ring, one of the best. If you have a deep anterior chamber, if you have a shallow, don't use it. If you have a shallow anterior chamber, don't use it because it's a little bit bulky, but it is a very soothing. It is like a very easy. It does not cause any trauma to the sphincters. I used since more than 7 or 8 years. It was before PVI. And you can put it easily because it has grooves. Also, the B-hex, one of the B-hex, one of the very nice recently I'm using, and I'm enjoying really the B-hex, but I usually dilate first. And the B-hex, one trick I'm going to highlight it, that you put it firstly over the iris, and then with the micro forceps, you direct the 3 very slowly, not to make trauma, very slowly under the iris. This is the big part, and the other side. And sometimes when you reach this side, you cannot, so I change my position. This is the trick. Very important. Stretching maneuvers are better before putting any of them. And if there is iris abuse, don't go, or chronic uveitis. To summarize, multiple technological advances over a span of many years have made it possible for modern cataract surgery. Following a small pupil management algorithm can guide the surgeon to methodically achieve adequate pupil size and wide range of pharmacological agents. Lastly, this is our book just released this month. It's one of the biggest cataract surgery. It is nearly 1,000 pages, 120 chapters, 950, 600 images and videos, 145 authors from 5 continents. Most of the people of the cataract surgery are in this book. I'm happy that a lot of Indians also are in this book. Thank you so much.
Amazing. Ashraf, thanks a lot. It was really amazing. This webinar is actually truly international. We got top people from the US, Canada, and Egypt, and sharing their expertise and knowledge. And Ashraf, before I go on to the panelists, I want to ask you, suppose you have a patient, the patient is on tamsulosin, okay?
Yes.
What will be your cutoff level? In the beginning of the surgery, what will be a cutoff level as far as the pupil is concerned? That I'll put a pupil expander, whether it's an iris hook or a Mulligan or a BX or eye ring or whatever it is. In the beginning, what will be your cutoff level?
In my opinion, according to the color of the pupil, as Kevin said. Dark pupil with a small pupil of IFIS, you can easily manage even if the patient is in Tamsuline. So I have a 91 years patient since 2 weeks. the same cataract grade 4, and he's a small pupil. He's just 3, does not go. He's in Tamsuline for 20 years. So usually in our system, we put a red in the file. This is a red. This is a risky patient. So before the surgery, he goes for non-steroidal for 1 week before. And then during the surgery, I changed the fluidics of the patients, the settings of the machine. I don't want anything to be in hurry. I used visco cohesive and visco dispersive soft shell technique, and then dilate the pupil slowly, because in these cases, if you make a manual dilatation aggressively, you are going to lose the rest of the tone of the iris. So just to reach 4 millimeter, which is the appropriate size to put the Malugan ring, I put a Malugan ring for the patients and finish. And even during the removal of the Malugan of these patients, take care. The iris has no tissue. You can make an iris root this insertion very easily, especially at 6 o'clock. This is the first one. So dislodges very slowly from the iris. Make sure, because usually the iris catches the Malugan ring. This is in these cases because there is no muscle and it cannot go easily in and out. Then remove it, and this is my technique. Usually this is what I go, and I continue non-steroidal for these patients for a week, for 1 month after the surgery.
That's fine. George, any take on this? What will be your cutoff level? Because my cutoff level is around 5.56 millimeter. In the beginning, if the patient is on tamsulosin, I know this 6 millimeter is going to become 3 or 4 and make my life difficult intraoperatively. So right in the beginning, I put iris hooks for these patients, or BX ring, or whatever it is. So what do you do?
Well, for me, it depends on how dense the cataract is and how much I suspect pseudo-X to be a factor. Because in our population, I would say about 20% of the people that I have at surgery have pseudo-exfoliation syndrome. So if there's a very small pupil, and to me, small pupil is 4 millimeters, 3 millimeters, I then move the eye and see if there's any phacodenesis. If there's phacodenesis, and I'm worried that there's other issues, so I'm more likely to use my pupil expanders in those. The other thing is my mix that I put in is lidocaine and phenylephrine. So we'll put some of that in because that'll stiffen up the iris. It may not dilate it, but it'll stiffen it up and prevent that iris from flopping out. When I'm doing the phaco, I'll bisect the nucleus, and I'll take the segments out one at a time. I don't rotate. I don't move the things around because I'm worried about the capsule. So as I say, my biggest concern is not so much the tamucilin, but it's more pseudoexfoliation, because that's what we see and that's what we want to deal with.
Okay. Kevin?
Can I add something small? Also, I go for the depths of the anterior chamber. As the depth of the anterior chamber is less than 2.3, 2.2, the incidence of iris prolapse and exaggerating the problem of the iris go high. As it is deep more than 2.5 and above, the risk is less because you have a space to control the fluidics inside the eye. This is very important.
Kevin, quick comment.
My what I do is kind of varied over time. Ashraf, great presentation. I grew up in pilot carpine era where there were no hooks, no rings, no anything, So we ended up doing phaco through 2 millimeter pupils like routinely. Every week I had a 2 millimeter pupil case, and I learned how to move the pupil out of the way to do the capsulorhexis.
Suppose the cataract is a little hard, Kevin.
It was hard. No, I'm just saying back then that's what I had to do because so I'd bring the pieces into the pupil phaco and I'd go out there and grab the pieces and it worked. And then when IFUS came along, I went like to the other side. Every pupil got a ring or a hook or something. And now I've kind of gravitated back towards I'm way less interventional with hooks and rings now. I do most of my IFUS cases just with pharmacologic agents and viscomydriasis. I don't often put in rings, and I almost never use pupil hooks. If I'm going to use them, I'm using a ring, and I don't do a lot of rings anymore. I just kind of pendulum back towards being much more physiologic, if you will, and not mechanical But I don't hesitate to go to the mechanical if I have to. And I don't have a cutoff, but it would, if I did, it would probably be about 3.5 millimeters for a ring to go in the eye.
Yeah. Suga,
Yeah, it's
Sugas, what do you do?
yeah, it's very interesting to listen to Kevin because we are so much trained enough to be able to do things without, and we just at the drop of the hat also we try and use it because they're so easily available and we have been trained so well. So for me, I just if it's a small pupil, yeah, first I make sure it's rigid or elastic. If it's rigid, then after a bit of stretching, I would definitely go for a Malyogin's ring. But if it's an elastic pupil, I would straight away go ahead with BX. But before that, I would give a try with the dispersive viscoelastic to do viscometriasis, and then try and be in the center under low parameters and try and do phaco. But my go-to will be a BX ring.
Sujata?
My favorite is
Sujata?
always iris hooks, and my tolerance level will be up to 5 millimeters. And depending on the hardness of the cataract, grade 2 to 3 I can manage, but beyond that I would like to use iris hooks. Of course, I also use a BX ring, but for me, I'm so comfortable with the iris hooks that I prefer most of the times.
Kiran, you have anything to add? Kiranjit and Shail?
Yeah,
Quick.
yeah. The main point is the cause of iris incarceration in the wound is because we have a very large sized side stab. If you have a size tab of 0.8 millimeters, you will never have a iris prolapse. And Dr. Rohit Omprakash has published a paper in which he has shown a smaller incision will never invite iris into it. And number two, I don't go for iris. I do put iris hooks, but in a rectangular fashion, not in a circular fashion. And I never have had a iris prolapse from anywhere.
Okay, I think we are running out of time, and over to Kiranjit Singh, again a guy who is really does not require any introduction. His father was the father of the iris claw lens in the entire world, I would say. And Kiranjit Singh and Ravijit have taken the Daljit Singh Eye Hospital to a totally different level altogether. And iris claw may be a good savior. It's a very quick in and out, fantastic results. Over to Kiran
Sir, I
for
have
your talk.
pressed the wrong window. I have instead of pressing share the screen, I have pressed the share the window. So how do I do that? Undo that.
Karan?
Sir, stop sharing again.
Settings.
Stop sharing.
And then you again share it.
Share it
Where
again.
is that? Okay. Should I close the window?
First click on share, sir. Then a window will pop out. A
Yeah,
window will pop out, and
that's
then
right.
yeah.
Yeah, it's come.
Stop share.
I saw him. The slides came now.
Yeah. So I have
Oh, I
pressed
have
on.
opened your presentation and kept.
No, I have not opened it.
No, open your presentation and keep it on the desktop, and then
Okay.
share, and then click on the presentation.
I think I will have to go back again. Can you do it again?
Yes, sir. You click on share again, and then as sir said, click on desktop. Then the entire thing will come. You just did it.
I'm pressing. Yeah, okay. Share entire screen. Okay.
Yes, sir. We can see that. Now let it be. Now go click on your presentation, which is on the right lower corner of your screen.
Quick on the presentation will come.
Yeah. So
Yes,
should
sir.
I start it?
Yes, sir.
Yes, sir.
So nothing against the glued lens, but I am not trained to handle the glued lens. So I am taking out the glued lens out of the eye, and I am going to implant a iris claw lens behind the iris. and the dimensions are 7.2 millimeters into 4.5 millimeters. You take it underneath the iris and enclave the iris by pushing it down into the claw. And similarly, on the other hand, you swap your hands and swap the instruments, and you do it, and not more than 2 minutes are needed to finish the case. So today I'm going to talk about four claws. So this is a case of endophthalmitis in which an iris claw was implanted behind the iris, but it got dislocated because it was very hard posterior surface. So in that case, I used a four claw lens to fix it into the interior surface of the eye. So when you fix the lens to 4 points, it becomes very stable and no pseudophecodinosis, no damage to the endothelium. And the benefit we get, you can do a pupilloplasty as well. So this patient in the post-operative period had a vision of 6 by 6 uncorrected. And this is how I do a case of pseudo exfoliation. I make a use the iris hooks and make a rectangular out of it. And then I don't make a round rexes. I make a oval rexes. And this case, ideally, I should have done a SICS. But because I have iris claw lens in my armamentarium, I go ahead with the phacoemulsification till I catch hold of the interior capsule because it is very loose and it gets sucked into the phacoprobe. So I emulsify one or two segments, but one of the segment was about to fall down in the vitreous. So I quit phacoemulsification and extended the incision to some extent. And the segments are already broken, so I take them out with the help of a wire vectis. And in such cases, there is no point preserving the capsular bag. So this is the lens. The pupil is distorted, enlarged. I can pull the peripheral iris into the four claws, and the job is done. So this is a case of coloboma in which there was gross dislocation. I will not even think of phacoemulsification. I took it out intracapsularly. In this case, I'm going to put that four claw lens behind the iris at four places and able to do pupilloplasty as well. Patient had 6/6 vision in the post-operative period. This is a patient of bomb blast injury in which repair was done elsewhere. What I did was I used a retractor to break the synechiae vitreous iris tissue, and my aim is to create a nice recipient bed for the PKP to follow. It was done after 2 months, and after 1 year, this is how the eye looks.
Beautiful.
And this is a patient of 19-year-old boy who had fungal ulcer, and the IOP was around 40. So I did the synecholysis and put the lens, and glaucoma was at 40. It never came back. So if I don't do this type of lens, the IOP is going to rise again. The patient had 6/9 vision uncorrected. This is a patient of ectopia lentis operated elsewhere, and this was my first case of four claw lens, and I had operated upon his mother, sister, so many people all had done beautiful, got done via surgery somewhere else. So I did the first case, and on the first post-op day, uncorrected, he was able to see 6 by 6, and the pupil dilates as well. So this is a case of trauma in which there is fibrosis of the capsular bag. So I did the phaco first, then I put the lens and created a slip in the fibrous band. So that slip, I slipped into one of the claws, and in the rest three claws, I put the iris. Did some vitrectomy to clear the some hemorrhage and fibrous bands. Patient had could read 4 lines. So this is a patient in which the primary surgeon operated 3 times because megalocornea is there. So, but the lens was moving, wandering lens caused pigmentary glaucoma, caused iris transcolumination defects. IOP was 30, and you can see just now, you will see witness the pigment epithelium at 6 o'clock. So this was the cause of glaucoma. After the lens implantation, the IOP started going down, and presently it is below 19 without medicines. So you have to treat the cause to treat the problem. So this is a case of pseudophakic bullous retinopathy, single-eyed patient from a family of RP, and the foldable lens was lying in the pupillary area. We took it out, put a 4-claw lens, and there was peaking of the pupil. So I did some vitrectomy, and it made I could made it around. And after that, we do the smetorexis, take out the take out the this is the healthy endothelial lenticule, and the tamponade sits very nicely behind this. And this is after 1 year. Patient just had 660 vision because of the RP thing. And this is a case in which the patient did not have any vision, but the angle supported lens was damaging the eye too much. IOP was very high. The main aim of my surgery was to do interior segment reconstruction, not vision. And presently, the IOP is controlled with medicines. And you can see the 4-claw lens is just 1/3 the size of this angle supported lens. So I enclave the peripheral iris into the claws at 3 places, and the eye looks quite normal these days. After I think 2 years, the eye looks normal, but there is no visual prognosis, no visual improvement. So this is a patient, high hypermetropic patient, in the primary surgeon. Instead of putting a IOL of 55 diopters, he put a IOL of 40 diopters. So he came to me with a residual power of refraction of +8. So I put a lens of 14 diopters, and presently the patient is emetropic, and PI needs to be run. And there is an opening in the center of the IOL for the aqueous movement. This is again a patient of high hypermetropia, in which the anterior chamber depth in the center is 2.68 millimeters. And this is concavo convex lens. There is opening in the center for movement of the aqueous. And you can see this is after 6 months. No, you can see opening of the angle, and the pupil can dilate as well. This is an opaque lens with a 3-piece. I want to exchange it. So plan is this. So I'm using needle, this scissors. So I get a iris prolapse. I'm sitting at 12 o'clock, no problem, making a small PI. I do a hydrodissection behind the IOL, cut the haptics, take it out. I'm ready for implantation of a 3-piece IOL in the bag. And when I'm rotating it, I break all the zonules which were intact before this, and now I'm stuck. So I need to open the incision a little bit and take it out with a plain forceps, do some vitrectomy, and again go for this 4-claw lens. I have not witnessed any case of cystoid macular edema or anything like that. No inflammation, because once the iris is stuck into the claws, it becomes part of the IOL. So this is a patient of 1 year old, and VR surgeon has done
Can
this.
you just, can you just, because we have one more presentation.
Okay.
And we've got another
So
few minutes only. Yeah.
I think it is just finished. So this is a patient, ROP stage 4 pars plana vitrectomy lumpectomy has been done. And if we don't do aphakic rehabilitation, we are not going to give benefit to the patient. And the next movie I'll skip. And all these 5 patients with ROP age 1 to 2. So this is a patient in which I had to exchange the lens, and I have to put a prosthesis. This is a prosthesis made from colored PMM. It is not coated one. Coated one will release pigment and cause pigmentary glaucoma. So I do some interior vitrectomy, and there is a strip of iris which is moving at 12 o'clock. I suture it and make the forces stabilize. And the patient never have had a photophobia. So patient has 612 vision. So this is Dr. Abhay. So this is Dr. Abhay. Should I close it?
Yeah, I think so, because we have one more presentation by Shail. So
Okay, I saw.
that was a Kiran. That was
Yeah.
That was a master class on iris claw lens, purely magical, completely magical, and only you people can do this so very well. Over to Shail, can you quickly share your presentation, case presentation, for just about 4 minutes, and then
Yes,
we'll
sir.
close the session.
Sure, sir.
Thanks, Kiran.
Thank
I
you,
think we
sir.
should have a big round of applause for
Thank you, sir.
Kiranjit Singh. What
Thank you.
lovely videos,
Thank you, sir.
complicated cases.
So I'll be sharing a case of right eye cataract surgery, grade 2 with the posterior subcapsular cataract. Nothing which I expect things to go wrong. And you can notice here while injecting the trypan, the focus is a little bit lost and it's kept injecting, and this is at this point of time still the surgeon is oblivious to the fact that the anterior capsular axis has sort of split. So while injecting, either while making the side port incision or while injecting trypan, the anterior capsule has been ruptured, and injecting the viscoelastic has made sure that it's got completed almost up to the equator. So that we have not even started the surgery yet, and the patient was planned for a toric IOL. So the first thing that I want to do is try and salvage whatever the capsular axis is there from the remaining part. So I want to create a fashion a capsular axis on this side. So I'm making a side port incision which is ergonomically easy for me to make the cut with the forceps, with the scissors. And then with the micro incision rexus forceps, making sure that at least 3/4 of the capsulotomy on this side at least gets completed. So it's important that you may have to approach the area from an ergonomic location. Here I had to make a side port on the opposite side, so be open to doing that. And here I realized that it's extending up to the equator, so there's no point in trying to pull it in. I'll cause more zonular damage. So I made a nick and make sure that at least except for this part which is extending up to the equator, the rest 3/4 of the capsular axis at least becomes intact. So that was a relative sort of first management to be done in such a tricky situation. The second is you need a reasonably good hydrodissection in such eyes, because you don't want to put too much of force on the zonules while rotating. So make sure that you see a reasonably good fluid wave, and if required, inject in multiple areas. So as you can see, I did see a good wave, and I'm doing a little bit of gentle multi-quadrant hydrodissection so that whatever corticocapsular adhesions are there also get freed up. Now it's the time to make sure that this doesn't wrap around the posterior capsule, so which means I need to be slow and low with my parameters. So I'm using an IOP of only 20 and a flow rate of 20 cc per minute, and I'm trying to make sure that all the movements of chopping or lateral separation that I do, I try to avoid too much stress in this open area, and I'll probably try and do the chopping in this area, which fortunately here is the rexus is quite intact in the area of the chopping. And go ahead again during fragment removal also, I do not wish the chamber to keep too much of fluid or turbulence occurring, so I've kept a relatively low intraocular pressure once again of 20 millimeters of mercury and a low flow rate, and making sure that I remain right in the center with my phaco probe, so that you don't inadvertently catch anything else, and the fluidics remained controlled. Fortunately, it was not a very dense cataract, only about grade 2 to grade 3, so not too much of lateral maneuvers were required. And at every point, make sure that the chamber doesn't collapse. So inject dispersive viscoelastic so that there is no forward bulge, and at this point also, if you don't take care, it can wrap around the posterior capsule. Making sure that I do bimanual IA in such situations and swipe a lot before actually pulling it. So less radial force but more swiping movements to make sure that the cortex is free from the fornices, and making sure the entire cortex is removed. So the first objective has been achieved, that is preventing this capsular rexus from running behind. And now the trouble is that this patient requires a toric IOL to be placed in this exact same axis. So the first question is, should we actually implant a toric IOL when the anterior capsule is open, and particularly in the area where the placement axis is likely to be? So having had a few past experiences with that, we decided to go ahead and implant the toric IOL in the capsular bag and making sure that the axis is aligned. I'm seeing the axis through the digital marking on the Varion. And even during viscoelastic removal, try and make sure that you direct the aspiration port away from this open area. Hydrate all the wounds before bringing the irrigation out so that the chamber doesn't shallow. And in the end, always make sure that through the whatever weak area there was no triamcinolone. There was no vitreous prolapse. This patient did very well. The toric IOL remained centered right through now the follow-up of more than 3 years. You can see some PCO developing. So far hasn't required. It can be considered in selective cases of anterior capsular dehiscence, and stability is not an issue in the long run.
Wonderful, wonderful, Shail. I think it was really the icing on the cake at the end of this really fantastic session. And since you're running out of time, I request Dr. Karan Bhatia to give the vote of thanks.
So big thank you to our international guests and for an amazing session that we had. And Dr. Kevin, Dr. Beko, Dr. Shell, Dr. Haldipurkar, Dr. Sujata, Dr. Ashraf Armania, and Dr. Kiranjeet Singh sir. And a great thank you to Mohan Rajan sir for this wonderful conference and for AIOS for this wonderful opportunity. I would also a big thanks to my coordinators, Dr. Krina and Dr. Rolika for this wonderful opportunity and a great session together. Looking forward to a great academic session tomorrow. And I would suggest our viewers to again take a look at the program tomorrow. Lots of exciting learning points like
Big
today.
thanks to our President
Thank you,
Titiyal,
sir.
Secretary Santosh, and the Chairperson Scientific Committee Namrata Sharma, and the entire AOS team. Thank you.
Thank you so much. Thank you.
Thank you,
Thank you
everyone.
all for inviting us.
Thank
Great
you.
Thank you,
session.
sir.
Kevin, I'll see you in Pattaya.
I'll see you in Pattaya.
Yes, sir. George.
Thank
Have
you.
a
Bye.
great rest of the day.
Bye.
Bye-bye.
Good night and good day.
Thanks a lot, everybody. Krina.
Thank you, sir.
Thank you. Karan.
Thank
Bye.
you, sir.
Thank you,
Good night,
sir. Thank you, ma'am.
Good night, sir.
Good night.
Good night.